进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种。若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症；因肿瘤或颅内出血使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病，建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的寂寞腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防哦，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制3高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些，比如说记忆力减退，这种记忆力减退通常指的是，最近的事情记不清楚，可是远的事情他可能反而记得很清楚，或者是大小便没有办法控制，或者是走路步态不稳，有这3种状况的时候，那必须立即找神经外科或神经内科的专科医师，赶快加以诊疗，赶快去处理，看看到底是不是有水脑症的状况。那如果不幸真的是有水脑症的状况，那必须要赶快处理，来减少将来后续的一些问题，比如说失智啊，或者造成一些残障或失能的状况。
进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种。若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症；因肿瘤或颅内出血使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病，建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的棘膜腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防啊，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制3高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些，比如说记忆力减退，这种记忆力减退通常指的是最近的事情记不清楚，可是远的事情他可能反而记得很清楚，或者是大小便没有办法控制，或者是走路步态不稳，有这3种状况的时候，那必须立即找神经外科或神经内科的专科医师，赶快加以诊疗，赶快去处理，看看到底是不是有水脑症的状况。那如果不幸真的是有水脑症的状况，那必须要赶快处理，来减少将来后续的一些问题，比如说失智啊，或者造成一些残障或失能的状况。
在进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种。若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症；因肿瘤或颅内出血使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病，建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的棘膜腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防哦，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制3高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些，比如说记忆力减退，这种记忆力减退通常指的是最近的事情记不清楚，可是远的事情他可能反而记得很清楚，或者是大小便没有办法控制，或者是走路步态不稳，有这3种状况的时候，那必须立即找神经外科或神经内科的专科医师，赶快加以诊疗，赶快去处理，看看到底是不是有水脑症的状况。那如果不幸真的是有水脑症的状况，那必须要赶快处理，来减少将来后续的一些问题，比如说失智啊，或者造成一些残障或失能的状况。
Good morning, everyone. Welcome to International ICH meeting. Let's welcome Professor Gao Mingjian to give us an opening remark.
Dear colleagues, Professor Ma and President Rai of Taiwan Neurosurgical Societies, also Professor Zheng of the Taiwan Societies for Middle Use Neurosurgery, and Professor Shen, in particular Professor Hongbo Hao. First of all, I would like to congratulate Professor Hongbo Hao and President Zheng to organize this very important international ICH meeting. As you know, the COVID-19 pandemic is still very severe around the world. We are only able to hold a meeting, an international meeting, in dual types. A physical meeting for our local participants, and online meeting for the international speaker and the participants. The meeting particularly invites very distinguished neurologists and neurosurgeons, particularly, for example, Professor Hanley from the Johns Hopkins, and Professor Kellner from the United States, and also Professor Chen Xiaolei from Beijing, mainland China. I think this is a very important platform to let us can able to exchange on our clinical experience and advanced knowledge about the management of ICH. I hope that the meeting will be very successful and all the participants be happy and healthy. Thank you.
Thank you, Professor Gao. Let's welcome Professor Ma Xingyi to give us opening remarks.
Good morning, everybody. Because most of our participants speak in Mandarin, so I speak in Mandarin for the opening remark. 首先我在这边要感谢那个中青年神经外科医学会啊，还有神经外科医学会办了这么精彩的一个 international 那个 ICH 的这个 meeting 啊。那其中特别要感谢就是跑前跑后啊，任劳任怨的黄博浩我们黄教授啊。 他整个安排了一个非常非常好的一个 program。刚刚高教授也提过啊，这几位大师啊都是非常非常难请到的，而且讲的题目啊都是现在大家都是最关心的啊，所以我就不耽误大家时间。那这边还是要感谢一下我们在座的哈，因为都是理事长啊，我们中青年的郑文玉郑理事长啊，最美丽的理事长，还有薛董事长啊，还有这个还有沈主任啊，沈主任现在是脑下垂体 的理事长，还有我们的大家长哈赖达明赖理事长，还有高教授哈，那谢谢大家一起啊群策群力把这个活动办起来，那我就谢谢大家，谢谢。
Thank you, Professor Ma. Let's welcome Professor Lai Daming to give us opening remarks.
好，我也是用中文啊，郑理事长。 然后，陈主任，然后感谢你们办这个盛大的会议。其实这个 ICH 的 guideline 是，马理事长那时候已经做了大概2/3了，只是还没有 finalize。那黄博浩督促我说，我们跟神经科医学会，然后要有一个共识 ，ICH guideline 到底要怎么？我希望在这一届完成。 所以他组了一个 team， 然后我们在这个写guideline以前，我们还需要一些 up to date 的知识。那感谢他 organize 这个会议。那之后我们再看看，在1年内可不可以就把guideline设出来，做出来。感谢大家的参与。那这边可能都是以后guideline的那个指导者。那希望这次这个会是一定会很成功啊！希望大家也 很快的会有共识，感谢大家，感谢郑主任。
Thank you, Professor Lai. Let's welcome Taiwan Society for Middle-Use Neurosurgery, the President, Zheng Wenyu, to give us opening remarks.
Thank you. Good morning, ladies and gentlemen. It's our pleasure to invite all of you to join this meeting. First, I will thank Professor Huang to organize this meeting. With the advancement of surgical technique, the treatment of ICH is different from before. Minimally invasive surgery, such as navigation guide, keyhole surgery, robotic surgery, or endoscope surgery, can reduce patient trauma and restore neurological function quickly after surgery. In today's meeting, all the variables opinions are welcome, and I hope to spark more sparks in the discussion. I also like to discuss the new version of the ICH guideline for Taiwan in the future. Finally, I wish the conference a complete success. Thank you.
Thank you, President Zheng. Let's welcome our first moderator for this session, Dr. Huang, to start our today.
Dear colleagues, thank you very much for your attendance. Today, our first speaker is the world-renowned Dan Henley. He's a renowned professor in neurology, and he published many research in JAMA, Lancet, and many famous literature, especially in the ICH field. He conducted one of the MISTI trial, the MISTI 3, which was published a few years ago, and now he's planning for the MISTI 4. So today, we are very honored to have him here as our first speaker to give us an introduction and what he thinks about the future treatment of ICH. Thank you, Dan.
Thank you for the opportunity to speak at this very important international conference. And I share the opinion of all the leaders that this is a very important area. I'm honored to give this talk. I'd like to talk about what we need to know to establish minimally invasive surgery for ICH as standard of care. These are my disclosures. These are some educational goals that I hope are covered in this talk. I'd like to start with predicting outcome. This is a receiver operator curve, which I'm outlining here. And it predicts whether or not people will survive their ICH with a Rankin scale of 0 to 3, or have a good outcome. And that's what this dark blue line is. The factors that predict it are listed on the right and have been demonstrated both in our own work and in the work of others to be very uniform in predicting outcome. They predict about 80% of the outcome. That's the area under this curve, this receiver operator curve. And they are age, the Glasgow Coma Scale at presentation, location, the size of the ICH, the size of the IVH, the diabetic status, yes, no, and the amount of white matter injury that pre-exists the ICH in any number of scores. In this case, we use the Vasicus score. So 4 out of 5 times we can predict whether a good or bad outcome is going to happen. But there are unknown factors, and among those unknown factors is whether or not surgery definitively helps. As you're all aware, our last big trial was neutral, and it was only the per protocol analysis that demonstrated benefit. MISTI had 255 patients treated with minimally invasive surgery and 251 with medical management only. We did not have crossovers, and it's an excellent trial because we didn't really lose very many patients to follow-up, only 2%. It's given us a lot of lessons. The first one is it's demonstrated the generalizability of our ability to predict outcome. And I just showed you the receiver operator curve there. The questions that need to be answered, however, is minimally invasive clot removal valuable in producing a better functional state as measured by the Rankin score or some other score? How the clot should be removed, when, what technical aspects are important. In order to discuss these issues, I'm going to use our own MISTY-3 data taken from monitored data from 70 sites across the world, some meta-analysis of trials, and meta-analysis of individual subjects that we've done subsequent. This is the MISTY catheter-based procedure of placing a catheter on the long axis of a hematoma, aspirating clot, and then cleaning up the remainder of the clot by injecting low-dose TPA. And you can see the removal that one can get over about a 3-day period of time. In this case, 52 hours or 2.5 days. This is the clinical protocol showing daily 3 times injections of TPA up to 9 doses. In the MISTY trial, the average patient received between 4 and 5 doses. And we excluded any vascular defect with a CT angiogram. This is the protocol results of MISTY. The primary outcome was the MRS distribution as measured at the MRS 0 to 3 boundary. Medical patients are in the lower bar, and the surgically treated patients whose surgeons followed the protocol and continued to give the TPA until the size of the hematoma was reduced to under 15 milliliters in size. Per protocol analysis, which covered 60% patients in the trial, there can and benefit minimally invasive surgery, and there was a substantial benefit in mortality, as you can see. That benefit was approximately 3%. It was safe. In point of fact, if you look at death, 0 to 30 infections, symptomatic bleeding, SAEs, events, in the severe adverse event category, and in early death and death at 30 days, it was safer to be in the MISTY arm than to do nothing and be in the medical arm. This is unusual for a surgical trial. In point of fact, if ICH was treated as a malignant disease, as cancer, we would already have evidence-based benefit for surgical treatment. In both the MISTY trial, we found evidence to benefit in terms of mortality, and in the CLEAR trial, as you can see from the Kaplan-Meier curves, both of which were statistically significant. Now, what we don't know about ICH that we need to know in order to demonstrate definitively in a trial that minimally invasive surgery is a beneficial approach. I think there are 3 main questions. is it helpful or not? And we're proposing to answer that we combine groups receiving catheter and endoscopic removal via a standardized minimally invasive approach. We do need to compare approaches and see if the procedures are the same or not. I'll show you some data from our own trials suggesting that they are similar. And we need to define who can benefit from surgery, particularly in the area of timing, location of the clot, the size of the clot, and the age of the patients. So the first question, is minimally invasive surgery helpful? Well, to date, there is no phase 3 clinical trial proof that is definitive. The intention to treat analysis of MISTY was demonstrated a point benefit of about 4%, but it didn't reach statistical significance. Only in those patients where the surgical protocol was performed fully did we reach statistical significance. So the best meta-analysis of small trials combining the trials together does suggest, as this red box shows you, that almost all the trials lie to the left of the line of identity, which is the red line on the right-hand side of the box. And the point estimates are of benefit in most of the trials. And it doesn't matter what the comparator is, whether it's medical treatment or conventional craniotomy, whether it's endoscopic surgery or stereotactic thrombolysis. Both techniques seem to demonstrate that there is functional benefit in terms of the outcome when you get to a large enough number of patients in well-conducted trials. Are all minimally invasive surgery procedures the same? This is our own data, which was performed in MISTY-3 and in the ICES cohort, which was the endoscopic cohort of MISTY-2. On the right-hand side are the clot removals that occurred. The blue boxes are medical and the red boxes are surgical. And you can see that surgery ended up removing about 70% of the clot, and the average reduction was down to about 15 milliliters. And in both trials, they produced about 34 to 38% good outcomes. So the good outcomes were about the same. Now, certainly, open surgery is different than, than endoport-mediated evacuation, such as in the ENRICH trial. And that perhaps is a bit more invasive in that it requires a keyhole craniotomy than endoscopic aspiration. And stereotactic aspiration with an introducer and a catheter certainly is a narrower object to place into the brain than an endoscope. So there is potential for more collateral tissue damage, the more mechanically open a procedure is, and there is potential for limiting mechanical injury with the smaller and narrower techniques. Who can benefit from surgery? There's an important set of unknown questions here that need to be answered with more data. Timing, the stable versus unstable patient, the location of the hematoma, deep versus superficial, and there may be subgroups of locations within both of those categories. And size, is there hematomas that are too big to operate on? Are there hematomas that are too small to operate on? So those are a number of questions that we need more data in order to fully answer them. And probably the best data to acquire is that monitored data in a randomized clinical trial where all of these factors that affect outcome are balanced because of randomization. I believe there's equipoise on the issue of timing. There is a recent paper by Sondag in the Annals of Neurology that is a meta-analysis of trials in which the average outcome of trials and the average time to surgery was compared. And within that paper, a statistical benefit for early versus late was found. This graph shows that statistical benefit, and it's this modestly sloping line here. In the same meta-analysis by Scaglianti, when he was a fellow with Dr. Kellner, there is no effect of time when trials are compared to one another. We looked at our own data in this area, and this is our own data, which has now been published. And on the left are the stage 1 and 2 patients, which we were given by David Mendelow, who was a MISTI investigator as well. And in that data, on the x-axis here is time in hours from 0 to 120. And on the y-axis is the probability of reaching MRS 0 to 3, and that probability ranges from 0 up to 100%. And you can see in the first 60 hours, the probability increases over time and then plateaus between about 35 hours, 40 hours, way out to 80 or 100 hours. Well, there aren't a lot of observations out there. In the MISTI data, we found the same phenomenon, a plateau between about 30 hours and 90 hours. So within our own data, we find no benefit for time. This is important if it's true, and if we can find it again, particularly when we explore some of the earlier times to surgery with minimally invasive surgery. What would be good about this finding, if true, is that we can offer surgery with a predictable approximately 40 to 50% good outcomes occurring at 24 hours and at 48 hours, and maybe as far out as 3 days. That would allow for the transport of patients from far places to skilled centers, which could be very important to patients. So the things that we don't know that could be answered in a trial are, is surgery helpful? And I think at best we can say currently it may be in the phase 3 trials and meta-analysis. And therefore we need a phase 3, a definitive phase 3 demonstration, which I would argue should be a very large trial in order to avoid some of the problems of the smaller trials. We need to answer the question, are all minimally invasive procedures the same? And we need more data, and a large trial will give that data to us on timing, the stable versus unstable patient, deep versus superficial, and the limits for size that that we need to observe in clinical practice. I think in Asia, where there is a tremendous amount of experience with the procedure, most Asian clinicians who I talk to feel that the 30 to 60 millimeter range is the ideal size to operate on, and that below it and above it, the benefits may be less. But we need to demonstrate that in a randomized trial. Modified intention to treat is an important principle in any clinical trial. In a drug trial, the FDA in the United States, the Food and Drug Administration, requires as a condition for modified intention to treat that the patient be exposed to the drug that's being tested, which makes a lot of sense. You shouldn't make an inference about whether or not a drug works without exposing the patient to that drug. In surgery, I think there is an equivalent, and I'd like to show you some of our data about this. And that's exposure to an effective procedure, not to a sham procedure. This is a plot, again, of how successful a surgery was in terms of volume reduction. And so the x-axis is the end of treatment volume in the stage 2 patients. That's an open craniotomy procedure. And in the MISTI 3 lobar patients. Stage 2 was lobar only. So it's a comparison across the same location. And in both data sets, you see that once the surgeon reaches a reduction to approximately 15 milliliters, perhaps a little bit before, maybe somewhere around 20, there is a sharp inflection point and an increase in good outcomes that goes from this 40 to 50% level up to about 70%. That would suggest that there is an impact of the extent of ICH removal on outcome, and that it's relevant in both minimally invasive surgery and in craniotomy. So to do surgery and only remove a part of the hematoma is or appears to be, in effect, a sham surgery. It exposes the patient to the procedure, but not to the benefit that comes from a major reduction in size. This is the actual data about surgery from the 245 patients who had surgery in MISTI 3. Each patient is a dot, and on the x-axis, patients are sequentially shown over time with the number of patients reached at any given point in time, shown here, 50, 100, 150, 200, 242, 245. The protocol asks that the surgeon keep the catheter in place or replace it and move it back into the clot, and to continue up to 9 doses of TPA to reduce the hematoma to 15 milliliters. That's 60% of the patients achieve that goal. Another approximately 8 or 9% were under 20 milliliters, and 90% were under 30 milliliters. This group out here did not make any major change in the size of the hematoma under surgical treatment. I would argue that this group did not receive effective treatment for sure. The orange set of bars may be marginally effective. We think the sweet spot is 15 milliliters in size. Why do we think that? Here are those comparisons. Those patients that were left with greater than 30 milliliters and those left with under 30, a big effect on mortality and a small, moderate effect on functional outcome. By comparing the under 20 to all those over 20, there is a substantial and statistically significant effect of about 10% on that 0 to 3 modified Rankin cut point. So the proportion in the good outcomes is about 10% better here in the under 20 than it is here in the over 20. And that proportion is even larger in the under 15 versus over 15. In all three, you see an effect on mortality. So it could be that 30 milliliters is a threshold for saving a life, and 20 or ideally 15 is a threshold for improving function. This is a slide that shows how the experience of the surgeon influenced protocol performance. The red dots are the first operation that the surgeons in MISTI performed on the randomized patients. And the red dots refer to the threshold of 70% removal. The blue dots are the same patients, but measured in absolute value of the end of treatment. And the blue dotted line is the 15 milliliter threshold. You can, whether you look at the red dot,
可以再看一下连线的问题。哦，好 ，OK。OK， 好像那个外宾网络断掉，所以我们可能要请他再重连一下，请大家再稍等一下。
Can you hear me now?
Yes. Yeah.
Okay.
Okay, great. Thank you.
I'm sorry, the connection was unstable. No. We believe there's a learning curve for minimally invasive surgery. In this paper, which was published along with the MISTI trial, we looked at those that achieved 15, 20, and 30, and we found the same things, that catheter placement had a protocol deviation, which meant it wasn't placed close enough to the clot. The surgeon didn't manipulate the catheter when he or she should have, or the number of doses of TPA was too small. We believe those surgical factors are remediable and are part of the learning curve. Is there a penalty to pay for achieving this lower post-surgical volume? Here are the medical SAEs on the left-hand side, the surgical SAEs in the less than 15 group, and the surgical SAEs in the greater than 15 group. And in point of fact, not only is there not a penalty, but the people who are left with a larger hematoma have a much higher event rate for surgical SAEs. So unlike many drug treatments, where if you give a large dose, the patient oftentimes has more side effects, we don't see that in the MISTI procedure. In contrast, this is an ICH paper, the ATAC trial, done in both Asia and North America, in which the more aggressive treatment was which was aggressive blood pressure lowering, giving more of a drug to lower blood pressure greater, did produce an increased number of neurologic deteriorations, and an increased number of renal events. So it can be that aggressive therapy is worse, but in the case of Misty, it doesn't appear to be so. So I would argue the performance of the surgical task in surgery is like dose and adherence in medicine, and it is a form of modified intention to treat. We have to expose our patients to the correct surgery in order to see a benefit. Can the lessons from Misty 3 be used to improve surgical outcome? This is a case series that was published by Issam Awad and his fellow Ali Mansour of 20 consecutive patients at the University of Chicago after Misty. And you can see that there's only one failed surgery and 2 patients that were in that 15 to 20 threshold area. So the majority, 84%, achieved the evacuation target of under 15 milliliters. So we believe these learnings can be applied. Interestingly, Dr. Awad is using the Cine CT to follow the catheter and make sure it's appropriately placed and make sure that the position is optimal. And this may be an important part of improving the technique. The famous Boston surgeon, Francis Moore, had a statement over the top of his operating room that you saw as you walked out. And it said, surgery begins after you leave the OR. Patient care is also an important part of what happens to the ICH patients. And I know most of the audience knows that already. But we've looked at the Misty data to show what happens after surgery, and that is important. We did it in a paper that is soon to be published that has the 500 patients from clear IVH-based catheter surgery and 500 from Misty. Of those, there are 339 survivors of clear that have a Rankin of 4 to 5 at day 30, and 376 that have that same Rankin 4 to 5 at day 30. So the care of those patients is important in producing good outcomes. The left-hand panel are the patients who are MRS4 at day 30 in this combined group from both trials. And you can see that by day 180, the majority are no longer MRS4. The majority are either MRS3 or 2. They moved either 1 or 2 levels higher. For the 5s, over half of them are at MRS4 or 3 by 365 days. So there is an improvement if you continue to render care. We've looked at what are the characteristics of that improvement. And interestingly, resolution of the ICH, the more complete the resolution, the better the outcome in terms of resolution by day 30. The same for ICH. Persistent hydrocephalus is a bad indicator. Ischemic stroke is a bad indicator. So prevention of ischemic stroke is a positive medical treatment. The need for gastrostomy, i.e. the inability to achieve oral nutrition, was also a negative indicator. So these factors can be considered in predicting who's going to have a good outcome. The blue line are the receiver operator curve for considering those factors. And you can see that the area under the curves, if you consider those factors of care rendered in the first 30 days, improve the likelihood of prediction to almost 85%, with only 13% unknown factors at that point in time. A final thing I'd like to call to your attention that's come from the MISTY trial, has to do with what the patients think about their own situation. We use the EuroQol visual analog scale. It's part of the EuroQol 5D test. It's a very simple to administer test in which you ask the patient how they feel about their life today. The average score on this in North America for a US population between 65 and 75 is a score of 74.9. And you see that as patients go through rehabilitation and come home, their score begins to approach that. And by 365 days, the patients at home and even the patients in rehab have a pretty good score. When we, on the right-hand panel, when we matched survivors for severity to people who had withdrawal of care, the survivors who matched the severity of those who chose to not continue care, those survivors approached this norm for Americans who have not even had a brain hemorrhage. So if you consider the patient's perspective, it appears that they do have a good quality of life with their survival. I think this is something we have underappreciated in the past, but comes directly from asking the patient how they feel about themselves at 180 and 365 days. This same, I'd like to look at the right-hand side of this slide. This same set of questions was asked in Houston, Texas, and is published in Cardiovascular Outcomes by Slaughter and Farhan Vahidi. They use something called the standard Gamble test. That's the blue lines here, where you ask the patient, is their life so bad that they would undergo a risky treatment that might only help them survive for a year, but would turn them to a good state? And all the blue lines, the answer is essentially no. So even the rank and 4 patients are saying they're happy with the way they are, which is a very interesting finding, and it's congruent with the EuroQol VAS finding that patients have returned to a normal state in their life. So thank you for listening. We hope there's a MISTY 4 that comes soon that compares endoscopic techniques to minimally invasive techniques and allows us to enroll patients both early and late. We think that as opposed to just prognosticating with our own data and everybody else's data, we think we need more data that will lead to a realistic estimation of the benefits and could be a proof of the benefits. Thank you very much.
Thank you, Dan. Are there any questions from the audience? Oh, I have a question about the definition of stability and unstable. For example, if we have a deep ICH, for example, putaminal ICH patient, like 30 milliliter, he is conscious and his muscle power, contralateral muscle power is deteriorating. Does that count as unstable, or because he's still conscious, it's a stable patient?
Yeah. In MISTY and CLEAR, we use as a definition of stability that the hematoma itself was not expanding.
Okay.
And the threshold was within 5 milliliters of the prior scan 6 hours earlier. So this patient could be deteriorating neurologically with a stable hematoma size.
I see.
Now, neurologically, he's clearly unstable. So one of the questions that needs to be answered is, do we need to take this step of demonstrating that the hematoma is not expanding. Clearly you do if you're going to inject a thrombolytic. You may not need to do this with an endoscope, and that could be an advantage of endoscopic surgery. But that advantage is yet to be proved, and it's one of the things that we could prove if we made the appropriate comparisons across a population that had surgeries going on at essentially the same time.
Yeah, thank you, Dan. Yeah. So another question is that, like in Taiwan, we have many hospitals, so the patient get to the hospital very early on. So most of our intervention are done very early on. You mentioned about the problem in United States that it probably needs to transfer to a center with expertise in doing MIS-D or surgical intervention. So
yes.
What are the efforts you have been done to facilitate this transfer or educate to allow the regional neurosurgeon or medical expertise to perform procedures such as MIS-D?
Right. So our Heart Association has been very important in educating about the potential benefits of surgery. And I think the transfer is much more rapid than it was 20 years ago. There's still work to do on that. And you have a different situation. There are perhaps more neurosurgeons in small and medium-sized hospitals. And there's greater experience with ICH in Asia than there is in the United States. So I think it's a good thing that a patient can come to a knowledgeable neurosurgeon in Asia and get a minimally invasive procedure very rapidly. And I hope we can continue to learn from your experience.
Oh, thank you, Dan. Yeah, so we also hope to participate in MIS-D4 if there's any chance in the future. Yeah, please do let us know if there's any opportunity.
I hope you will be able to.
Okay. Thank you very much for your presentation.
I wish all the members of the Congress well.
Okay, yeah.
Thank you, Dr. Huang. Let's welcome our next moderator, Dr. Zhou Zhongxin.
The next speaker is Professor Tang Songjun. He's a key person in Neurology Society about 脑中风学会. Today his talk is clinical feature prognosis in ICH patient with Notch3 mutation in Taiwan. Please.
Thank you for Professor Lai's introduction. And first of all, I just want to thank you for all of you to invite me to be here to present this interesting topic. I know that today's meeting is mainly for young generation neurosurgeon, so I just try to present the topic with some purpose of education regarding to a new concept. Probably in these several years, we just noticed that in Taiwan, a new etiology, genetic-related stroke, Notch3 mutation, is an important etiology for ICH patients. So all of you know that there are two types of strokes, ischemic and hemorrhagic strokes. And based on the epidemiology study, most of strokes, probably 80 to 85%, are ischemic stroke, and the others are hemorrhagic strokes. For patients with ischemic stroke, we would do a classification in clinical or research purpose. We call it as TOS classification. That means we will divide ischemic stroke patients into 5 etiologies: large artery atherosclerosis, small vessel occlusion, cardiac embolism, cryptogenic, and unusual etiologies. And that means based on the etiologies, we will know the risk factors and the cause for ischemic stroke. Besides, we will, based on the etiologies, to use specific preventive or therapeutic strategies for ischemic stroke patients. Similar to ischemic strokes, we also do some classifications for ICH patients. I'm not sure all of you are quite familiar with this classification. I just quickly go through the flow chart of SMATCH-U classification. That means once we confirm the diagnosis of ICH, we will try to look at if there is structural lesion, or if there is systemic disease, or ICH caused by some related medication, or we think the ICH is fulfill the criteria of amyloid angiopathy, or the patient could be related to hypertension, or finally, if we don't know the specific etiology for ICH based on the aforementioned definition, we will give an undetermined. The SMATCH-U classification has been introduced for many years. And in our hospital, NTUH, we also have our ICH cohort and try to use SMATCH-U classification in our registration. So the data was published in Stroke 2014, include around 4,000 ICH patients. And the most common cause was hypertensive angiopathy, accounts for around 50%, then followed by CAA amyloid angiopathy, around 10 to 12%. And you can see the figure in the right side. The classification not only for the etiology, but also imply the different survival and also the difference of recurrence rate. In our registration, the CAA amyloid angiopathy has the highest recurrent ICH rate. So that implies some clinical importance and also, of course, can give us some research purpose for the registration and classification. If we combine two classifications, TOST for ischemic stroke and SMATCH-U for ICH, you can see the small vessel in TOST classification accounts for probably 20 to 30% of ischemic stroke patients. And the SMATCH-U amyloid angiopathy and hypertensive angiopathy accounts for probably 60 or 70% of ICH. They are all cerebral small vessel diseases. So I just quickly overview the cerebral small vessel disease. It's an important etiology for both ischemic stroke and hemorrhagic strokes. Usually we will divide two etiologies, amyloid angiopathy or hypertensive angiopathy, based on the location and involvement of small vessel. For example, we will usually identify amyloid angiopathy for patients with superficial perforating arterioles involvement. That means the hemorrhage would locate in lobar or subcortical area. On the other side, the most common and typical involvement location for hypertensive angiopathy is deep. That means probably like middle cerebral artery, proximal part, the perforatory artery arriving from this branch, or also like basilar artery, the perforator, and related to the pontine hemorrhage. We will base the location of small vessel involvement to divide this type of small vessel as amyloid angiopathy or hypertensive angiopathy. Currently, we like to use MRI to identify the involvement of small vessel disease for the location and possible etiologies. For ICH patients, not only for the location of hematoma, we will look at other hints responsible for small vessel involvement. For example, not only ICH, the location, we also look for if the patient also have white matter hyperintensity, lacune, perivascular space, or cerebral microbreeds. All of this from MRI can help us to identify if the patient has some feature of cerebral small vessel disease or the possible etiology of cerebral small vessel disease. Right now, I just want to introduce two cases and try to show you why we will look for specific etiologies other than the SMART-U classification. The first case is a 62-year-old woman. She has underlying hypertension, but really good, well-controlled in the past and DM. She doesn't have any family history of stroke because she was adopted. And she presented with acute onset of left limb weakness. And in our hospital, the initial head CT showed right thalamic hemorrhage. So the imaging was here, so you can see a fresh hematoma in the right thalamus. The patient recovered really well with medical treatment only. However, 5 months later, while she was doing the rehab program, she suffered from another stroke event. And the CT showed another site, left thalamus hemorrhage in this time. So when I look at the patient, actually, she was my friend's mother-in-law. I just look at the patient and the clinical course in the past several months. I just don't know why the patient developed the recurrent stroke so frequently, even under a well-controlled hypertension. So we arranged the MRI for the patient. So as I just mentioned, MRI not only show the location of hematoma, we would also look at the features of small vessel disease. So you can see that the patient has left thalamus hematoma, but she also has very diffuse severe white matter change in both sides. And the down part, and let's try. Okay, so you can see the microbreeds here. Hippocampus, temporal occipital, and frontal, and bilateral thalamus, external capsule, and periventricular white matter. And also the patient has like superficial siderosis. So it's a case of mixed cerebral microbreeds and some hint for properly superficial perforator arterially involvement, both deep and superficial. So I just want to show you another case. It's an 84-year-old woman. A couple of years ago, she developed right posterior medial temporal ICH. The location is here. So the upper part, you can see the SWI show the patients not only for the location of acute hematoma in the right temporal. At that time, she also has some microbreeds in right temporal. Right temporal, and also some dip in both sides. And also in the down panel, the flare also show the patient has diffuse severe white matter change. However, just 2 months ago, she developed left thalamic hemorrhage. Not only for the acute hematoma, you can see compared to the similar MR imaging a couple of years ago, during the interval, there is some changes of the severity of white matter and also the amount of cerebral microbreeds. So what's the etiology or cause of ICH in these two patients? Usually we will contribute the thalamus or subcortical hemorrhage into probably hypertension and angiopathy because both of them have underlying hypertension, but actually both of them are well controlled. However, if the patient, the etiology is hypertension and angiopathy, we would expect the location of microbreeds would be like predominantly or usually like only in deep area, but they all have mixed CMB. And then they have severe and diffuse white matter change and all lacune. So what's the etiology or type of ICH patients? Can we say they are cerebral amyloidoangiopathy, but a typical hematoma location, or hypertensive angiopathy with a typical hematoma location or a typical cerebral microbreeds? I'm not sure, but then we did the genetic testing for both of them and revealed the NOD3 mutation positive. So they are not only for the underlying risk factors, they are CALR-CO patients because of a strong and specific NOD3 mutations in both of them. So now I just want to quickly introduce this disease, CALR-CO. The full name of CALR-CO is cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. The disease was introduced for probably 20 or 30 years, but the original or classical concept for the disease is repeated ischemic stroke, not hemorrhage. So you can see the CALR-CO. There is no hemorrhage concept into this full name. Because the classical patient, we will see the diffuse severe white matter change, especially in external capsule and anterior temporal. And most of them develop repeated ischemic stroke or vascular dementia or vascular Parkinsonism. In Taiwan, our group, in 2004, we identified the first CALR-CO family. And the typical imaging pattern, just like the one I showed you from the Western countries, anterior temporal involvement and external capsule, and the patient has very strong family history of stroke and also repeated ischemic stroke. However, because of the rapid progress of genetic testing all around the world, there are more and more studies using large database with genome-wide survey or exome sequencing. They started to identify some NOD3 mutation, not in the classical location, but also cause the function or clinical impact in different NOD3 mutations. Especially, all this show some founder effect. That means in specific area, the specific NOD3 mutation would be accumulated in the population. And the frequency of NOD3 mutation in the population could be as high as previously unexpected. Previously established, the prevalence of CALR-CO would be like 100,000 per like 2 or 5 subjects. But due to the introduction of genome-wide survey or exome sequencing in like many big database, they identified the prevalence could be like 100-fold higher than the previously expected. For example, in East Asia, the mutation of arginine to cysteine 544C could be as high like 0.9% in this population. So a couple of years ago, we started a study just to screen this hotspot R544C in a stroke consortium in Taiwan. We screened this hotspot in around 2,000 stroke patients. And surprisingly, we found around 2% to 3% in this stroke consortium participants, around 2,000 stroke patients. And we especially found the mutation is highest in patients with small vessel occlusion and also patients with ICH. And let me remind again that both of them are related to cerebral small vessel disease. And then we look at some imaging features for patients with ischemic stroke on MRI. So we look at around 700 ischemic stroke patients with MRI available. And we identified that the most important imaging feature would be deep white matter involvement compared to in NOD3 mutation patients compared to non-NOD3 mutation patients. So these are the demographic imaging for like periventricular white matter involvement and deep white matter involvement. So for patients carry NOD3 mutations, the involvement of white matter usually is more severe, and also the area is more widespread, not only the periventricular area, but also to deep white matter involvement. So then we start to look for some image features for ICH patients. Since ICH patients usually just receive head CT only, so we try to look for some imaging features for ICH patients only from the head CT images. So this study was done in our hospital. We tried to look at the ICH patients with only CT to identify, collect like burden of white matter lesion, degree of brain atrophy, number of lacunes, present of juxtacortical white matter lesion, and lobar lacunes in a series of around 300 ICH patients. And among them, around 5% of ICH patients carried 544C mutations. And we found that based on the CT imaging, if the patient present with juxtacortical white matter involvement, again, the concept is widespread white matter involvement. It's the most important key feature to hint the patient may have NOD3 mutation, a case of NOD3 mutations. So compared to other imaging features, we found that this new concept that look at CT to identify if the patients have predominant juxtacortical white matter lesion, just like the imaging in our right hand, the B and C, that means some juxtacortical involvement. They have high chance of NOD3 mutations. So we just try to tell our colleagues and our students that not only look at the character of hematoma on CT, as a clinician, especially for neurologists, you need to look at the severity of white matter changes, especially the juxtacortical white matter involvement. That will help you, at least in Taiwan, to identify if the patients carry NOD3 mutation or not. That's an important key feature. Another study will just try to compare patients with CAA and CADASIL, the microbreeds distribution. And you can see that CADASIL patients carry probably like all these areas microbreeds, but CAA only for lobar. And the quantification image also show the distribution, the difference between CADASIL and CAA. So we just conclude that not to exclude CADASIL for the pre-existence of lobar microbreeds, but probably we can exclude CAA for the existence of deep cerebral microbreeds. So what about the prognosis for CADASIL ICH patients? In the first, we just collect like 70 patients with stroke with R544C NOT3 mutations, and followed up probably for 5 years. And we found that the annual stroke recurrence rate was high as 8% per 100-person year, especially for patients with ICH onset cardiac patients, then ischemic stroke onset patients group. But the recurrent stroke could be either ICH or ischemic stroke among cardiac patients with stroke. Then finally, I just want to show you the data that we also established an NTUH cohort for cerebral small vessel disease, Taiwan genetic and sporadic small vessel disease, TEC SVD. We include patients with CSVD features on MRI or clinicals. And we screen R544C first, and then we will do the NGS for these 5 genes related to small vessel disease. And we identified that once patient carries some small vessel disease features, the percentage of NOT3 mutation could be as high as around 30%. And if we compare ICH patients with or without NOT3 mutations, we can see that patients with NOT3 mutation, ICH patients, were more likely to have thalamic hemorrhage, family history, especially sibling history of stroke, and more severe neuroimaging markers of SVD. And the prognosis also different that ICH patients carrying NOT3 mutation has much higher recurrent stroke and recurrent ICH rates compared to non-NOT3 mutations. So what to do after genetic testing? So we can do very aggressive BP control. So in my clinics, I give all my patients with NOT3 mutation positive, each one a new BP monitor. I just tell them that you just try to use this BP machine and record the data every day and come back next time. I'll check if you fulfill the recommendation for patients with ICH, not only for mutation patients, but we recommend patients with ICH or try to control BP below 130. And then we ask them to do the lifestyle modification. And we'll do regular follow-up imaging, cognition. Especially the most important is genetic counseling. Because for the patient already developed ICH, the outcome probably not so good, but we make early identification of some patient with very mild symptom of CALASIO. So we can do the genetic counseling and try to identify if some of their relatives also carry the gene and already develop some symptoms. And finally, I think the most important is some study already focused on specific genetic or target therapy for CALASIO patients. And if we can really try to identify them in our hospital or countries, we may apply these new therapies for them once a day. So I just make a brief summary. So based on our study and some of our colleagues' study in Taiwan, we found that ICH patients carrying NOT3 mutation is not uncommon. At least it's not rare in Taiwan. And ICH patients with NOT3 mutation have prominent CSVD markers on not only MRI, we can also look at CT to identify juxtacortical white matter involvement. That's very important for patients with ICH because most of them may have only CT imaging, but you can still use them to identify who may carry NOT3 mutations. And compared to NOT3 mutation negative, NOT3 mutation positive ICH patients have higher recurrent stroke rate and worse outcome. Finally, for CALASIO patients, we may do aggressive BP control and other risk factors control, which we already have some data to show that this can improve their outcome compared to patients without aggressive BP control. And we also believe that individualized therapeutic approach will be promising in the future for this group of patients. So this is my presentation. Thank you.
Thank you, Professor Tang, for your excellent speech. Is there any question from the audience? Yes, Professor Tang.
Thank you for your particular explain this mutation patients. I just want to know, is this kind of mutation patient had any particular change of hyperlipemia or suffer from DM?
Yes.
Mobility, how about the comorbidity?
Yes. Thank you for Professor Gao's really good question. We found that why we will overlook or miss the diagnosis for these patients, because some of them or most of our CADASIL patients, they also have comorbidities, not only hypertension, but also dyslipidemia or DM, or even some of them have habit of smoking. So clinicians may think the severe Y matter change or the development of stroke could be related to these risk factors, not only related to gene. However, if we compare them to other patients without genetic mutation, but also have these comorbidities, it's really to identify genetic patients because they show much more severe Y matter change and much higher recurrent stroke rate. So I think right now we try to look if we really control risk factors for these populations, maybe we can improve some of prognosis for the patients. But yes, the question is yes. I think most of our CADASIL patients, they have conventional vascular risk factors. So clinicians should not exclude CADASIL for patients with conventional risk factors. On the other side, for this group of patients, we may try to control at least conventional vascular risk factors, because this may help them to reduce the incidence of stroke and better prognosis. Thank you.
Is there any gender difference? Gender?
No. But actually, this is a good question, because in our observation that male usually have like poor control vascular risk factor and poor lifestyle, but female, they may have like better control of vascular risk factors and better lifestyle, so maybe have some difference. But overall speaking, I don't really think there is gender effect in our population. Thank you.
Okay, thank you.
I have two questions. Do you have data about the normal I'll change my question. If I have NOTCH3 mutation, well, I definitely have small vessel disease in the future.
Okay. That's a really, really good question, and that's we really want to try to answer this question in the future. According to my introduction, so you will know that even in Taiwan, the prevalence of symptomatic or asymptomatic, we call that carrier, that would be as high as probably like 0.8%, based on the Ventral General Hospital Professor Lee's study. That means in Taiwan, a lot of our generation or population carry the NOTCH3 mutation. However, the NOTCH3 mutation also requires the accumulation of aging, the vascular risk factors, or other environmental factors to develop disease. But if we don't really think about the disease, we just look at the MRI, the NOTCH3 carrier at the average age of 40 or 50, they already show some degree of Y matter change. However, we may not show some symptom, or we may have some disease just because of our Y matter change. So the answer is, if we look at the disease, probably you don't have any disease in your lifelong. But if we look at MRI, I think you will have like mild, moderate Y matter change in the age of 50, and moderate to severe in the age of 70. But of course, we may not really think it's really important, because you don't have to have genetic mutation. You also may have Y matter change or other disease in the old age because of some comorbidities.
So right now, the CADASIL was single gene disease
Yes.
or multiple genetic mutation?
It's a single gene disease.
Okay. Is there any question? Okay. Thank you for that time. On behalf of the Taiwan Society for Middle Use Neurosurgery, thank you for it.
我的脑袋进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种。若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症；因肿瘤或颅内出血使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病， 建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的寂寞腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防啊，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制三高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些，比如说记忆力减退，这种记忆力减退通常指的是最近的事情记不清楚，可是远的事情他可能反而记得很清楚，或者是大小便没有办法控制，或者是走路步态不稳，有这3种状况的时候，那必须立即找神经外科或神经内科的专科医师，赶快加以诊疗，赶快去处理，看看到底是不是有水脑症的状况。那如果不幸真的是有水脑症的状况，那必须要赶快处理，来减少将来后续的一些问题，比如说失智啊，或者造成一些残障或失能的状况。
我的脑袋进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种。若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症；因肿瘤或颅内出血使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病，建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的寂寞腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防哦，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制3高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些比如说记忆力减退，这种记忆力减退通常指的是最近的事情记不清楚，可是远的事情他可能反而记得很清楚。
会议即将在1分钟后开始，还请各位尽速就座。会议即将在1分钟后开始，还请各位尽速就座。
各位同事，还有医师，那个我们可能要回座，因为我们有国外的讲者在线上等待了，哈，就拜托各位再回到座位上，我们可能很快就要开始了，好，谢谢。好吧，好，那我们就直接开始好了，哈，好。 所以直接介绍嘛，哈。Okay. Good morning, dear colleagues. Today, I'm very honored to introduce our next speaker, Chris Kellner, on behalf of Professor Lai. He is doing emergency surgery on a patient with cerebral aneurysm. So I have the honor to introduce Chris Kellner. Chris is a long-time friend. He graduated from Harvard College and got his MD from Columbia University. Now he's a renowned neurosurgeon and the director of ICH program at Mount Sinai. He's also a pioneer in the MIS surgery for ICH in the United States. I had the honor to visit him a few years ago at Mount Sinai, and I was inspired that not only he knows about surgery and his technique, he also tried to improve ICH patient outcome in many other ways. For example, they work with software companies to bring in patients more earlier to get earlier intervention and better outcome. So I think ICH is not only a surgical disease, it needs a different multidisciplinary effort. With that said, let's all welcome Chris Kellner. Thank you, Chris.
Hi, thank you so much. It's really a great honor to speak to you today. I'm in New York City, and I'm just in awe that I'm able to contribute to this conference from New York right now. So thank you so much for inviting me. Today, I'm going to focus on surgical trials in ICH. I'm going to give an update, and then I'm also going to talk about future directions. And I know you're having a few talks similar to this today, so I'll try to be as original as possible. I have a few conflicts of interest, and I'm in a few trials. I'm not a consultant for any company, but I'm involved in research with numerous companies that have devices that I'll talk about, and they're all listed here. I'm going to start with my acknowledgements. These are my surgical mentors, and I really owe all of the training I've had and my perspective being a surgeon and a doctor to these individuals as well as others and my colleagues here at Mount Sinai. This is Dr. Connolly at Columbia. This is Dr. Mako at Mount Sinai, the director of our cerebrovascular center. And this is Dr. Betterson, the chairman of neurosurgery at Mount Sinai. And they have really given me the opportunity to focus on intracerebral hemorrhage and to help me develop surgical techniques that we as a team deploy for every patient who's eligible. But also I'm going to give some acknowledgements to some of the giants in this field who you're going to hear from in this conference. This is Dr. Dan Hanley. You may have already heard from him today. And then Gustavo Perdilla. I actually got to know both of them around the same time. When I was a medical student, I went to Hopkins to do a rotation, and Dr. Perdilla was a resident at the time. And I kind of tagged along with him. And while I was there, I heard about Dr. Hanley and all the great clinical research he was doing. And of course, Dr. Kwang as well. And so I just wanted to mention these people because they have been inspiring to me in the development of my own techniques and perspective for ICH. And I'm honored to be talking in the same conference as them. And what I'm going to be talking about really comes from the work that they have done. The MISTY trial, which is really my favorite trial, this trial brought some information to the field that has been vital for how we move forward. And that's that if we remove the clot effectively, that might help get the patient better. And so we learned a little bit that you might have to hit a certain threshold, you might have to get a certain amount of clot out and do the procedure with efficacy to have a good outcome with the patient. And then of course, this very famous paper from 2011, which is way ahead of its time, 68 patients who had early evacuation with exceptional procedural outcomes. And the combination of these two papers is what I believe is the future of ICH. Effective evacuation done early. And these two papers from these two individuals come together. And that's really the theme of this talk. It's trying to do the evacuation effectively and trying to get it done early. This is where I am right now, New York City. One of the hospitals I work at here is Mount Sinai. The other hospital I work at, where I'm sitting right now, is Mount Sinai West. and this is where I live up in Harlem, we have a unique system that my mentors established before I started working here, and I was recruited to build this system where if any patient in this area, in any of these satellite hospitals in the Mount Sinai Health System or our partners has an intracerebral hemorrhage, we immediately hear about that hemorrhage using an AI detection algorithm developed by Viz AI. And that gives us an automatic volume. So if this patient arrives at Elmhurst, or sorry, Mount Sinai Queens over here in Queens, I hear about it immediately when that patient's CT is done. If a patient arrives at Mount Sinai Hospital with an ICH, I also get a text about it immediately with the volume. If the patient arrives at Mount Sinai Beth Israel, the same thing. And all of those patients get triaged to emergently to Mount Sinai West, which is where I now am. And we have built a intracerebral hemorrhage center right here. And by bringing all the patients there to this ICH Center of Excellence, we're able to consolidate this disease process and get everyone familiar with how to treat these patients because, as you said, this is a multidisciplinary disease that really requires all hands on deck and everyone focusing on this disease process because the patients are so sick and they do require such specialty care. So there are a few major questions I'm going to try to address in the next 25 minutes. The major questions in ICH trials: should we take out the clot? And I would argue this is not even a question we've answered effectively yet. Once we answer that question, how should we do it? And these are being answered simultaneously because maybe we need to do it effectively to answer the question of should we take it out or not. And then, of course, when should we take it out? Should we take it out ultra early, like in the paper from Dr. Huang's group from 2011? Or can we use a more selective method that permits us to do the evacuation a little bit later? And then, of course, and this is the futuristic part that I'm excited to talk about in the second part of my talk, what should we do after we take out the clot? What kind of neuroprotective strategies can we employ? Should we take out the clot? Let's focus on that for a few minutes. We've learned from trials that have focused on open craniotomy that open craniotomy is not effective. These are the 2 stitch trials. I'm not going to go into the gory details, but these were very well done trials that both showed that open craniotomy overall did not appear to be effective when evacuating intracerebral hemorrhage. Also, we learned around the same time in 2001 that ultra early craniotomy did not appear to be safe. And this particular study showed that rebleeding occurred in 40% of patients treated within 4 hours, compared with 12% of patients treated within 12 hours. And that's not the data we saw from Dr. Huang's group, but that is the data we saw when craniotomy was performed in this particular study. Before this study, it seemed like the field was moving rapidly towards early evacuation through craniotomy. And this really put a stop to that and let people know that maybe it's not safe because of the bleeding. The bleeding can't be handled in the procedure safely. Surgical hematoma evacuation within 4 hours was complicated by rebleeding, indicating difficulty with hemostasis. However, something interesting that came out of this that we saw in MISTY 3 is that there was a clear correlation between improved outcome and smaller post-surgical hematoma volume. So that was kind of the first clue in the history of all the trials that the more clot you get out, maybe patients do a little bit better. But overall, this trial was a warning, and that this put a stop really for many, many years to ultra early evacuation. Well, for 10 years to be specific. But maybe other techniques might be effective. So minimally invasive ICH might be effective. And I say might because each of the trials listed here in this meta-analysis from our group from 2018, each had its own issues. Some of them were single center. Some of them had procedural issues. And but overall, if you look at these, they were all randomized clinical trials. Overall, the data that we have, all these minimally invasive trials taken together, appear to improve outcome at the outcome time point of each of the studies, favoring minimally invasive surgery when taken as a whole. And that in the meta-analysis is statistically significant. And so there is very good signal that minimally invasive surgery might be effective. And that's what we've based our practice on. And I know this data is also what your group has based their practice on. And why might minimally invasive surgery be effective? Let's go back to Dr. Hanley, and MISTY 2 showed us that when doing the MISTY technique, which is catheter drainage with thrombolysis, they were able to get out a good amount of the clot reliably. This is the treatment group that got out about 60% of the clot on average. And something interesting here, when the clot was removed, the more clot that was removed, the percent that was removed correlated with the percent reduction in edema. And so this is a little bit of a hint early on in 2013 that there might be a mechanism, an anti-inflammatory mechanism that's protective potentially. When the hematoma is removed, there's less inflammation, there's less edema. And so that's a surrogate outcome measure that was motivating for a lot of people to continue investigating this method in further trials. And then that brings us to MISTY 3. And as I mentioned, this is my favorite trial, not because it was negative, and it was negative here, and I show you this MRS distribution. That was the primary outcome, which was the MISTY technique overall compared to standard medical care. But this trial was so well done that they were able to get very good information from subgroup analyses that are informing future trials as we speak. And so this has become a very famous graph, and this is the end of treatment ICH volume. Here is a very high end of treatment ICH volume. So you might say that this one right here was a very ineffective treatment. This here was not that effective a treatment. But when you look at the probability of a good outcome, which is an MRS of 0 to 3, all of the good outcomes go up here and all the bad outcomes go down here. But the probability correlated with the end of treatment ICH volume such that very low volumes appeared to do better. And once you went under 15 milliliters as an outcome, as a final volume, it appeared when you took that subgroup alone, those patients appeared to do better than the medically managed patients. And so that was a pre-specified subgroup. It wasn't the primary outcome, so we can't say it is true. We can say it may be effective because it was a pre-specified secondary outcome. So should we take out the clot? I think we've addressed that in the data that we have. There's a strong indication we should. How should we take it out? And let's look at the wide variety of methods there are to remove a blood clot. And each of us has our own favorite, but there really has been a Precambrian explosion of techniques for removing blood clots. I'm going to go through some positive and negatives of each of these. And so this is the MISTY technique. And the MISTY technique from the MISTY trials, you place an EVD catheter stereotactically into a hematoma. You aspirate gently, see what kind of liquid you can get back. And then you infuse TPA and you allow the hematoma to drain passively over multiple days while repeating scans and repeating TPA to make sure that you have not caused any problems. And so there are lots of advantages, which is going to be the green square, and disadvantages to each technique. And I'm going to talk about the advantages and disadvantages here to MISTY. MISTY is highly feasible. If all the neurosurgeons in the audience here know that placing a catheter is challenging, and we know from MISTY you have to do it right, but it's easier than some of the other surgical techniques we're talking about. So it's feasible, it's teachable. There's a robust clinical experience from all the trials and all the centers having done it. So it's already well known how to do this in the field. And the cannula is very low profile. You're only putting in an EVD, you're putting in an EVD cannula and leaving in the tubing. And so it's very low profile, 4 point something millimeters, the lowest profile of all the techniques I'm going to show you. So what are the negatives? In the MISTY trial, approximately 60% of patients hit the procedural outcome of no more than 15 cc's left at the end of the procedure. And so you might say that that's on the low side. And you might say you need it higher to overall have a positive trial. You have to be highly selective when deploying this procedure. You can't use this for patients who have expanded unless you then get another stability scan. So you have to have stability of the hematoma, and that automatically excludes a large number of patients. Also, you can't have a spot sign, which gives you a high chance of expansion. And so that's another group. And you can't address expansion itself. there might be a major advantage to an early evacuation technique because you might be able to get in there quickly and mitigate expansion. If you can mitigate expansion, then you can automatically win the procedural benefit for those patients who don't expand, because we know that expansion worsens outcome. So this technique cannot address expansion, and I see that as a big negative, although there are major positives. Let's talk about end-to-port mediated evacuation. You're going to hear about this from Dr. Pradilla. Dr. Pradilla is a PI or the main PI of the ENRICH study evaluating this technique. And this is when an end-to-port is placed stereotactically into the hematoma, and then a device called the NICO Myriad, which is a morcellating tool, is put down the endoscope, and you can get 2 hands down there and use a bipolar next to the Myriad. And so that's one of the major advantages of this technique. You can use bimanual technique, and that permits you to aspirate with a 12 French sucker, cauterize, kind of do surgery like neurosurgeons know how to do surgery with bimanual technique. You can get good visibility if you do this with a microscope or even with loops on through the tube, and you can enroll patients or perform this on patients who have expansion because you're able to cauterize bleeding fairly easily. This is less minimally invasive than the MISTI technique and the other techniques I'm going to show you. There's less evidence currently in play, although that might change very soon with the ENRICH results. And it does require a little more training than the MISTI technique. So I'll count that as a negative, although this one's probably easier than some of the other techniques I'm going to show you. And so endoscopic assist, I know, is something that people in Taiwan and other countries have been doing for quite some time now. It can be done early. There's very good visibility with the endoscope down next to the multifunctional cannula or the instrument being used for aspiration. And therefore you can enroll quite a few patients or perform this on quite a few patients because you don't have to exclude patients with spot sign or patients who are expanding. It's less minimally invasive than the MISTI technique, but more minimally invasive than the end-to-port technique. It's about 1 centimeter cannula, and that's the average. There's less evidence currently. There's not a randomized clinical trial, or rather a large-scale randomized clinical trial. And this does require some more training probably than the end-to-port mediated technique and also the MISTI technique. Let's talk about endoscopic. This is the one I'm passionate about. And this has early evacuation potential. Maybe not ultra early, we don't know that yet. There's no data for that, but we do have data in our own group that early evacuation within 12 hours does appear to be feasible. You can get very good visibility, as I'll show you in the case, and there can be broad selection criteria. This is less minimally invasive than the MISTI technique, but it is more minimally invasive than endoscopic assist and then end-to-port. There's less evidence in support. There's the MIND trial, which is ongoing. And this does require even more training than end-to-port mediated and then the MISTI technique. So I'm going to tell you about the technique we've developed at Mount Sinai. We've been calling it the scuba technique, not because we perform it underwater, but because when you're in there with the endoscope, you're irrigating and working within a fluid-filled field. And by working in a fluid-filled field, you can puff up the cavity a little bit and maintain visibility of all the walls. If you've ever done these procedures, you know that things close down, and sometimes it's tough to see around the corner or to see through an area that already closed, and to go back through and check to make sure there's no bleeding there. You can cause more bleeding by touching the walls of the cavity. So I really like this because when I'm finished with this procedure, I know that there's nothing bleeding. So I'm going to tell you a story about this patient. This is a case we published as a video case in World Neurosurgery recently. There's a 55-year-old male who came in with loss of consciousness. Initially, he was a stroke scale 4, but then he worsened to a stroke scale 15. Here's what his hematoma looked like. I know that anyone in the audience who does these procedures sees this as a great case. This is a really nice case. It's a little bit more anterior. It's not hurting the thalamus. And you know that these patients, if you get a good evacuation, can do well. He was young, so we did an angiogram, and these procedures are done at our institution in the angiography suite. We usually do intraoperative ultrasound, and so here's the pre-evacuation ultrasound through the burr hole probe. I do this through a 1 centimeter burr hole right here on the forehead, down the long axis of the clot, just 1 centimeter there. And then I place this Escalap vascular sheath, which is 6.8 millimeters in diameter. And then down that goes the Storrs Lotta 3-port endoscope. And then down that goes the adjunctive aspiration instrument. It could be there are a few different options. I prefer the Artemis and by Penumbra, and that's what I've been using. And that's what this series I'm going to show you and this procedure utilized. So here's the inside of the sheath. Here's the device coming down. starting to aspirate, and then you can see some brisk red blood there. I keep irrigating, and then I keep aspirating as I see new clot come in. After about 20 minutes, I'm able to see a little bit in the cavity. You can see there's a little bit of cavity wall there. And I'm continually irrigating and aspirating any blood clots that come out there. And about 40 minutes into the procedure, now I've got a sense of what the walls look like and the cavity looks like. And I can even see where there's some active bleeding coming from up here from those streams of blood. And here's a bipolar that I'm putting down the working channel of the endoscope, and I'm actively cauterizing the bleeding area in the wall of the cavity right there. And then after 40 minutes to an hour, I've got the cavity completely clean, nothing's bleeding. I've irrigated out all the new blood and aspirated out all the old blood, and you can see that things look just like you're scuba diving and very clear here. That patient did very well. He left the hospital intact on post-op day 4. Here's his post-op day 1 CT. So we've done this in about 200 patients now, and we published our first 100 patients in 2020. And just to give you highlight a few data points here, our average evacuation percentage was 88.2. And the number of patients out of the 100 that we hit the MISTI target in was 86%. So we had less than 15 mLs of residual in 86% of patients. Our average time to evacuation was pretty late. We didn't really start rushing patients in until after we saw the results of this 100 patients. And it took us about 2.5 hours for each procedure. Patients spent 8.5 days in the NSICU and 17 days on average in the hospital, or rather the median. And then our 180 MRS 0 to 3 was 46%. And now these are all comers. We're not being very selective with these patients. So some of them are doing very poorly when they come in. Many of them have spot sign. Many of them have expanded. And so we're not really excluding patients who seem like they're going to do poorly. So this is a as they come kind of group. And one thing that I think reassured us that the technique we're using is effective in preventing rebleeding by ensuring that the cavity's clear is that we had very few rebleeds. We only had 4 asymptomatic rebleeds, and we had 1 symptomatic rebleed at day 30. Right at day 30, he came back to the hospital with a symptomatic rebleed. When we looked at that data set, which we published in 2021, and we looked at factors that predict a good outcome at 6 months, we saw a lot of the old characters that we know do this, such as age, intraventricular hemorrhage, lobar location, but we also saw within our own data set that it appeared that time to evacuation played a role in predicting a good outcome at 6 months. And this odds ratio of 0.95, we interpreted as every hour earlier, you had a 5% increased odds of a good outcome. And when we graph that in the same way that the MISTI team graphed their data, time to evacuation on the x-axis, probability of a good outcome on the y-axis, we kind of saw a similar curve where patients who were evacuated earlier had a higher probability of a good outcome. And so when should we take out the clot? We think it's earlier, and there's some good animal data supporting that, and also some other clinical data I'm going to show you in a minute. And so this is one, I'll show you only a few of the many animal studies suggesting that early evacuation is better. And so here, an inert object, a balloon, is inflated in this rat basal ganglia. And here, when the balloon was only inflated for 10 minutes, those rats did very well. Their clinical score was very high, and none of them died. When it was inflated for 60 minutes, they did less well, and some of them died. When it was inflated for 120 minutes, they did less well, and more of them died. And when it was inflated and not removed, all of them died. And so in this one example, you can see that there's a benefit, obviously, to early evacuation here, or early removal of the mass. Here's another study. This is a study just showing that when you do an early evacuation with lysis in this pig model, you can get the hematoma out effectively, and then you also reduce edema and you decrease blood-brain barrier breakdown in the model. This wasn't randomized. They didn't do a comparative study, but they just showed that you get, when you remove the hematoma, the animals that did not have the hematoma removed had more hematoma, obviously, but they had a lot more edema. So when removing the hematoma, you reduce the edema. Again, that same neuroprotective effect we saw a little bit of a hint of earlier. We also saw this in our own data. We saw that in our evacuated group, we saw less edema on average, the more hematoma that was evacuated. And so this has been seen in clinical trials as well, that early evacuation appears to potentially play a role here. And so in this patient-level meta-analysis with 13 RCTs, 8 of them had data that was included in this patient-level meta-analysis. And when you took the patients who were enrolled in their study less than 8 hours, and you compared those to the patients, the ones who got surgery, compared them to the ones who didn't get surgery, but were enrolled within 8 hours, there appeared to be signal favoring surgery. When you look at the later groups, that signal disappeared. And so this is a patient-level meta-analysis supporting early evacuation. There was also a study-level meta-analysis that had a similar finding, although it was very subtle. But why wasn't there a time effect in MISTY or stitch seen? And you'll hear that from Dr. Hanley and others, that there wasn't any time effect in MISTY or stitch. And two possibilities that I think need to be investigated are, the evacuations overall occurred too late to perceive a time effect. You can imagine that this occurred in ischemic stroke, where later procedures are believed to be outside the time window and therefore less effective. Too much damage has already occurred to perceive a time effect. That doesn't mean that the removal is ineffective, but it might be too late to perceive a time effect. The time effect might be early, and you might lose that window of the benefit of time early. That's something we haven't evaluated in any way yet. And then maybe not enough clot on average was removed in either study to perceive the time effect. Maybe you need a combination of a good removal and an early removal to show a time effect. What should we do after we take out the clot? And so I know I've only got a few minutes left, and now let's take a brief trip to the future and just kind of imagine what things are going to look like if all these trials work out in the best fantasy situation. Let's talk about advanced hemolysis and drainage, robotic ICH evacuation, intracavitary neuroprotection, and post-ICH neuromodulation. Don't worry, I'm going to blast through this in 2 minutes and try to stay on time here. But this is I'm just going to lightly touch on a few exciting things I've heard about. I'm not going to show any data. This is entirely hypothetical. So there are some devices that have been developed and I've heard about, and this is one that I'm likely going to start a research project with. This company called Eros has a double lumen catheter that can irrigate a cavity. So you place this, you might do the MISTY procedure and place this and then irrigate the cavity with or without TPA. And that lavage might improve the evacuation rate. We don't have any data on that yet, but that's one potential advanced hemolysis and drainage technique. Here's another one from Dr. Hanley again, and this is using sonothrombolysis in the hematoma to hasten the breakdown of the hematoma to permit more rapid and effective drainage. And so that's something that was published in 2011. I haven't seen more from that particular technique, but that's something that might be a future option. Robotic ICH is also something that a few articles have started to come out on this. We know that robotic ischemic stroke thrombectomy is occurring, and there are already numerous articles on that. So why not ICH as well? Well, there's this particular study called the Niche Robot by Jun Sheng and others. And then there's also a grant that is active, and I've seen one paper by this group with Kevin Cleary from Children's Research Institute. So more to come on that exciting topic, and I'm sure there will be numerous papers in the near future on that. Let's talk about intracavitary neuroprotection. And there are 3 types of this. There's drug delivery, stem cell therapy, and focal hypothermia. And I know some people in the audience have done a lot of work on stem cell therapy. Drug delivery, there are a few papers that are animal studies infusing various drugs into the cavity after hematoma evacuation. And you can imagine this might work well with the MISTY catheter technique. Put in the catheter, put in TPA, allow the drainage of the hematoma, also infuse a neuroprotective agent. And in this particular animal study, rosiglitazone appeared to have a neuroprotective effect. Stem cell delivery is something that I know this group in the audience is very active with. And so this was a paper that I stumbled upon when preparing this talk, and I thought this sounded really interesting. I was surprised to see that there really have been quite a few studies looking at brain parenchyma delivery of stem cells. These are all preclinical studies summarized in that paper by Dr. Huang and others. And then there have even been 2 clinical trials in China looking at direct infusion. This is brain infusion of various forms of stem cells. So more to come on that. Looking at focal hypothermia, this is something our group is very interested in, and we have developed a device around implanting a focal hypothermia device and leaving it in there after the minimally invasive evacuation to chill the brain. There's also, in stroke, peripheral neuromodulation and vagal nerve stimulation. A lot of you probably saw this article from last April, where vagal nerve stimulation, when paired with rehab, improved upper extremity movement after ischemic stroke. There's animal data suggesting that this might also work in intracerebral hemorrhage, and there might be trials down the road evaluating this, so something to watch for. And then, of course, brain-machine interface, and this is an article from JNIS recently with Tom Oxley, who founded a company called Synchron and implanted a stentrode, or a stent with electrodes on it, in the sagittal sinus, and that has been able to code some brain activity and permit individuals with limited movement to interact with a computer. This is only one example of numerous brain-machine interface techniques that have been published only in the last few years. But why not ICH? Ischemic stroke and paralysis, but ICH could be down the road for this as well. And so I'll stop here and take questions from the audience if we're going to do that right now, or otherwise discuss in the panel. Thanks so much for inviting me here today.
Chris, so we have one question from the audience. What's the explanation for expanding hematoma as a red flag for surgery? So I just think during your talk, maybe you talked about like the MISTI trial. I think if there's a expanding hematoma, it's a contraindication for MISTI, right? But for other surgical technique where you can do direct hemostasis, that wouldn't be a problem, right?
Exactly. I think of evacuation techniques as, in general, being passive, where you're not inside the cavity and you don't have the ability to coagulate something bleeding, or active, where you're in there evacuating the hematoma actively and coagulating something if it's bleeding. So the passive techniques such as craniopuncture and the MISTI technique cannot cauterize, and therefore it may be unsafe. We don't know that for sure, but it might be unsafe to attempt to remove a hematoma with active expansion and with a spot sign in those cases.
Yeah, thank you. So are there any other questions from the audience? Oh, yes, Professor.
Thank you very much for your very exciting speech. I just want to know any animal experiment to show the benefit of the intracavity injection of stem cell therapy for the after ICH evacuation. Any evidence of animal experiment to show the benefit or the efficacy of the injection of stem cells into the ICH after ICH evacuation. Any more experiment to show the efficacy?
Yes, that is a great question. I went through that quickly because it was towards the end of the talk, and I'm not an expert in this, but all of these studies evaluated animals getting direct injection of stem cells into the hematoma cavity or around the hematoma cavity. And this particular study, I was able to see some data from. This study was presented at International Stroke Conference 2020. And here are two graphs from that publication. And here you see there are cells that are uptaken around the cavity when injected into the hematoma cavity. And these are, I believe these are placenta-derived mesenchymal stem cells. And then there was also more cells. Sorry, this is the edema ratio. And so when cells were injected into the cavity in this particular model, there was less edema on the ipsilateral side of the hematoma in animals that had the cells injected. So there appeared to be more cells and less edema with the cells present. And then those animals did also have improved neurologic exams, which I don't have those graphs here. But that does seem like a very promising avenue. And it's an area where it seems like some groups are ready to move to clinical trials. And this slide I moved through quickly, but there are 4 clinical trials. All of them are in China. 2 of them have been published, and 2 of them are either recruiting or about to get started. So an exciting area.
So this kind of procedure is approved as a clinical procedure in the FDA of the United States. Is it approved?
No, I have not seen anyone in the United States inject stem cells. I was only showing data globally that I found when doing research for this talk. It seems like most of the research is done in Taiwan and in China.
Okay, thank you.
Okay. Yeah, thank you, Chris. So I have one last question. So how do you guys work with the software company to provide like transfer to your hospital? So what kind of collaboration between different centers? Because you get these ICH cases to your place, and do you also like compensate or work with the different hospital? I mean, can you tell us your experience in doing that? Of course, you gather a lot of cases and do early evacuation. I think that's amazing. Yeah.
Yes. Well, this disease process is a disease process that's very challenging to treat. Mm-hmm. And so not a lot of centers are doing this in the United States. So if a patient who has a hematoma that's within our enrollment criteria for the studies that we're running, or is within the guidelines for what our institution has agreed would be amenable to minimally invasive ICH evacuation, then we evaluate that from a distance. And that can be from a patient who's within our health system or from a partnering hospital. And then we either get the image on text message on the phone and evaluate by text message, or if the patient or if the hospital the patient's coming from has the app that I was showing you, then I will automatically be able to see on my own phone the scan, and I can scroll through the scan, and I can also see the automatic volume segmentation of the hematoma. And that's critical because the hematoma volume is one of the inclusion criteria for all the studies we're running. So it's very important to know exactly what that is. And getting this application called Viz.ai, there are 2 competing apps that are available in the United States that I know about called Rapid AI and AI Doc. So all 3 of those companies have some software where it will automatically detect an intracerebral hemorrhage. It will segment the intracerebral hemorrhage. I believe that not all companies have the FDA approval for that, but it does seem like that is becoming something that I believe will be standard of care in the immediate future.
Thank you so much. Yeah. Okay. So thank you for your time, and thank you for listening.
Thank you so much. I really appreciate it.
Thank you, Dr. Thank you, Dr. Huang. Let's welcome our next moderator, Dr. Li Yihui, and speaker, Dr. Cai Likai.
Good morning, ladies and gentlemen. Thank you for inviting me to this inspiring congress. It's my pleasure to introduce you Professor Cai Likai. Dr. Cai is currently the director of Department Neurology at the Hsinchu branch of National Taiwan University Hospital. He is also the professor of clinical neurology at National Taiwan University. His talent is not only limited in stroke, but also in motor neuron disease and translational studies. Let's welcome him to giving us this talk, Regenerative Strategies in ICH.
Thanks for the introduction. Ladies and gentlemen, It's my great honor to be here and present something about the regenerative strategy in intracerebral hemorrhage. And as you know, stroke can divide it into cerebral infarct, intracerebral hemorrhage, and also subarachnoid hemorrhage. And we may arrange the thrombolysis or thrombectomy for patients with cerebral infarct. We may do the surgery or hemostasis for patients with intracerebral hemorrhage. We can perform the clipping or embolization for patients with SH. However, not all the patients can receive this kind of treatment, for example, thrombolysis, thrombectomy, or surgery. Some treatment, for example, hemostasis therapy, are still under, maybe had an equivocal conclusion. And for clipping or embolization, is actually treatment is for prevent future event. So actually, until now, the acute management for stroke is still limited. And how about the neuroprotection treatment? Now we already have more than 50 phase 3 clinical trials try to demonstrate the usefulness of these neuroprotective agents in acute stroke. Unfortunately, all the trials are failed. So how can we do more for these acute treatment patients? About 5 years ago, Nature Review has showed that maybe we can do some new approaches for brain repair, from rescue to reprogramming. That is the idea of stem cell therapy. If we try to search some articles using a PubMed and using the keywords of stem cells and stroke, you will find that in the past few decades, the number of publications increased very rapidly. It means that this field has become more and more important. So today, I will try to show you first the lessons from ischemic stroke, then the current progress of stem cell therapy in intracerebral hemorrhage, and finally, the endogenous stem cells in ICH. About 20 years ago, researchers showed that intravenous injected mesenchymal stem cells can home into infarcted area with some differentiation into neuron, astrocyte, or endothelial cells. And this kind of treatment is associated with better functional outcome. And now we already know that various cell types, stem cell types, were effective for acute stroke treatment, especially mesenchymal stem cells and neural stem cells. And among them, mesenchymal stem cell is the most popular used stem cell type for stroke therapy. It's because of the features, including easy isolation, easy amplification, low immunogenicity, and a high ability for paracrine effects and immunomodulation. And I try to summarize the meta-analysis of stem cell therapy in ischemic stroke model. Overall, you can see that stem cell therapy is associated with better neurological function and less infarct volume. And there is consistent benefit using different methods in the ischemic stroke models regarding different dose, different treatment timing, and different injection methods. Is our data. Previously, we also tried to use the mesenchymal stem cells IV injection for our MCA occlusion animal models. And we indeed have the positive treatment effect. Unfortunately, we did not see any evidence of cell replacement. These injected mesenchymal stem cells are still mesenchymal stem cells with only a little of them differentiated into other cell types, including astrocyte or endothelium. And after they go into the brain, they nearly lost their ability to proliferate. And now we know that there are multiple therapeutic mechanisms of stem cell therapy in ischemic stroke, including enhancement of endogenous NSC proliferation, potentiation of neuroblast migration, promotion of neuronal differentiation, augmentation of angiogenesis, affecting neuronal plasticity, and modulation of immune reaction, but unlikely self-neuronal differentiation. So now we know that using different kinds of stem cells to do the stem cell therapy for stroke, you can have the benefit in stroke animal models via different mechanisms, including enhancement of neurogenesis, angiogenesis, hematogenesis, anti-inflammatory effect, and white matter remodeling. And finally, we need to confirm this kind of treatment in a human being. And here's a summary, the meta-analysis of stem cell therapy in current available clinical trials of ischemic stroke. Overall, you can see that stem cell therapy is associated with better functional outcome using different functional assessment. And stem cell therapy also has a trend toward better mortality data. And here is the 12 current available publications of randomized clinical trial about stem cell therapy in ischemic stroke. And here I would like to exclude 3 of them because they are just focused on chronic ischemic stroke. And among these 9 remain clinical trials, you can see that they are published from 2005 to the last year. And the number of patients in the study group range from 5 to 65, with the treatment timing range from 1 day to 2 months post-stroke. Some of them use the autologous bone marrow stem cells, and some use the allogenic bone marrow stem cells, using different dosage and the different treatment pathway, including intravenous treatment and intra-arterial injection. And overall, all the studies demonstrate the safety of this kind of treatment. And some of them show the positive treatment effect. And then I would like to focus on 2 of them because they have the highest patient enrollment. The red one, unfortunately, had a negative effect, negative final result. And they used the autologous bone marrow stem cell. It means that after patient has a stroke, you need to collect the stem cells from the patient himself or herself. Then after collection, after proliferation, inject the stem cell into the bloodstream of the patient. So it requires about 2 to 3 weeks after you can inject the cells. So maybe it's already too late. And for a story of the green one, you can see that is a positive result. And they use the allogenic multipotent progenitor cells, that is the bone marrow stem cells, because they use the allogenic stem cells. They can inject, they can treat this patient at very early stage, that is 1 to 2 hours post-stroke. So let's continue focusing on this green study. We call that master trial. It's the largest stem cell trial in stroke until now. That is a randomized double-blind placebo-controlled phase 2 trial, and they use the allogenic multipotent adult progenitor cells, or so-called multi-stem, from bone marrow. And the patient will receive the intravenous injection of this stem cell at the window of 24 to 48 hours after stroke. And first, they found that, again, this kind of treatment is safe and well tolerated. And at 90 days after stroke, although there is no significant treatment or primary outcome, but at 1 year after treatment, there is significant better functional outcome in the stem cell treatment group. And they also demonstrate that early treatment at 24 to 36 hours show more beneficial effect. So now they rapidly move into a phase 3 international multi-center double-blinded RCT trial, and we call that MASTER-2 trial. And they use the similar treatment method, but they treat the patient at earlier phase, like 18 to 36 hours post-stroke. And finally, they will enroll 300 of patients. And our hospital just started recruitment and enrolled the first patient. And this patient has very good clinical outcome until now. Of course, we don't know that this patient belongs to a stem cell treatment group or placebo group. And in addition to stem cell therapy, some studies try to see the effect of exosome. Exosome is released from stem cells, in which there is some good factor, for example, neurotrophic factor, and you can easily isolate this exosome from the stem cell culture medium. And you can try to inject this exosome into the bloodstream of the rodent animal model or the patients. And this exosome can go through the blood-brain barrier and target your neuron. And while some effects including neuroprotection, neural restoration, the patient or the rodent can have the better functional outcome. And actually, until now, there are already some small early phase clinical trial using exosome in acute ischemic stroke, and the results are still anticipated. And then I would like to move into the current progress of stem cells in ICH. Again, about 20 years ago, some researchers have demonstrated that human neural stem cells or other kinds of stem cell transplantation can improve the functional recovery in animal model. And they also show that neural stem cell can home after intravenous injection, can home toward perihematoma area. And this homing neural stem cell can differentiate into neuron and astrocyte. And Dr. Huang Bohao, who is sitting here, sitting there, okay, recently already published 2 important articles. The first one is over here. They show that early intraventricular MSC, mesenchymal stem cell treatment, can improve post-ICH functional outcome via different mechanisms, including enhancement of endogenous neurogenesis and reduction of post-ICH inflammation. And in the second article, they also show that early intracerebral mesenchymal stem cell treatment can also reduce perihematoma edema and also reduce the microglial activation using MRI study, PET study, and also immunohistochemistry respectively. And here is a summary of current available animal model data. It is a meta-analysis of stem cell therapy. You can see that after stem cell treatment, the treatment is associated with better functional outcome and less tissue loss after ICH across different treatment methods, including intraarterial, intravenous, or intracerebral ventricular injection, and across different treatment time. And now we already know that intracerebral hemorrhage may increase the neuroinflammation, increase the neuronal apoptosis, but they also increase the neurogenesis, angiogenesis, and oligodendrogenesis. And when we do the stem cell therapy, the stem cell can release some factor to reduce the neuroinflammation, anti-apoptosis, and more enhance the neurogenesis angiogenesis. So we know that there are multiple therapeutic mechanisms of stem cell therapy in ICH, including neurotrophy, anti-apoptosis, promotion of neurogenesis, angiogenesis, and also immunomodulation. But there is still some challenge, because if we try to inject this stem cell into the cavity of the hematoma, this stem cell will embed in a very tough microenvironment. For example, the cavity will have some mass effect. There will be oxidative stress. There are some hemoglobin and iron over there, and hypoxia. So we still need some clinical trial to demonstrate the effect of stem cell therapy in ICH. And now, here is a summary of some already published articles of clinical trials about stem cell therapy in ICH. There are 7 articles over here, which are published from 2013 to 2020. And most of them are published in China, by Chinese group. And the number of the patients in the study group range from 1 to 60. And the timing of treatment range from 5 days to more than 1 year after ICH. Some of them use the autologous bone marrow stem cells, and some of them use the allogenic umbilical cord mesenchymal stem cells using different cell dosage with a different route. And finally, you can see that all of them demonstrate the safety of the stem cell therapy. And most of them show the improvement of the functional outcome. But you can see here, only 3 of them belong to the control trial. And some of them are just single case report or the case series. And here I would like to focus on 2 of them, the first 2 of them. The first one is a prospective non-randomized control trial. All of the patients will receive the surgical intervention on the first day after ICH, and on 5th day, they will receive or not receive the stem cell therapy with intracerebral injection to the cavity. And they found that early autologous bone marrow mesenchymal stem cell implantation can reduce the neurological impairment and improve the activities of daily living in a selected group of ICH patients. And the second one is a retrospective study in acute ICH without or with different kind of stem cell therapy. But all of them will receive the surgical intervention. And they conclude that stem cell therapy is safe and effective in ICH patients. And interesting, they also demonstrate that autologous umbilical cord mesenchymal stem cell therapy is better than autologous bone marrow mesenchymal stem cells by the functional assessment and also neuroimaging follow-up. And here is a list of some ongoing clinical trials regarding stem cell therapy in ICH. Among them, only 1 study belonged to randomized controlled trial. And all of the study is conducted by either Chinese group or USA group. And the case number range from 9 to 300, with a timing range from 3 days to 5 years after ICH. They may use the autologous bone marrow stem cells or allogenic umbilical cord mesenchymal stem cells using a different kind of treatment route. And about exosome treatment, there is one study using the ICH animal model and demonstrate that intravenous exosome treatment will improve the neurological outcome in this ICH animal model. And regarding the treatment mechanism, they show that single exosome treatment, only single injection, can enhance angiogenesis, neurogenesis, and preserve myelin at post-ICH day 28. And finally, I will try to introduce the roles of endogenous stem cells in ICH. It's not until about 57 years ago we start to know that there is the neurogenesis in the adult brain. And now we know that this adult endogenous neurogenesis are located at the subventricular zone of the periventricular area and also subgranular zone of the hippocampus. In a normal situation, this red neural stem cell located at the subventricular zone. And if there is a stroke, then these stem cells will highly proliferate, migrate to the stroke area, and differentiate to different kinds of cells, including neuron. And studies show that ablation of these endogenous neural stem cells will cause poor motor function and larger infravolume. It indicates that this endogenous neural stem cells is functional when you have the different kinds of injury. And this is our data. We show that we confirm there is numerous proliferating cells in the infrabrain of the rats. And how about human? This study tried to analyze the postmortem brain from an 87-year-old man with right middle cerebral artery infarction. And they demonstrate the proliferating cells and neural stem cells in the infarcted brain. So for me and for your brain, there are already some endogenous adult neural stem cells in it. But until now, we did not know the significance of these endogenous neural stem cells in the brain of the human brain. So we try to do a study using CSF to investigate the post-stroke neurogenesis. We have the patients, so we have the clinical data. And theoretically, after stroke, the stroke will induce the release of some good factor which will diffuse to the subventricular zone to trigger more neurogenesis. And this kind of factor may also appear in the CSF. So we also try to collect the CSF, and we also try to culture the red neural stem cells. And finally, treat these neural stem cells with human CSF. And we will try to analyze the effect of this CSF on proliferation, differentiation of these cultured neural stem cells. And finally, correlate this effect to the clinical data. And first, we use before we try to investigate this kind of study in a human being, we first generate a SH rat animal model to see the feasibility of this kind of study. And we first find that the post-SH, there is post-SH neurogenesis in subventricular zone of this SH animal model over here. And then we collect the CSF from this SH rat and treat the cultured neural stem cells using this CSF. And we found that post-SH CSF can increase the neurogenesis of these cultured neural stem cells. And then we move into the patients. We collect the CSF from 36 SH patients and found that post-SH CSF, the human CSF, can enhance the red neural stem cell proliferation. And this kind of proliferation was correlated with SH volume. And more importantly, the proliferation promoting capacity of post-SH CSF is correlated with clinical outcome. So we, in the first time, indirectly confirmed that the neurogenesis in the brain is associated with clinical outcome of human. And now we already know that some growth factor, small molecules, and proteins has a capacity to enhance the neurogenesis, endogenous neurogenesis, and angiogenesis. So maybe a certain factor may be useful in the future stroke treatment. For example, study has shown that post-ICH statin treatment can benefit ICH rate, partially via neurogenesis. You can see here, functional outcome is good, and there is enhancement of neurogenesis after statin treatment. And for human study, these two articles demonstrate that statin treatment is associated with post-ICH outcome. It's a story about minocycline. This drug can also promote the post-ICH neurogenesis and then associated with good functional outcome. Until now, there is only 2 small clinical studies using minocycline after ICH. You can see that there is no significant difference, but the number is very small, and there is a trend toward better functional outcome. So the final conclusion still need further study to confirm. In addition to stem cells, some studies try to use a hydrogel-based therapy. Hydrogel is a biocompatible material that forms matrix for cell infiltration and adhesion to facilitate tissue repair after stroke. So you can inject the hydrogel into the cavity with some good factor. For example, this study showed a high neurogenesis under galectin hydrogel with epidermal growth factor. And this kind of treatment is associated with better outcome. So finally, we know that to enhance the endogenous neurogenesis can improve the post-ischemic stroke or ICH outcome. So is it possible for us just enhancing neurogenesis instead of cell transplantation? In this old review article, the authors ask that, are exogenous stem cells really necessary? And in 2022, I would like to say that we should try to enhance the neurogenesis with combination of cell transplantation. Now we can do the cell transplantation with the cell under some genetic engineering to produce more amount of this growth factor. So maybe with this kind of combination, with single injection, we can get additive effect. Of course, we still need some effort for optimization of this kind of therapy. So in summary, stem cell therapy shows consistent benefits in acute ischemic stroke preclinically. And clinical trials, including phase 3 clinical trial, will potentially demonstrate the usefulness of the novel therapy. And for ICH, preclinical study also showed a significant benefit, and clinical trials are still at early stage. And not forget that endogenous neurogenesis may be an attractive therapeutic target for stroke treatment. And it's a Japanese noodle called ramen. And if you look into this photo, you will find that it's a coronal section of the brain. And this one is a stem cells with the nucleus over here. And the stem cell can release some exosome with some growth factor to treat the stroke patient. Thank you very much.
Thank you, Li Kai. Thank you for very exciting progress in stem cell therapy in stroke. We welcome questions from the audience. please.
Thank you, Professor Tsai. It's a very inspiring lecture and presentation. And my question is that for us, we are neurosurgeons, so our clinical treatment of the patient for some intraventricular hemorrhage, when they present with some hydrocephalus, we always use some CS drainage. So if for your study, we found that CSF have some neurogenesis effect on such kind of cerebral vessels or some neurogenesis. So if we drainage the CSF, will they decrease the effect of neurogenesis in patients? Could you please comment? Thank you.
Okay, thanks for your question, and that's an interesting point. Actually, I did not think about that. In our previous study, I did not mention about that. We found that the good factor include the BDNF. And the BDNF in the CSF after stroke can induce the proliferation, migration, and the differentiation of the neural stem cells. But I think that to drain out the CSF for the patient after stroke is still important because that is life-saving. But is this kind of removal of CSF is damage? I still did not have any data. Okay.
The second question is that when your study found that CSF have some effect on neurogenesis, for such kind furthermore dissection, the mechanism, do you think exosome or some molecule such as BDNF or something will have better important role in neurogenesis? Could you please comment? Thank you.
You mean that exosome from stem cells?
Maybe something within the CSF. So is there any study proven that some exosome in the CSF have some effect on neurogenesis? Thank you.
Okay, thank you. In the previous study about exosome, they tried to do the stem cell culture and isolate the stem cells from the culture medium. And as I know, there is still no any study try to see whether there is any exosome in the CSF which is produced from the endogenous stem cells. So maybe it's also a good approach for future study.
Thank you.
Yes, Professor Gao.
Thank you, Professor. It's a very exciting lecture. And I want the question. You have already mentioned the continuous intravenous injection of stem cells and also the intracavity injection of stem cells all show some benefit. But do you suggest, because we are neurosurgeons, we have chance to do the evacuation of hematoma, so we can immediately injection the stem cell, and then the patient post-operative continue intravenous stem cell therapy. These two kind of treatment is more beneficial, or just only the simple IV stem cell injection? Thank you.
Okay, it's very sensitive question. It's a very difficult to answer until now. And for patient with ischemic stroke, we will prefer to use the intravenous injection because it's very hard to create a hole for intracerebral injection. And actually, in a past study, they already show that the mechanism of stem cell therapy in ischemic stroke is not cell replacement. So we don't need to inject the stem cell into the brain for them to differentiate into neuron. So until now, the major of the clinical trial in ischemic stroke is using the intravenous injection, including, I just mentioned that our hospital just participated into a phase 3 clinical trial. And in that trial, we just do the likely blood infusion of these stem cells into the venous bloodstream. But for ICH, it's a different story. because some or most of the patients with ICH will receive the surgical intervention. So we have a direct route for stem cell inoculation. So it will open another possibility for direct injection of the stem cell. And if you use an allogeneic stem cell, you can just inject the stem cells after your surgical procedure. But we should think about that. In the brain, after you do the surgery, the environment is very tough. Okay, so maybe the timing is still need to study. Maybe after surgery, you can wait for 1 to 2 days or some hours to have less tough microenvironment. But I cannot say more because I did not have more data about this kind of consideration. And in addition, as I know, there will be a phase 1 study try to see whether there is any effect of stem cell therapy in ICH using the intravenous injection. It is based on, actually for ICH, it's also a little bit impossible for the stem cell to differentiate into neuron and have the cell replacement effect. So the optimization of this kind of stem cell therapy in ICH still need to be compared.
Yes, please. Perhaps the last question.
Yeah, Professor Tsai, very enjoy your talk. And just follow the Professor Gao's question. If you inject the stem cell into the clot, it's maybe blocked by the clot. So most of the rescue area is a pre-neural area, not the cause of the infection or hematoma. So I suggest after removed hematoma, then injection the stem cell. And my question is, where the stem cell go after the treatment? They direct to neuron or glial cell or oligocyte. Okay. You can tell where the stem cell go.
Okay, thank you for your important question. In our data, we try to use the intravenous mesenchymal stem cell injection for the rodent of ischemic stroke. And we found that after intravenous injection, a little amount of stem cell will cross the blood-brain barrier into the infarcted brain. But actually, I did not find any neuron or neuronal differentiation of these stem cells. The origin of these stem cells are bone marrow mesenchymal stem cells. On the other hand, most of the mesenchymal stem cells are still mesenchymal stem cells. But they indeed have some treatment effect with the improvement of the motor function. So it is consistent result that stem cell treatment in ischemic stroke is mainly contribute to some maybe paracrine effect. They release some good thing to promote the anti-inflammatory effect, anti-apoptotic effect, and extra. So for the fate of these stem cells, I think that stem cell will be the original stem cells, and they will stay for maybe a few weeks, and they die. But they already do some good things, maybe mainly by paracrine effect.
Yeah, 10 years ago, we have experiments on the ischemic stroke rate. We treated stem cell from the intravenous. Then we trace the stem cell with the CM-DI. So we can follow the stem cell later. Then we sacrifice the rate 1 week, 2 weeks, and 1 month later. And we can find that the CM-DI stem cell go into the pre-neural area of the ischemia stroke. And they enhance the gyrogenesis. So there are a lot of the a glial cell. Then the glial cell can protect the brain and secreting some neuroprotective factor and enhance the recovery of the prelingual area. And after 1 month later, the CMDI stem cell disappear, and the glial cell also disappear. But clinically, the rate is better, recovery of the motor. So in the treatment of ischemic stroke now, not only use stem cell, but use exosome or some growth factor to treat the ischemia stroke.
Okay.
Thank you.
So it's a consistent result. Thank you.
Because of the time limit, on behalf of the society, I would like to present you the acknowledgement. And thank you for your attendance. You'll find the lunchbox at the back of the room. Thank you.
进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种， 若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症。因肿瘤或颅内出血，使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病，建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的寂寞腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防哦，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制三高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些比如说记忆力减退，这种记忆力减退通常指的是最近的事情记不清楚，可是远的事情他可能反而记得很清楚，或者是大小便没有办法控制，或者是走路步态不稳，有这3种状况的时候，那必须立即找神经外科或神经内科的专科医师，赶快加以诊疗，赶快去处理，看看到底是不是有水脑症的状况。那如果不幸真的是有水脑症的状况，那必须要赶快处理，来减少将来后续的一些问题，比如说失智啊，或者造成一些残障或失能的状况。
进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种。若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症；因肿瘤或颅内出血使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病，建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的寂寞腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防哦，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制3高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些比如说记忆力减退，这种记忆力减退通常指的是最近的事情记不清楚，可是远的事情他可能反而记得很清楚，或者是大小便没有办法控制，或者是走路步态不稳，有这3种状况的时候，那必须立即找神经外科或神经内科的专科医师赶快加以诊疗，赶快去处理，看看到底是不是有水脑症的状况。那如果不幸真的是有水脑症的状况，那必须要赶快处理，来减少将来后续的一些问题，比如说失智啊，或者造成一些残障或失能的状况。
位午安，我们的会议即将在1分钟后开始，还请尽速就座。Welcome back, everyone. Let's start our next session. And let's welcome Professor Gao to start our session.
Good afternoon, and it's my honor to introduce the distinguished speaker from Beijing, mainland China, Professor Chen Xiaorui. Professor Chen Xiaorui graduated from Sun Yat-sen University of Medical School in 1996. Currently, he is the Vice Director, Department of Neurosurgery, First Medical Center of Chinese PLA General Hospital, Beijing. Today, he will give us a very interesting lecture. MIS-ICH treatment in China, leveraging devices, workflows, and technologies to improve patient outcome. Let us welcome Professor Chen Xiaorui.
Thank you very much, dear Chairman. Dear Professor Gao, dear Chairman, dear friends, today it is truly my honor to be here and share with you our experiences for the treatment of the intracranial hematoma. My topic today is minimally invasive surgery for the treatment of the intracerebral hematoma in China, leveraging devices, workflows, technologies to improve patient outcome. So as we know, the intracerebral hematoma, a major part of the stroke, is a big burden in China. According to the data published in circulation in 2017, China maybe has the most biggest social burden suffering from the stroke. Mainly, the majority of the stroke patients are suffering from the intracranial or intracerebral hematoma. So from several years ago, we started our study for the minimally invasive surgery for the treatment of the intracerebral hemorrhage. And we published our protocol for our trial on the website of the clinicaltrials.gov. And it is a RCT, a multi-center RCT trial to evaluate the outcome of the patient who had the craniotomy and minimally invasive surgery, including endoscopic hematoma evacuation and catheter insertion for the drainage of the hematoma. And we have already finished our enrollment and the data collection at the end of the last year. So far, we are still analyzing the data, and hopefully we will have final results at the end of this year. So today I will present our works in the past almost more than 10 years in the following 4 parts. Number one is the devices including the endoscopic port design, the drill design, and the cautery improvement. And so the second is the workflow of our technique, mainly the endoscopic surgery technique. And the third is technologies we developed dedicated for this minimally invasive surgery for ICH, including the navigation and the hemostasis. And the final part is auxiliary measure for the management of such kind of patient. So first, I want to introduce you the endoscopic port that we used for our study. This port was designed by our team, and we're still holding the Chinese patent for this port. So the port has different lengths, which can adapt into different procedures, including the ICH, the intracerebral hematoma evacuation, or the intraventricular tumor resection, or the intraparenchymal lesion resection. And it has a transparent sheath. And it can be held with a Lila retractor, with a standard Lila retractor. That's a major improvement, confirming if we considering the previously commercially available port system. So this video demonstrated how we insert the port system. First, we insert the introducer into the brain, and after we remove partial removal of the hematoma, we confirm that the positioning is right, and then we insert the sheath from outside the introducer. So after the insertion, we can fix the sheath with a traditional or standard Lila retractor holding system. So this is a picture of the port system that we developed in several years ago. Actually, we had this Chinese patent from 2012, and it has different lenses for different procedures. This is introducer. The diameter of the working sheath is only 2 centimeters, which is quite small. And so in a staged dilation of the brain or the trajectory, we can avoid the contusion to the surrounding brain tissue. And next, I will show you the workflow with an illustrative case. This is a 65-year-old male suffered from, obviously, intracerebral hematoma located in the right basal ganglia, which is also a very common situation. And the patient suffered from coma and left hemiparesis. And another situation, which is also very common now in China, is the patient is taking aspirin daily, in a daily basis. So our workflow are as follows. First, the preoperative management. We will transfuse 1 unit of the platelet as well as DDAVP to try to convert the effect of the platelet to convert the effect of the aspirin. And then next, we will perform the three-dimensional volume assessment of the hematoma for the patient, so that we can have a very quantitative and very reliable preoperative hematoma volume for the future for the following study. And we will have we will show you the positioning, incision, and the bone flap design of the patient. And intraoperatively, we will show you the hemostasis and how we close the wound for the closure. And post-operative evaluation and management are also very important. I will show you step by step. So first, we import the CT data into an open source software, which is called the 3D Slicer. It's free, and it can run at it can be run and on standard PC personal computer, which is very convenient and very cheap. And you can see the CT data here. Next, we will perform the hematoma segmentation with this software. In this way, we can perform the hematoma segmentation on every slice that the patient have been scanned with a CT. And next, we will perform the 3D modeling of the hematoma. And finally, we will have the 3D volume assessment of the hematoma. Here, we can see the patient's hematoma volume is about 57 milliliter. In this way, we can have a very reliable and very quantitative assessment of the hematoma. The details are, we published this technical details on stroke in 2014. If you are interested, you can check our paper. And next is a positioning and the incision. The patient was positioned in a supine positioning way, and we have the incision is a linear incision with a length of 4 centimeter. And the bone flap is like this. We designed one very special dedicated circle drill for this procedure. And next I will show you. The bone flap has a diameter of only 2.3 centimeter, which is very, very small. And the round shape makes the closure very easy, and watertight closure can be achieved. So this is a video, intraoperative video. We can see from our sheaths, from our transparent sheaths, you can see clearly the boundary between the normal brain tissue, which is white, and the hematoma, which is black or dark blue here. So intraoperatively, we can use a suction or the forceps special design bayonet-like forceps to take out the hematoma. And when we evacuated the hematoma, when the normal brain tissue is exposed, then we need to be manipulated. We need to be gentle and to avoid the contusion to the surrounding brain tissue. So the hemostasis can be done with this suction tube with a monopolar cautery. So for big hematoma, when we evacuate the hematoma inside the sheath, we can just pivot the sheath so that the sheath can aim to different part of the hematoma, and so that we can evacuate the hematoma. And usually we start to evacuate the hematoma from the depths from a deep part. And after the evacuation of this part, we can just gently withdraw the port so that the surrounding hematoma can be squeezed into the surgical field and to be evacuated for later. So for the closure, we always perform the watertight closure for the dura, and then we put back the bone flap made by our circuit drill and fix the bone flap. In this way, you can achieve a watertight closure. So in the past 12 years, when we started our business, we have got no case suffering from the post-operative CSF leak or the following infection. So post-operative evaluation is also very important. This is day one CT follow-up scan image. You can see we have already evacuated most part of the hematoma, but how much is clearance rate? We need a quantitative data for this procedure. So we can re-import the data, the post-operative data into our open source software, and we can perform the segmentation and the hematoma 3D modeling and the volume assessment again. So the post-operative hematoma volume is only 1 milliliter. So it makes our hematoma clearance rate like this 98.3%. So in this way, we have a very reliable and quantitative rate of the hematoma clearance rate. It is very helpful for us to perform a multi-center study all over China. So far we have already got 22 centers all over China to enroll in our study. All of them use the same workflow so that we can have a very reliable and very scientific data. So the post-operative course was uneventful and no neurological deficit was found. And we always ask a patient to have the rehabilitation and the hyperbaric and acupuncture therapy after the surgery. And this patient fully recovered 3 months after surgery. So before we use a minimally invasive surgery, we use a craniotomy for such kind of patients. And most of them do not have such a good outcome after the surgery. So the minimally invasive surgery is very helpful for the preservation of the patient function. So we published our the case control study in JNS, Journal of Neurosurgery, and World Neurosurgery. And it is very interesting that these two papers, these two studies is coming from 2 campuses of our hospital. One is in Beijing and one is in Sanya, Hainan Island. So one is in North China, one is in South China. And we use the same workflow. And we have got very similar results. So it is very interesting that in 2 groups, which representative North Chinese people and South Chinese people, we got similar result, which means the workflow is quite easy to be copied and quite easy to be replicated. So for the technologies, the major technologies, the first one is navigation. We tried to use a standard neural navigation for the hematoma evacuation, but the navigation system is too bulky and expensive. It cannot be easily replicated in China. So we sought to develop some easy to use and low cost system. We tried to develop a smartphone guided insertion of the introducer and the port. We use a smartphone and use a gyroscope embedded in the smartphone to guide the insertion of the introducer. We published this study in 2014 in neurosurgery. In this way, in this case, we use the iPod. Of course, you can also use the iPhone or other smartphone as long as it has a gyroscope inside. And later we developed the dedicated gyroscope. It's a prototype in this small white box. The gyroscope can transmit the angle of the introducer to the nearby PC or iPad so that we can guide our insertion of the introducer and followed by the insertion of the working sheaths, which is the most important part for the navigation in our endoscopic port surgery. And for other case, which is not has not so such precision requirements for the procedure, we developed this AR augmented reality positioning with iPhone. We published this paper in 2016 in World Neurosurgery, which is use both the camera of the iPhone and the data we acquired preoperatively with CT and to perform as augmented reality image projection of the hematoma onto the patient's head so that we can make certain how we can insert the introducer. For Android phone users, we also developed a way for the augmented reality positioning. We published this paper in 2017 in Journal of Neurosurgery. We use an app called Sina to overlay the image of the hematoma onto the patient's head for the guidance of the insertion of the introducer and the port. And later, we developed a wearable mixed reality navigation. We used the HoloLens, which was the hardware was developed by Microsoft, but we developed the software. We published this paper, this study last year in neurosurgical focus. So with this wearable mixed reality device, you can see the holographic image of the image, even with the insertion trajectory on the patient head. This is for catheter insertion. And we also have ways to use this mixed reality device for the guidance of for the craniotomy. This is a hematoma which was enrolled into the craniotomy group or cohort for our RCT study. And we have another technology for the guidance of the insertion and the intraoperative quality control for the hematoma evacuation, which is the intraoperative ultrasound. This is a whole solution for the ultrasound with the navigation system. And we can see this is a case that we used the ultrasound to assist for the hematoma evacuation. You can see clearly the shape of a basal ganglia hematoma, typically the like a kidney shaped hematoma. And for this intraoperative ultrasound, we have a special probe, special transducer that you can use with a very small diameter. It's about 1 centimeter. And we can insert this into our port system to get a real intraoperative, intraport ultrasound image of the hematoma evacuation. This is a 46-year-old male suffered from the intracerebral hematoma. And we again use a circle drill. You can see the circle drill can make a bone flap with only a diameter of 2.3 to 2.5 centimeter. This is an intraoperative ultrasound. And this is an intraoperative hematoma evacuation. because the time is limited, I will not show you the video. And this is an intraoperative ultrasound image. You can see clearly the sheath here, the port, working sheath of the port system here. And this is a hematoma. This is after the hematoma evacuation. We can see the hematoma has already been completely evacuated. So in this way, we have a low-cost intraoperative imaging way to confirm the evacuation clearance rate or the evacuation rate. And the closure again. The post-operative, 6 hours post-operative, after the surgery, we performed the control CT, which confirmed the complete evacuation of the hematoma. Post-operative day 10, the patient was discharged and with all the neurological function intact. So post-operative auxiliary measure is mainly the complication management, including the major part includes the hydrocephalus management and the cranioplasty. And we also always refer the patient for the rehabilitation, the hyperbaric therapy, and the acupuncture of the Chinese traditional medicine. They are very helpful for the auxiliary measure. So for the patient suffered from persistent vegetative state, we tried to do the dorsal column stimulation for the recovery of the consciousness. So this is another case as a 62-year-old male suffered from the hypertensive intracerebral hematoma. And in other institutes, the doctors performed the hematoma evacuation as well as the decompressive craniotomy. And unfortunately, the patient is still remain coma state and persistent vegetative state in the even 19 months after the surgery. The patient suffered from hydrocephalus and bone defect for the decompressive craniotomy after, and the persistent vegetative state. So we performed the VP shunt first, then the cranioplasty 1 week after shunt, and the DCS, the dorsal column stimulation. We inserted the electrode at the spinal cord and epidural space of the spinal cord and performed the DCS stimulation. And the patient got consciousness improved 1 month after the surgery. But still, we are still observing this patient, and the is still not fully alert so far. So summary. The minimally invasive surgery for the treatment of the intracerebral hematoma is technically feasible. And we want to offer the patient a whole package solution, including offer not only the patient, but also our colleagues and other medical centers a whole package solution, including the devices, workflows, technologies, and auxiliary management. Actually, this protocol has already been being included into a standard resident training program in China for the endoscopic intracerebral hematoma evacuation, and we want to replicate our whole package solution in more centers in China. And the whole study, in the past 12 years, has leveraged devices, workflows, technologies, and the patient outcome improvement in China. So although we have already got very promising results, we still need higher level evidence to evaluate the real role of the minimally invasive surgery for the treatment of the ICH. So I also invite you guys to participate into our study and to make progress and to make improvements for the patient suffering from the ICH, because it is really a big issue in China. So thank you very much. Thank you.
Thank you very much, Professor Tan. It's a very exciting and interesting speech. Is there any question from the floor?
Thank you for your very inspiring speech. And regarding to the post-operative improvement of neurologic function, in your slides, you show that hyperbaric oxygen therapy and acupuncture. So in general, for your patients, your starting time for hyperbaric oxygen is starting from post-operative day 7, or when did you start it?
That's a great question. Thank you very much for asking. So the time for acupuncture, actually we started, if possible, we will start it as early as 3 days after surgery when the patient is stable. Because for the acupuncture, our physicians, our therapists can come to the bedside and perform the acupuncture. That's a big advantage because it's easy to use and easy to deploy. For hyperbaric therapy, it's a little bit complicated because we need to transfer the patient to another department. So usually we will start the therapy 1 week after the surgery, if possible. Thank you very much.
Thank you.
Any question, Dr. Chen?
Thank you for your comprehensive introduction. In your workflow, may I ask you, when do you, what's the surgical timing? I mean, the patient arrived at the emergency department. When do you start the operation immediately or just waiting? This is question one. Another question is for breathing tendency. Some patients have liver cirrhosis or uremia, you got the hemodialysis. This patient is coagulation is very difficult for intra-operation. So may I ask you, did you perform this patient or any coagulation method in your operation? Thank you.
Well, that's also a great question. Thank you for asking. So for the first question, that's time. When should we start our surgery? It's still controversial globally. So some studies suggest that we should avoid to perform surgery 6 hours within 6 hours after the hemorrhage or after the ictal. So after the stroke. So we tried to perform study for the time, for the best time that we should conduct the surgery. But unfortunately, so far, because efficiency in the ER part and other factors, that we seldom can get patients within 6 hours of after the stroke. So that's a big problem. So that's after we conducted our RCT trial, we want to enroll. We totally enrolled 1,350 cases of the patients. So among them, some in other centers, basically, especially in some small centers, because they have high efficiency. So maybe we can get the patients within 6 hours. So that we are still analyzing the data acquired for this kind of cases. Hopefully, we will publish our data by the end of this year. So please, and so also please just I want to also invite you, if you have this kind of case, which can go to your hands rapidly within 6 hours, I want to invite you to participate into our study, and we can together analyze this interesting interesting situation. So after 6 hours, usually most of our cases are after 6 hours, and traditionally it is considered to be safe to conduct the surgery. The second question is very important. The drugs that patient take to anticoagulation medicine is a big problem in China now. Usually, for the patient taking only one kind of anticoagulation drug, like aspirin, it is not a problem. We can use the platelet and the DDAVP to try to convert the effect of the aspirin. But for patient taking two kinds of the drugs or medicine at the same time, or for patients suffering from other situation, like you said, the hepatic cirrhosis or the kidney failure, this kind of patient is a big issue. So today, because the time is limited, so I do not have chance to introduce you our catheter insertion technique for the minimally invasive surgery treatment of the ICH. And in recent years, from 2 years ago, we use the electromagnetic navigation guided catheter insertion for this kind of patient who has very severe coagulation dysfunction. So it's very effective. So on the contrary, to our traditional concept, this kind of catheter insertion is very effective and doing well with this patient suffering from severe coagulation dysfunction. And in this kind of case, usually we can drain the hematoma within 5 days and remove the catheter and got lower infection rate. So we are still doing quantitative and data analysis for this kind of case. It's very interesting. So for this kind of case that you mentioned in your second question, I strongly recommend that you do not use the endoscopic or the craniotomy surgery, but to use the catheter insertion. But to use the image-guided catheter insertion to acquire high efficiency for the drainage of the hematoma so that you can remove the catheter within 5 days after the surgery. Thank you very much.
Thank you. Any other question? Okay. And so we could close this session. Thank you, Professor Chen.
Thank you.
Very
The honor
nice.
is mine. Thank you very much.
Hope to see you in the near future. Okay.
Thank you.
Thank you, Professor Gao. Let's welcome our next moderator, Dr. Chen Jingchang, to lead this session.
Okay. And I just informed I have to use English just now. Okay. Professor Liu is a director of neurocritical care in Tri-Service General Hospital, Taiwan, Taipei. Recently, the Taiwan Stroke Society, Taiwan 中风医学会, invited Professor Liu, Professor Huang Bohao, and also me to organize a small community about the ICH guideline of Taiwan. So today, Professor Liu will introduce us about this program and the progress schedule about Taiwanese guideline of ICH surgical treatment.
Because this is a Taiwanese guideline, so if Professor Liu, you want to use Mandarin, I think this will be allowed. Or maybe you can use Chinese, Mandarin, Chinese, or Taiwanese will be better. Okay, let's welcome Professor Liu.
Thanks for Professor Chen's introduction. Good afternoon, ladies and gentlemen. Today I want to present the topic of Taiwanese guideline of surgical ICH treatment. The paper is published in 2009 Lancet Neurology. ICH is a global problem. In USA, ICH presents 15% of all stroke. And in Asia Pacific, ICH presents higher incidence, about 35 to 45% of all stroke. The paper is published in 2003 Stroke. The article is about international variant in surgical practice for spontaneous ICH. The paper showed operation rate varied globally from 2 to 74%. However, Asia Pacific is higher operation rate, about 30 to 40%. Treatment landscape in Asia Pacific, in Taiwan, Japan, Korea, China, the treatment has craniotomy, stereotactic, and endoscopic. In UK, non-operative craniotomy. In USA, MIST, minimal invasive, and endoscopic. The background surgery for ICH. Number one, minimal invasive means, for example, stereotactic drainage with or without thrombolysis, endoscopic assisted, endoprod assisted. Number two, craniotomy and decompression craniotomy. The left side is minimal invasive procedure, and the right side is craniotomy and craniotomy. The surgical methods for ICH, reload, and the trials. The stereotactic drainage plus thrombolysis, we call MIST technique. The size of endoscopic size is 6.5 millimeter, and 54% blood clot was removed. The endoscopic assisted size is 12 millimeter, and 90% blood clot was removed. Endopro assisted size is 30.5 millimeter, and over 50 blood clot was evacuation in 75% case. Right side craniotomy and craniotomy, it has large size, about 30 millimeters. The paper is published in 2015, Stroke, AHA ASA guideline for the management of spontaneous ICH hemorrhage. In the guidelines, ICP monitor and the treatment recommendation, every neurosurgeon very clear know this, but I repeated the guideline. Number one, ventricular drainage as the treatment for hydrocephalus is reasonable, especially in decreased level of consciousness. Number two, patients with GCS score less than 8 points, those with clinical evidence of transtentorial herniation, or those with significant IBH or hydrocephalus may be considered for ICP monitor and treatment. CPP of 50 to 70 millimeter of mucus may be reasonable to maintain depending on the status of cerebral autoregulation. Number three, corticosteroids should not be administration for treatment of elevate ICP in ICH. IBH recommendation. Number one, IBH so in intravascular administration of RTPA in IBH appear have a fair low complication rate, and the efficiency and the safety of this treatment is uncertain. The efficiency of endoscopic treatment of IBH is uncertain. The surgical treatment of ICH, number five, decompression craniotomy with or without hematoma evacuation might reduce mortality for patients with supratentorial ICH. In a patient with coma, large hematoma, significant midnight shift, and elevated ICP referred to medical treatment. Number six, the efficiency of minimal invasive clot evacuation with stereotactic or endoscopic aspiration with or without thrombolysis usage is uncertain. Right side, timing of surgery. Ultra's early craniotomy within 4 hours was associated with increased risk of rebleeding rate in the study. About 24 patients. The paper is the right side. This is Parman paper. Rebleeding leads to poor outcome in ultra early craniotomy for ICH. Shift in the guideline. The guideline is about AHA-ASS guideline. In 1999, craniotomy has been the standard approach for remove ICH. In 2010, the effectiveness of minimal invasive clot evacuation alternate either stereotactic or endoscopic aspiration with or without thrombolytic usage is uncertain. In 2015, the effectiveness of minimal invasive blood clot evacuation or with stereotactic or endoscopic aspiration with or without thrombolytic usage is uncertain. This paper is published in 2019. The article is about efficiency and the safety of minimal invasive surgery with thrombolysis in intracerebral hemorrhage evacuation. MISTI 3. The paper showed that for moderate to large intracerebral hemorrhage, MISTI did not improve the proportion of patients who achieve a good response 365 days after ICH. The paper also showed a reduction in blood clot size to 50 milliliter or less is associated with functional improvement. In the table, other parameters, including withdrawal of care, time in ICU, time to return home, ICP events has not significant difference. The paper published in 2012 Stroke, the article about minimal invasive surgery for spontaneous supratentorial ICH, a meta-analysis of randomized control trials. The study including 1,950 patients. The conclusion, the most likely candidate to benefit from this surgery are both sexes, aged from 30 to 80 years with superficial hematoma, Glasgow Coma scale over 9 points, hematoma volume between 25 and 40 milliliters, and within 72 hours after onset of symptoms. Furthermore, the paper published in 2018 Stroke, the article is about minimal invasive for ICH, update meta-analysis of RCT. The results including 2,150 42 patients. The conclusion shows selected patients with supratentorial ICH benefit from MIS over other treatments. The paper also shows MIS within 24 hours is associated with favorable outcome. In a detail, patient underwent MIS surgery evacuation within 24 hours will have a good function independence. Endoscopic surgery was associated good chance to reach functional independence and survivals. The paper is published in 2020 in Neurology. The article is about neurosurgical intervention for supratentorial ICH. The study includes 4,145 patients. The conclusion shows surgical treatment of supratentorial spontaneous ICH may be benefit with minimal invasive procedure and when performed soon after symptom onset. This is Korea ICH guideline on MIS for ICH. New commendation. Number 2, a craniotomy should be considered for a lobar hemorrhage located within 1 centimeter from surface with a conscious level of 9 to 12 on the GCS. Number 3, for supratentorial ICH with GCS score over 9 pointer with hematoma volume between 25 and 40 milliliter within 72 hours after onset symptoms. Minimal invasive surgery to evacuation the hematoma is recommended. The paper is published in 2020. The article is about Chinese Stroke Association guideline for clinical management of cerebral vascular disorder. 2019 update of clinical management of ICH. The paper shows very detailed about ICH with indication for surgical intervention. GCS less than 8 point, consider ICP monitor. In IVH require blood suction, consider injection RTPA according to the guideline. Hydrocephalus and poor conscious consider ventricle puncture and external drainage. Midnight shift and coma due to supratentorial hemorrhage, consider decompression craniotomy. Cerebral hemorrhage lead to deterioration neurological function, consider hematoma remove. Minimal invasive, consider image guide hematoma suction and endoscopic hematoma removal. Cerebral vascular structure abnormal in cerebral hemorrhage, consider the relationship between cerebral hemorrhage and the primary disease individualized. In the guideline about minimal invasive recommendation, number 1, image guide hematoma suction with RTPA may be effective and safe. Number 2, image guide endoscopic removal of hematoma can be effective and safe. Number 3, it is reasonable for different level of medical units to choose operation methods according to the medical facility and the experience of the units. Number 4, in units without image guide hematoma removal technique, it is reasonable for physicians have received professional training to consider standard minimal invasive puncture hematoma evacuation for appropriate patient in ICH. Number 5, for simple basal ganglion hemorrhage, volume about 25 to 40 milliliter, micro-invasive drainage can be effective. About craniotomy operation recommendation. Number 1, for supratentorial ICH, if the patient is coma, midnight shift, elevated ICP due to large hematoma, decomposition craniotomy with or without hematoma removed might reduce the mortality, and the efficiency of early hematoma removal is uncertain. Supratentorial hematoma removal is reasonable for patients with deteriorated condition. For subtentorial ICH, such as cerebellum or brainstem ICH, hematoma removal should be performed as soon as possible in patients with progressive deterioration of neurological function or completion brainstem and or hydrocephalus. EVD alone as the initial treatment is not a recommendation for these patients. About ventricular hematoma, the recommendation is when patients with IVH require intraventricular puncture and external drainage, ejection of RTPM might reduce mortality, but not improve functional prognosis. For intravascular hemorrhage, the efficiency of endoscope is still uncertain. Time to treatment. Time is very important. Early surgery, the data show basic outcome in the minimal invasive for early surgery, and the lower rebleeding rate minimize secondary injury. Surgery after 48 hours may have hard blood clot, may have great brain edema, may need craniotomy or even partial lobotomy. The patient has worse prognosis. No one-size-fits-all solution in surgical treatment of ICH. Our prospective thyroid treatment, we consider if the ICH in the superficial ICH craniotomy is considered, deep location ICH may be considered missed surgery. Early surgery may be considered minimal invasive surgery. Late surgery may be considered decomposition craniotomy. For example, if the ICH about 20 to 80 milliliters, spotted size positive, less than 48 hours, hard clot, we can consider port-based approach. If the ICH more than 4 hours, within 1 centimeter below cortical surface, we can consider craniotomy. If the hematoma over than 48 hours, more than 80 milliliters, severe brain edema, ICP more than 22, ICP more than 2 millimeter of mercury after surgical removal of ICH. This time we can consider the craniotomy. So there are very ongoing trial surgery for ICH. For example, the stereotactic drainage without thrombolysis, MIS-type 1, 2, 3 was done, and the MIS-type 4 is ongoing. Craniotomy also done in stage 1 and 2, decomposition in the switch study. Summary, the time to treatment is very important in surgical treatment in ICH. Ultra-early craniotomy is associated with high rebleeding rate. Ultra-early missed surgery is also associated with low rebleeding rate. Missed surgery is associated with favorable outcome if done with 24 hours. Endoscopic have good functional independence and a good survival. Thyroid treatment is need more study. In 2022, Taiwanese guideline for surgical treatment is ongoing in recent days. Welcome more neurosurgical surgeons to join this work. in the guideline, we have 5 sessions. Surgical ICH is our responsibility. The consensus in the 2022 guideline, number 1, deep ICH may be considered missed surgery. Superficial ICH may be considered craniotomy and craniotomy. Early surgery may be considered missed surgery. Late surgery may be considered craniotomy and decomposition craniotomy. Cerebellar ICH operation as soon as possible if the brainstem compression. IBH with RTBA treatment is uncertain, but this is a temporary consensus, so we need more neurosurgeon can join this work. This work now is ongoing. Thanks for your listening.
Okay, thank you for the speech from the Professor Liu. Is there any question, comment, or suggestion about this topic from the audience?
Thank you for your speech. So I just wonder, from the 2020 Chinese guideline, it mentioned about the infratentorial surgery for cerebellum and the brainstem ICH. So on the slide, it mentioned that brainstem ICH also needs to be treated aggressively from the Chinese guideline.
The guidelines writing brainstem and cerebellum. Maybe in Taiwan guideline we only write cerebellum hemorrhage, not brainstem hemorrhage.
Yes, but in the China guideline they also mention brainstem, right?
Yes.
Yeah. I think it's a very interesting point because I started to see some papers from China, and they do brainstem ICH minimally invasive surgery, very aggressive, but
yes.
Still needs more data, I guess. Thank you very much.
Yes, thank you.
Is there any question? If there are no question, I will end this section. Okay. And I represent the organizer to give Professor Liu the appreciation certificate.
的演讲跟主持，那因为我们的现在演讲提早结束，那我们大家先欢迎到后方先去享用一下我们的茶点。那我们40分的时候再回来继续。 的下场会议即将开始，还请尽速就座。Welcome back, everyone. Let's welcome our moderator, Professor Gao Mingjian, to lead the session.
Okay, we start this session. Okay. I will introduce Dr. Zhu Huizhong. He graduated from National Taiwan University Medical School, and then received neurosurgical training in National Taiwan University Department of Surgery. And he has been as a fellow of the biodesign of Stanford University. Currently, he is the director of Neurological Intensive Care Unit, Shuanghe Hospital. We welcome Dr. Lu.
Good afternoon, ladies and gentlemen, and thank you for the introduction from Professor Gao. And thank you for the society's invitation, especially from the President Zheng and also from Dr. Huang. It's my honor to share some experience about the application of the ROSA in those ICH patients. So my topic will be application of the ROSA for spontaneous ICH aspiration, and also with the thrombolytic catheter placement. For the stroke is the second leading cause of the death worldwide, and the major cause of severe disability in adult. So spontaneous intracerebral hemorrhage accounts for up to 20% of all stroke, and 40% of 30-day mortality. Although the conservative medical management is still the standard treatment for those ICH patients with small hematoma, the patients with residual hematoma, no more than 15 cc after the surgery, are associated with a better functional outcome and survival rates. MISTI-3 study reports that image-guided catheter placement with the thrombolytic irrigation did not improve functional outcomes. But the post-operative ICH patient with those residual hematoma, no more than 50 cc, or the hematoma reduction rate achieved the 70%, had a better functional outcome and survival rate. So in clinical practice, the ROSA stereotactic robotic system has been gradually adapted for electrode placement for SEEG, and the lead implantation for the DBS, and also the LITT in the United States. Two recent studies report the stereotactic advantages for ROSA for the deployment of catheter for the intraparenchymal hematoma was reported. And this study we conducted is aimed to describe our clinical experience and the workflow of ROSA as a safe and effective approach for stereotactic ICH aspiration and the further intraclot catheter placement. So let me introduce some of our material and methods. This is a retrospective study conducted of patients with spontaneous ICH who underwent ROSA-guided ICH aspiration surgery with the intraclavicular catheterization insertion. So the eligible patients were 80 years old of age or older with a spontaneous ICH. The hematoma volume should be greater than 30 cc, unless the surgeon and the evaluating physician agree that the ROSA-guided ICH aspiration surgery was the best approach, considering all the individual's risk. In addition, ICH volume must have remained stable for at least 6 hours after CT diagnosis before doing the ROSA-guided ICH surgery. Patients were excluded from the study if they have the traumatic ICH, brain tumor, vascular malformation, or hemorrhagic transformation of the cerebral infarction, or any other suspected cause of the secondary ICH. Information was obtained regarding the patient's demographic data, comorbidity, medication, GCS score, ICH volume, ICH score, and all the operation details was collected. Also, we will clinically follow up those patients through the radiology and also through the clinical after the operation for 3 months. This is our protocol. In short, this protocol can be divided into 3 parts. The one is the preoperative protocol, and then the intraoperative part, and the last is the postoperative management. So our ROSA-guided ICH surgical technique employed the ROSA-1 brain system to aspirate the ICH, which is divided into preoperative protocol and intraoperative and postoperative, as what I said. And the clinical treatment workflow for ROSA-guided ICH aspiration was illustrated here, but the word is a little too small, so I will introduction in detail later. But first, let's see the preoperative protocol. That would include to control the blood pressure, to correct the coagulopathy, and also to identify the possible cerebral vascular lesion first. And all the patients will underwent the high-resolution, non-contrast brain CAT scan. The slice thickness would be 1.25 millimeter, the 1 day before the ROSA surgery. And the DICOM format image were loaded onto the surgical planning software on the ROSA-1 brain system for the subsequent surgical planning by the surgeon before the operation. So the next, this is the setting of the operation room. This figure shows that the operating room layout for the ROSA ICH surgery. The ROSA machine will stand at the contralateral side of the hematoma. So in this case, the hematoma is in the left side, so the ROSA machine will stand at the right side. And the operator, assistant, and the scrub nurse will stand at the same side of the ICH, that is the left side. And this is the photo, the picture, which was happened in the real world, the OR. The machine was placed superior to the patient's head, with the robotic stand contralateral to the ICH side. So as what I said, at this case, the left side putaminal ICH, so the machine will stand in the right side in order to let the operator to stand in the same side of the ICH. And the head of the patient was fixed by the skull clamp, with the neck of the patient was slightly flexed anteriorly 50 degrees relative to the floor. And the entire cranial stabilization system was connected to the telescope support arm of the ROSA-1 machine. We can see here, maybe I can use the. Okay, just connect it just in the front of the machine. The laser is not working. So the next is the registration part. We use the semi-automatic laser-based facial recognition to do the registration for all the patients. And only the registration error less than 2 millimeter, then we will continue to do this operation. So it's very convenient. You don't need to use the frame first and then to do the image later. We just use the surface marker and use the semi-automatic laser-based recognition to do the registration scene. So we can finish this part of procedure within 5 minutes. And the next is trajectory planning. The trajectory was pre-planned by the surgical planning software and were rechecked by the surgeon after we do the registration on the machine. And the entry point on the skull was identified about 1 to 2 centimeters lateral to the ipsilateral coccus point. And the first target point will be selected to be 5 millimeters shallower from the deepest point of the hematoma. So that's our protocol. And during the procedure, after all the draping and sterilization, we will make a scalp incision, and then we will drill a burr hole, and we will start to cut the dura open and do the hemostasis. An adapter with an internal diameter around 2.5 millimeter was installed onto the ROSA robotic arm. And we also introduced a side-cut biopsy needle, was gently introduced through the adapter and all the way to the originally planned target point. And the side-cut window was first opened to the anterior direction, and then opened toward the lateral, posterior, and medial direction, respectively. The hematoma will gently aspiration twice in each of the 4 directions. That is the anterior, lateral, posterior, and medial. And we use a 5 cc handheld syringe to do this aspiration. After finish this, the robotic arm will then move 5 millimeters back from the first target point along the trajectory. And then the hematoma will again aspirate it twice, respectively, in the 4 directions. So that would be the whole aspiration procedure. And after this aspiration procedure, we will do the intraclot catheter insertion. I also call it the mystic catheter because we are preparing this to do the further thrombolysis work. So after 2 rounds of the aspiration, the rigid biopsy needle was removed, and the adapter of 2.5 millimeter will replace with another larger one, its diameter to 4.0 millimeter. And then we will put a ventricular catheter through this adapter and we will fix the catheter. Will be tunneled subcutaneously and connected to a closing drainage system. So that would be finished this operation. And through the photo, this is all the instrument that we need to use during the operation. So from the left side is the holder, and then it's an adapter with an internal diameter about 2.5 millimeter, and then it's a larger one with a 4.0 millimeter, and then it's a biopsy needle with the diameter about 2.1, so we can easily push and go through the first adapter that is a diameter about 2.5. And then the final one, the ventricular catheter, the outer diameter is 3.5. So we need to change adapter to the 4.0 to make a way to get the ventricular catheter to insert into the clot. So that's all the instrument that we need to use. And brain CT will be performed within 24 hours following the surgery in order to confirm the position of the soft catheter and to calculate the residual volume of the ICH. If the placed catheter does not engage the ICH, the catheter will be removed and may be repositioned. Because due to our very limited numbers, so we didn't encounter this kind of situation yet. And if the remaining volume of the ICH is more than 15 cc, we will apply 1 cc of Artiplace into the catheter to do the thrombolysis in the following 3 days. So in the left side, this is a pre-operation CT. The ICH volume is around 33 cc. In the left side, the ICH volume is around 22. This is the postoperative image. So we aspirate about 11 cc during the operation. And also we checked the catheter was well situated in the clot. So we can start our intraclot thrombolysis protocol at this. The protocol will be after injection of 1 cc Artiplace, followed by 3 cc normal saline. The system will be closed for 1 hour to increase the thrombolytic interaction between the Artiplace and the hematoma. And then the drainage system will reopen for gravitational drainage of the lysis hematoma, as shown in the picture that we use the EVD system to do this drainage monitoring. And the Artiplace administration protocol will then conducted once daily for 3 consecutive days. This is a demonstrated case that the left upper one, that is figure A, is the preoperative image. And figure B is directly postoperative image to check the residual volume and also to check the catheter position. And the C is after the first TPA injection, and figure D is the second TPA injection, and the figure E is after the third TPA injection. And also the catheter was removed after the third injection. And the last one, the figure F, is 3 weeks after the ROSA surgery. We can see the mass effect resolved greatly. And let me introduce more about the procedure, especially about the intracardiac thrombolysis protocol. If the symptomatic rebleeding event occurred, and if the surgical intervention were not indicated, the administration of the antiplatelets was stopped immediately, and the tranexamic acid will be given intravenously. And this scenario actually, because we have a very limited experience, around 7 patients, so we haven't occurred about this kind of situation yet. So maybe if the major rebleeding occurred, maybe not only the tranexamic acid would be used, maybe the surgical operation for the hematoma evacuation would also be applied in the plan. Okay, so let's see the result. We have a total of 7 patients eligible for this ROSA-guided ICH aspiration surgery during the past 6 months. And they were all initially assigned to conservative medical treatment, actually, due to a relatively small hematoma or the unsustainability for the craniotomy. And for the purpose of improving the functional status or the long-term care quality, so those patients received the ROSA-guided ICH aspiration surgery after the careful evaluation of our clinical doctors. And this table 1 will summarize the demographic data. And we can see all the procedures were performed within 1 to 1.5 hours with a minimal perioperative estimated blood loss. Except for the second patient, because it's a special case, the hematoma is very large, and the patient is very old, it's 91-year-old. So the family initially was assigned DNI and do not operation. Yet the patient survived for 7 days. So they are going to consider how to make a good quality of the long-term care. So they decide to receive the trial and to do the minimally invasive clot aspiration. So except this patient number 2 with the excessively large hematoma with the safety concern. The other 6 patients, we successfully reduced the hematoma to a level of less than 15 cc. And the consciousness of all patients improved. No patient suffered from perioperative complication, no required reposition of the catheter. And there were no any postoperative complication, such as the infection or the rebleeding event of those 7 patients. Okay, due to the time limit, so I just skip the illustrative case here. So let's go into the discussion part. Through the trial, it's generally agreed that early hematoma evacuation through the minimally invasive surgery benefit the ICH patients. Why we show water here? Maybe some typo, sorry for that. And so therefore, safe and rapid reduction of the hematoma volume is one of the important steps in the ICH management, especially with those patients who are not suitable for traditional craniotomy, such as an extremely elderly patient or those in poor physical condition patient. And in recent years, the ROSA-assisted brain surgery has been successfully used for the catheter placement. So they can allow in the slow and continuous drainage of the hematoma, rather than directly reduce the volume in a one-time shot. I mean the one-time aspiration or evacuation surgery. So we developed a ROSA-guided hematoma aspiration combined with the subsequent accurate catheter placement to drain the remaining hematoma, so as to directly decompress the hematoma in the first time and then followed by a slowly and gently drainage of the lysis hematoma afterwards. And so the magic number 50 cc, that is concluded from the MISTY Trial 3. Because in the report, they say those patients with the residual hematoma less than 50 cc would have a better functional outcome and survival rate. So in our clinical practice, the ROSA-guided stereotactic ICH aspiration will effectively aspirate those hematoma and to reducing the residual hematoma less than 15 cc. And also we can done this all within 1 to 1.5 hours. So according to the report about the small volume ICH, still it's controversial to do the operation to those small volume ICH patients. But the recent randomized control trial has reported the benefit of craniectomy to reduce the intracranial pressure and the effect of hematoma on surrounding tissue pathology. So through the other trial, we can know that not only the hematoma size is it's an important issue, but also the hematoma will cause the collateral damage to the surrounding brain tissue. So in fact, with the exception of the massive hemorrhage, the conservative medical management still is the standard treatment for most spontaneous ICH patients, with especially those small hematoma volume. But we are now in the MIS, the minimally invasive surgery era. In the past, they think that the craniotomy may be more harmful than beneficial because of the risk of additional brain tissue damage during surgery. But some of the recent randomized study and reviews has already recommended that to use the minimally invasive aspiration instead of a standard craniotomy will have a better outcome with fewer complications. So we want to combine the ROSA with the MISTI-3 trial concept in our trial, benefiting from the stability and stereotactic accuracy of the robotic arm. We can use the ROSA to precisely and accurately do this minimally invasive surgery nowadays. So we combine the ROSA-guided ICH aspiration with the subsequent MISTI thrombolysis-based drainage catheter in one surgery. And the goal is actually the magic number. We want to reduce the hematoma size to less than 50 cc in order to improve the functional outcome and survival rate. And there's something more I want to discuss more deeper. Because the MISTI-3 trial procedure is up to 10 steps. So in order to give the accurate catheter placement for the subsequent intraocular thrombolysis, actually, MISTI-3 trial is a technically challenging thing for all the patients. Based on the interim analysis by Frame and colleague, poor catheter placement rate of the most commonly used trajectory A that I was showed below the figure, just the left side. The trajectory A is due to the puncture and the burr hole on the forehead or the frontal side. And this is the most familiar trajectory for us neurosurgeon, but yet there's still as high as 7% surgical complication or the missing rate. So that means that these 7% of patients are at a high risk of intraoperative brain injury. Just try to think, the 7% of patients, it means that they do the first aspiration in the wrong place, in the wrong site. That may cause the brain injury or even the cerebral vascular damage. So that's a safety issue in the MISTI-3 trial. So in contrast, the ROSA-guided ICH aspiration used in this study can accurately determine the correct hematoma position for 2 rounds of hematoma aspiration and then the intraocular catheter for thrombolysis placement. So I think the ROSA can help. This is because the stable robotic arm of the ROSA brain system, they can steadily hold and guide the operator along the pre-planned trajectory during the operation. So theoretically, this would improve the rate of the suitable catheter positioning and minimize the catheter replacement rate. And indeed, because the robotically placed catheter will properly engage the ICH in this study, so we haven't encountered the patient experience a perioperative complication, especially the rebreathing things or the misposition of the catheter. So the MISTI-3 trial protocol only applied the hematoma aspiration only once. I think it's possibly due to the uncertainty in the catheter location. So another thing is that the MISTI-3 trial protocol mainly used the active place cut irrigation to do the hematoma reduction procedure. So it used the every 8 hours with a maximum of 9 doses of articulate injection. So several times of radiation exposed and several times of the procedure to inject the fluid into the clot. I think that would increase the risk of infection and rebleeding, and also to increase the radiation exposure to those patients. So in our ROSA ICH protocol, we try to decrease this kind of situation. Maybe not this one, sorry. I put the wrong slide in here. This one is the correct one. We limit it to the injection protocol to once to every 24 hours. That means once daily with a maximum of 3 times injection. So that will reduce the procedure, and also we will reduce the infection and radiation exposure to our patient. And also, because of the easily laser semi-automatic registration things, so we don't need to put the frame first and then to do the image. So we will get this procedure sooner than those use the stereotactic frame procedure cases. Okay, it all takes about 15 minutes to do all the registration procedure, and then we can directly go into the surgery. And the error is almost every time less than 2 millimeters. A recent study conducted by Alan and a colleague also find that unlike the other neurosurgical application that may require a higher precision accuracy, because we are doing the hematoma evacuation. So ROSA requires only an accuracy of only about 3.48 millimeters. So it's very enough for us to do this kind of surgery. So in conclusion, we have designed a surgical protocol incorporating the advantage of ROSA-guided stereotactic ICH aspiration. And this approach combines the precise ICH aspiration and also with the accurate intraocular catheter placement for enhanced following drainage scenes. And we also have the modified postoperative management process to reduce the frequent administration of the artiplates and the CT examination. Our experience with this ROSA ICH protocol, I think is safe and effective to reduce the hematoma volume with a satisfactory functional outcome. So we are actually planning on the prospective study to demonstrate the long-term safety and functional outcome of the ROSA-guided ICH aspiration and the thrombolytic catheter placement in ICH patients. And we want to identify more about the risk factor associated with the treatment procedure, and maybe could more affect the functional outcome. And I would like to thank the neurosurgery department, the ROSA team from the Shuanghe Hospital. All the team members work together and we do this kind of design. And also I want to special thank to the neurosurgery division from the National Taiwan University Hospital, Dr. Huang, to have this kind of idea and design of the trial protocol. And this is my presentation. Really thank you for your attention. Hope to collaborate in the future. Thank you.
Thank you, Dr. Lu's very interesting presentation with the ROSA guide aspiration and the placement of the catheter. Any question from the floor? Okay.
Thank you for your comprehensive introduction, ROSA. In your study, I miss it. Your entry point and target point in your ROSA, I think you say you seem to choose one target point, then the aspiration first, then back 5 minutes aspiration 2. So it's also the one target point. I mean, in your ROSA, the protocol, your hematoma target point is 1 or 2. And what is you choose your target point is the hematoma middle or hematoma pre or post or the deep hematoma. This is question 1. Another question is you did not mention your surgical timing. You say you have 91 patient is the family side DNA first, then Rican and aspiration. So what is the actual aspiration timing? Is immediate or after? In your case, it seems 7 days.
Yes.
Yes. Oh, so this is my question. Thank you.
Okay. And thank you for Dr. Chen's question. So there will be 2 questions. Let me answer one by one. The first one is that the target choosing. it's a little confusing because I used twice the 5 millimeter. So we choose the deepest point of the hematoma. That is the fiducial, or maybe you can see that is a marker, the deepest point. And then the deepest mark, shallower 5 millimeter, that is the target point. So we didn't do the deepest one because I think it's very dangerous. So I target the deepest point and then I go back 5 millimeter. So that's the first aspiration point. After the full direction aspiration, I shallow more again, the 5 millimeter and do the second round. So can you understand what I mean? The deepest point is the, don't say target again. How to say that? It's a marker. Just we localize the deepest point first. And then the first target point is the deepest point, shallower 5 millimeter. So that is the first point that we do the aspiration. After that, we withdraw another 5 millimeter to do the second round. So we do 2 times for the full round, full direction.
But the deepest point is in the hematoma middle or hematoma pre or post?
The medially, posteriorly, and the deep, just in the sagittal and the coronal and axial, that's the deepest.
So it's the middle, just the middle.
Yeah, middle. And the second question is about the timing. Actually, we didn't do this as an emergency operation because I think we have to consolidate the safety issue and also the workflow. So I choose those patients is around, if you see from the table 1, I choose the patient is around the hematoma volume around 30 cc because those kind of patient actually is a controversial case to operate or not to operate. So I just do the first CT from the emergency room and then admitted those patients to ICH to control the blood pressure and also to correct the coagulopathy problem if any one of them use the anticoagulant or antiplatelet. And then if the hematoma is stable, we will plan this and explain this. So average, we do this operation about 3 days to 7 days of the ictus of the hemorrhage. So that is our preliminary data due.
线上有一个Professor Chen 从北京he had a question, just showing that please, Dr. Chen, Professor Chen.
Thank you, Chairman. I want to congratulate Dr. Lu for this nice try to use robotic to try to help assist the catheter insertion for the hematoma evacuation. We do have a ROSA several years ago, but the ROSA robotic system is extremely expensive. It costs over $1 million. A ROSA 1, I suppose, will be more expensive, right? So for such a common disease like ICH, in most of the common community hospital or the city-based hospital, the ROSA will be very, very difficult to access. So have you ever considered the accessibility for your technique to be replicated in the future, right? The second thing is the ROSA system is very accurate. It can reach about 1 millimeter. The navigation error can as low as 1 millimeter. But for a catheter insertion for the hematoma evacuation, which is not need to be so accurate, do you think it is a technical overkill for a 1 millimeter when a 3 millimeter error or 4 millimeter error can be acceptable for hematoma, right? So the third thing is I noticed that when you if you want to use ROSA to do the job, you need the general anesthesia, and which means you must come into the operating room. But as we know, the ICH is usually an emergency case. So the patient is in urgent condition. So, I mean, if you use the electromagnetic navigation system, you can easily perform it at bedside in ICU or in normal wards. within maybe half an hour after the admission of the patient. So I mean, the trial is your study is very important and may have very significant clinical impact in the future. But have you ever considered some cost effect analysis for this thing, right? And for the trajectory design, I noticed that just the last audience asked a very good question about the trajectory. So for the catheter insertion, for the hematoma evacuation, the most important thing for the trajectory design is to try to put the catheter align the long axis of the hematoma so that you can have more side holes exposed inside the hematoma for the future thrombolysis, thrombolytic therapy, right? So if I'm allowed to, I want to share you with one picture, very brief. So you see, if this is a hematoma, so we always recommend that you insert the catheter inside the hematoma and measure the hematoma length and cut as many as side holes along this length. And because in electromagnetic navigation, the navigation system can track the tip of the catheter. So it has some advantages over if we compare to the ROSA system, because the ROSA system cannot track the tip of the catheter, right? So when you insert the catheter, if the catheter is bended or catheter tip is deviated from the designed trajectory, the ROSA cannot show you that the catheter deviated, the tip, I mean. So you need maybe a very, very tough stylet to assist the insertion. So and another simple thing is during the COVID-19 pandemic in mainland of China, in most hospital, for emergency case, if the patient needs general anesthesia, the doctors need to have the so-called level 3 protection. We need to wear very heavy masks, the whole setting of the protection and do the job. It's very exhausting and takes a long time, and the patient is also in danger. So, but if you use another way, like in bedside insertion with electromagnetic navigation, you do not need the level 3 protection. It's quick, it's easier, and faster. So this is in the pandemic special situation. So I'm wondering, maybe in the future you can perform a clinical validity study for the ROSA-assisted catheter insertion. And it's better to perform a multi-center trial to see if your expensive technique can be replicated in more centers, right? In China, this kind of developing country. Thank you very much.
Okay, thank you for the question from the Dr. Chen. And I think my design is not, actually it's an expensive design, I have to admit. And I want to go for a more high quality and high precision to those kind of patients. And first, we need to validate the efficiency and the safety. So I didn't do those cases in the emergency condition. So we just put those patients to the ICU and make sure that the hematoma is stabilized after 3 to 7 days, and then we will conduct this kind of a procedure. So maybe it's a different kind of design for different kind of population to do this kind of thing. So I want to again congratulate Dr. Chen that you have done those kind of emergency procedure, even in the bedside to those emergency patients in a relatively cheap cost to do those kind of things. I think that is another development direction, but it's not the ROSA case in our space. And also thank you for the advice on the a catheter engagement of the hematoma through the long axis. I think maybe we will refine our protocol to make the long axis treatment and the engagement as much as we can to the hematoma to improve the thrombolysis in the future. So thank you for your question and your advice.
You're welcome. Thank you.
Thank you for Professor Chen's comment and the discussion. Any question from the floor? Okay,
I have a quick question. As you mentioned, the steroid aspiration hematoma cannot improve the outcome you just mentioned. So do you apply the endoscope to remove more of the hematoma in the future? Because in your series, the aspiration rate, very large variance from 17% to 72%. So, and how to improve your aspiration rate to use ROSA system?
Thank you for President Shen's advice and question. Actually, we did consider about applying the endoscope technique in this kind of ROSA trial. And actually, to the best of my knowledge, I remember in November, last year, November, there is one publication that they are trying to do the ICH aspiration via the stereotactic tool, the robotic tool with the endoscope engagement in order to greatly improve the aspiration rate, just as the President Shen has mentioned. So I think maybe in the future, we can apply this kind of technique, not only blindly with the aspiration needle, but also can with a small caliber endoscope system to make sure that we can see the hematoma residual where and in which place. So I think combined with those two, the stereotactic ROSA system with the endoscope system, I think we can achieve a greater hematoma evacuation rate in the future. So very thank you, the President Shen's advice. Thank you.
Okay. Any more question?
Thank you for your excellent presentation. I think stereotactic using ROSA to aspirate some hematoma is very minimal invasive, so very good for some old age patient to recover. However, for the hematoma volume larger than 100 cc, the target point maybe 1 or 2 points is not enough because of the hematoma is too large. So, for example, for your slide 21, it shows the second one, the number 2 patient, the hematoma is more than 100, and after aspiration, the remaining hematoma even also has more than 70%. So I just wonder, for your such kind of patient, and you still not yet consider the infiltration of some RTPA to minimize the hematoma volume. So did you ever consider, if you would like to apply such kind of technology to aspirate a hematoma for larger than 100 cc in coming future, did you consider some more procedure or consideration to improve the future outcome? Thank you.
Thank you, Professor Hong's question. And we actually want to try this, but actually the number 2 patient is a savage case. So we just try to do something, but the most important thing that we want to do it in the safety. It's not it's not an issue about how much or how large hematoma that we can evacuate, but we just want to release some pressure and in a safety way. So maybe in the future we can do this combined with the endoscopic way, because when you aspirate more and more hematoma volume, then the brain shifting problem would be more and more obvious. So I think the precision will change. So maybe at that time, if we want to do in a larger hematoma case, we need to apply the endoscopic technique to do this together. Maybe someday we can really do these things in the larger hematoma case. Thank you, Professor Hong.
The second point is that for such kind of minimal invasive aspiration hematoma, actually it is very, very good for motor function improvement or speech improvement. So my recommendation is that in coming future for your result following, you can consider to check preoperative and postoperative motor function improvement, the muscle power or speech function. before publication? Thank you.
Thank you. Thank you.
Okay. Any more question? So on behalf of the organizing society, I would like to present the certificate to Dr. Ru for his lecture.
Skip the coffee break, and please feel free to enjoy the. And then let's welcome our next moderator, Professor Chen Chunzhong, to lead this session.
Okay, let's continue. Good afternoon. It's my honor to be here to the introduction Dr. Li, Chen Qi Li. Chen Qi Li is a graduate from China Medical University. Then he get a PhD from the National Taiwan University. And Dr. Li is an expert in scar-based surgery, endoscopic surgery. Now he's working in Chang'an Memory Hospital. Today, Dr. Li will give you our talk. His topic is about the first in-man trial of minimal invasive ICH device in Chang'an Memory Hospital. Thank you.
And thank you for the introduction. And I would like to thank the society and the chairman for inviting me here. And it's my great honor to give the speech here. And I would like to share our experience in Chang'an Memorial Hospital about the first in-man trial of minimally invasive endoscopic surgery in ICH device. And it's my contact. And if you have any questions, please feel free to contact with me. Thank you. And I would like to address the following section, including the introduction part, material and the method, surgical technique, and the case sharing, result, and the conclusion. So according to the publication here, we know that the stroke in Asia, especially in our country, Taiwan, the ischemic stroke accounts for around 71%, and the hemorrhagic stroke accounts for around 30% of patients. And we all know that the ICH affects more than 2 million people per year all around the world. So it's obviously that minimally invasive intervention for ICH evacuation will reduce the surrounding brain damage and shorten the operation time, hospital stay, and also reduce the infection rates. And most important, it will improve the functional outcome at the same time. And we all know that for ischemic stroke, we have the well-known thrombectomy device, which improves the patient outcome of the ischemia patient. And for hemorrhagic stroke, we all know that according to the publication in Lancet 3 years ago, the MISTY 3 trial, and at the same year, the surgical performance and the summary of the procedure steps was published on neurosurgery. So their enroll criteria of MISTY 3 is spontaneous ICH volume more than 30 milliliter, aged older than 18, and the coma scale less than 14. The pre-bleeding MRS is 0 and 1. And normal coagulation test was necessary, and the vascular lesion was excluded by pre-op CTS study. They enroll around 500 patients and 250 in MISTY group. So their procedure is they did a burr hole and by the navigation guided aspiration, they then by EVD catheter and then insert EVD into the hematoma cavity. And they did post-op CT scan immediately to confirm the residual hematoma and the EVD position. And if there was no problem, they will inject alteplase and the thrombolytic agent every 8 hours for 3 days. So they found that the good outcome was associated with if more than 70% of hematoma was evacuated or the residual hematoma was less than 15 milliliter, those patients will have a good functional outcome. However, they have some weakness. The major weakness is the bleeder control and then the blood cross removal rate. And there are some issues about post-op thrombolysis related complications, especially the hemorrhage issue. So how about the brain pass and the endopole, the so-called tubular retractor system? Yes, it provides bimanual surgical freedom, and it's good for bleeder control. And it, according to their report, more than 72% of patients will have a higher than 90% of evacuation rate of the hematoma. However, it still has some weakness. For example, it needs a larger craniotomy and obviously more cortex destruction. And based on the location of the hematoma and the light from the microscope, maybe it will need a longer time and larger brain damage throughout the whole procedure. So we are thinking about, is there any better option? Is there any device can provide a clear visualization with simultaneous irrigation and suction function, and it can do a simple bleeder control with flexible vision angle, and most important, it is also minimally invasive. So a biomedical company just developed a device. This device has a multi-function goal, as I mentioned before. And in addition, it also has a function of debrider, which is a function of to smash the blood clot and break it into many small pieces. And it's convenient for the surgeon to suck the blood clot out. So it's the whole system of this device. The most important is the endoscopic called Axon pen device, and then an Axon monitor. It's around 12 inches monitor. And the other important part is the clear path. It can be penetrated through the to the center of the hematoma and to prevent the damage from prevent the surrounding brain from the damage in the procedure. And we all know that compared to the traditional craniotomy and the MIS procedure, the traditional craniotomy will need around 3 to 5 centimeter corticotomy. And the MIS procedure will need around a 5 centimeter craniotomy and 2 centimeter corticotomy. And if we use clear-mind procedure, we can reduce the craniotomy to 2.5 centimeter with less than 1 centimeter corticotomy. And here you may have a question that since we can reduce the corticotomy to less than 1 centimeter size, why do we need a large craniotomy around 2.5 centimeter? Because we all know that it's a phase 1 study, so the safety is our concern and the most important issue. So if the some situations, such as the blood clot is too hard to remove during the operation, or we have to do more satisfactory hemostasis, maybe we will need a larger craniotomy and corticotomy to make sure the safety is the first issue. So in the near future, after more and more experience and technical advances, maybe we can reduce the craniotomy to less than 1.5 centimeters. So we launched a clinical trial 2 years ago in our hospital. It's about an open-label, non-randomized, single-arm pilot study for Axon pen system to remove the spontaneous ICH in our patients. So our inclusion criteria is spontaneous ICH aged between 20 and 80, and coma scale between 6 and 14. Laborum sized between 30 to 80 cc, and the surgery can be done less than 48 hours. One of the reasons is that if we do the procedure after 48 hours, maybe the blood clot will become harder, and it's difficult to remove through the endoscopic system. Our exclusion criteria is that if the patient has a history of coagulopathy, spot sign, or vascular lesion detected by pre-op CT scan, then will be excluded. And if they have the history of cancer, severe CAD, active infection, or pregnancy, will be excluded as well. And if the patient underwent major surgery in the recent 2 weeks, will be excluded. And if they have drug history of anticoagulation or antiplatelet, will be excluded as well. So from 2020 November to last November, we have enrolled 9 patients, and 6 of them just complete a 6-month follow-up. And our surgical technique is we put the patient in a supine position with helping fixation. And we prefer a linear wound near the cochlear point, of course, based on the navigation guidance. And we did a small craniotomy, 2.5 centimeter. And then we puncture the clear path till the hematoma center under echo, and we suggest the more precise CT navigation guidance. Then we insert Axon pen endoscopic device. Then we start to remove the clot and did hemostasis. And the EVD insertion is optional based on patient's condition and the surgeon's preference. This is our state situation of our first patient. You can see we put the navigation system in front of the operator and the scrub nurse, and the monitor in the left side of the operator. So we did a linear wound in around the right cochlear point, and we did a 2.5 craniotomy. Then we did a small corticotomy. Then we insert Axon pen into the corticotomy. So after remove the sheath in the clear path, because this is the first case, so we did very carefully. Then we start to insert the Axon pen system into the hematoma. And you can see from the monitor, the screen, that the quality of the procedure is quite good. And after remove part of the hematoma, you can see the surrounding brain. And this is our first case, so we check the residual hematoma with echogram. And if there is any residual hematoma, we will change the operation angle to try to remove more and more the hematoma. So now we change to another angle to remove the hematoma. And after the case, we suggested to apply the pre-op CT scan and for CT navigation intraoperatively. So you can see after irrigation and suction, the hematoma most of the hematoma was removed. And we confirm again with the echogram to make sure there is no significant amount of the residual hematoma. So after second check, we can do the final step of hemostasis. So because of the minimally invasive wound, we inject some hemostatic matrix into the surgical cavity. So I would strongly suggest to use the hemostasis matrix, for example, FlowSeal or SurgiFlow or Avithron, which contains thrombin, or T-cell for this kind of minimal invasive surgery, especially brain surgeries, because they can make sure that the patient's safety and improve patient outcome. And this is a video recorded from the Axon monitor. You can see the suction the device is good at suck the blood clot out and the irrigation. And if necessary, you can use the debrider to smash the blood clot and aspirate it out. So I would like to share two cases. First case is a 49-year-old male with right side weakness, and the coma scale was localized, left side muscle power 0. CT disclosed a right peritoneal hemorrhage with rupture into ventricle. The hematoma volume is around 70 cc. And 6 hours after the operation, the CT disclosed around 4 cc of the residual hematoma. The evacuation rate is around 94%. You can see it's a right peritoneal hemorrhage with rupture into ventricle. The pre-op CTA did not disclose any vascular lesion or blood or spot sign. So this 6 hours after the operation, you can see only 4 cc of the residual hematoma was detected, and the evacuation rate was about 94%. Because this is the first case, so in addition to the ventricular drainage, we also put another EVD into the resection cavity for the safety. And the patient, after around 4 days after the operation, the patient's coma scale improved. And around 3 months after the operation, the patient's functional outcome improves to MRS score 4 and the GOSC score 4, and the left side muscle power improved to grade 2 to 3 from grade 0. The case 2 is a 44-year-old male with right side weakness. The coma scale was clear, but with right side hemiplegia. CT disclosed a left side peritoneal hemorrhage with around 72 cc. And 6 hours after the operation, the CT disclosed a 8 cc of residual hematoma. The evacuation rate is around 90%. So this is a pre-op CT. You can see the CT scan did not disclose any vascular lesion or spot sign. This is 6 hours after the operation. You can see only 8 cc of the residual hematoma. The evacuation rate is around 90%. And because of more experience, we did not insert any EVD into the surgical cavity, and the patient did not have any rebleeding episode. So the patient recovered uneventful as well. So around 2 months after the operation, the patient's right side muscle power improved to right upper limb grade 1, right lower limb grade 4 with good functional outcome. So this is a recent case we did. This is a typical peritoneal hemorrhage with around 50 cc. You can see the post-op CT scan disclose the very minimal residual hematoma. And the procedure is done within 2 hours. And the most importantly, our junior resident also participate in this procedure. So the Awesome Pen system is very easy to use. Compared to traditional craniotomy, we can reduce our wound around 5 centimeters. And with more and more experience, we are confident that we can reduce our skin incision to around 3 centimeters. So this is our initial demographic result. You can see that pre-op ICH volume is around 50 cc, and the pre-op coma scale is around 9 scores. And we didn't have any mortality, rebleeding, or morbidity rate. So you can see the ICH volume evacuation rate is around 90%. And 3 days after the operation, the coma scale improved 4 scores. And the long-term functional outcome, MS and the GOSC scores improves a lot after day 40. And of course, it improves more at the end of follow-up around 6 months later after the operation. So this is a summary of our current patient. You can see the evacuation of hematoma is almost 90 or higher than 90% of the hematoma. And in the first case, because we use echogram to localize and confirm the residual hematoma, so the evacuation rate is not as good as the following cases, but the residual hematoma is less than 15 cc. So this is our first case in the 6-month follow-up in the outpatient clinic. You can see he works very well with the left side upper limb around grade 2 muscle power. So as long as we reduce the residual volume less than 15 cc, and if we can achieve the evacuation rate of around 85 or 90%, the patient's functional outcome will improve more. So our conclusion is that the ultrasound pen system provides clear visualization with simultaneously irrigation and the suction function. And it can do a simple hemostasis with the unipolar or bipolar or some hemostatic matrix. And it's very easy to use. Even a junior resident can do it under surveillance. So another important issue is that I strongly suggest to use this kind of hemostasis matrix for better hemostasis. Or you can use Surgiflow or Evithrone. And in some cases that the hematoma, which with some breeder embedded inside, and it's difficult to remove the hardest part of the hematoma. And if you remove the hematoma, maybe you will see the rebreathing. So in this situation, you may use the T cell with fibrin and the thrombin combination to stabilize the residual hematoma. And in this way, you can also reduce the residual volume of hematoma and to make sure there is no rebreathing issue post-operatively. So the key step of this procedure is, of course, patient selection. And CT guide navigation is better than echo. And based on the CT guide navigation, you can design your skin incision based on hematoma shape and the assays. And most importantly, the hemostasis is also important in the end of the surgery. You can use bipolar or such kind of things that I mentioned before. So can we have another better option? Yes, based on the first generation ClearMind system, although it provides clear visualization with irrigation and suction function, but if we can extend the distance between the lens and the irrigation, maybe we can reduce the frequency of blurring of the lens during the operation. And in the second or coming generations, maybe we can integrate the bipolar into the device and we can do more satisfactory hemostasis during the operation. And based on our experience, the function of flexible vision angle maybe is not as useful as we expected. So maybe we can remove the flexible function, and then we can get a smaller diameter from 6.5 to 5.6 millimeter. Then we can achieve the true minimal invasiveness. Maybe we can apply on tumor surgery in the following future. So my conclusion is that, of course, time is brand, but as the speaker said, ultra early intervention maybe will be associated with a worse outcome, but time is brand, and the early endoscopic assisted surgery is associated with low rebreathing rate and the improved functional outcome. And finally, the minimally invasive procedure with modified modern techniques will promise a better outcome. So finally, I would like to thank the chief PI, Dr. Zhang in our hospital, and Elbo Huang from NTUH, and all the PI for this clinical trial. Thank you. It's my final presentation. Thank you.
Thank you, Dr. Lee, for comprehensive introduction. I mentioned the exopone is designed from Taiwanese, and the reproduction in Taiwan is a pure Taiwan product, right? So Dr. Lee is do a better study in here. Any problem from the audience? Okay, actually, I have some question. Okay. So how do you choose your entry point? You mean that you choose the long AC? I find you found the frontal or temple.
Yes. Based on the long axis of the typical peritoneal hemorrhage, the frontal wound is the best choice. But however, considering the cosmetic reason, we choose the entry point in the coca point. around focal point, the EVD point.
So in your study, you still need the CT navigation you mentioned?
Yes.
Okay. So in your ISO point is the scope and the suction indication in one device?
Yes, one
so
device.
during operation, traditional, we one hand is scope, the other hand is suction.
Yes.
So you combine is any affected wounding? Maybe some scope will be wounded by the hematoma.
Yes.
So how do you resolve the problem?
And because the career path is 2 feet, considering the size, so if we remove the function of flexible angle, you can reduce the size of the endoscope. And there is a space for the irrigation water to gush out. So it can reduce the risk of the blurring of the lens. And we extend the distance from the lens to the irrigation outlet. So it can also reduce the flow of the water irrigated in. So it also can reduce the chance of the blurring surgical field.
Okay. During operation, sometimes we will make some suggestion with intra-operation breathing, artery sudden breathing.
Yes.
So do you have ever this kind of condition? And sometimes the breathing is really large, and the scope may be wounded by the hematoma. So in your device, you can overcome this problem.
We have an alternative choice because this is the first generation. The hemostasis function is not as well as we expected. So in this situation, if massive bleeding was encountered during the surgery, we may convert into so-called tubular retractor. We use the Vicker tunnel to gain more space for us to make better hemostasis. But it's some kind of different from the brain path or endopore system procedure because we only use the Vicker for less than maybe 20 minutes. So I think the damage to the surrounding brain is limited. Thank you.
Thank you. Professor Chen.
Congratulations. And I have a question about the poor procedure is underwater. And I see sometimes not underwater. So the procedure is, poor procedure is
not
underwater.
Not like scuba procedure. We sometimes use the irrigation and the suction.
Just only irrigation, not the underwater.
No, not underwater.
Sometimes like Chinese Medical Center use underwater type 2 aspiration of the hematoma.
No, not underwater.
Yeah.
I think you is air comedial scope, not a water comedial.
Yes,
traditional neuroendoscope for cervical is water, but it's air container.
Yes.
Yeah.
But it's just a scope and irrigation such in one device.
Yes.
Yeah, because underwater may be more safe. Yeah, and I see you apply the flow shear to hemostasis, and sometimes you have some residual flow shear, and how much of the flow shear you must suction out. And I have seen you some residual.
Yes.
Yeah, and this is safe to the brain tissue or cause some damage to the brain.
I think the fossil is relatively safe to the brain tissue, and we, as the microsurgery procedure, we also irrigate the fossil out after applying for around 3 minutes. So I think the hematoma may be result from some difficult angle for the endoscope to remove it completely.
But you say you use the flow shear and the tissue shear, so it's a combined use or just use flow shear?
Just use flow shear.
The
condition use T-cell will be better in some organized or harder blood clots with some breeders embedded inside. So you don't want to remove the hematoma and cause another bleeding. So maybe you can use T cells to stabilize with screw-in and the thrombin effect. So I think it's another way to make better hemostasis.
Like raping.
No.
Okay, is there any other question from the audience? Okay, I will represent the organizer to Thanksgiving for Dr. Lee.
Let's welcome our next moderator, Dr. Shen Jiongqi, to lead this session.
It's my honor to chair this session, and the speaker will be Zhimin Lai. Dr. Lai is a graduate from National Defense Medical Center in 2008, and later he come to Taichung Veterinary General Hospital to complete the resident training, and later he served in Veterinary General System in the Taoyuan Veterinary General Hospital and Puli for 5 years. Then he moved back to Taichung Veterinary General Hospital and the service in intensive care unit. And today, he will give us, the topic is ICH aspiration at the hybrid OR, Veterinary General Hospital experience. Let's welcome Professor Lai.
And thank you for the professor's introduction and invited me to talk about the topic in this place. Today my topic is the ICH aspiration by hybrid technique in our hospital, Veteran General Hospital, Taichung. And my job is now working in the neurosurgical and critical department at our hospital. And so most of the patient I will talk today is the ICH patient. Also, why we choose operation or not to observation to treat the patient. And we're talking about the operation, there is harm or is there a decompression benefit? Or we want to prevent the ICH or mass effect herniation, or we want to reduce the ICP. Or there is a big mass, or maybe we consider to check some pathology and result of the mass. So maybe we should choose the operation. And so we should consider what is the timing is the operation, is it benefit to the patient. And in another specific topic is that cerebral hemorrhage. Maybe in this case, we should choose the operation as soon as possible. And now I list some issue we should think about. Is there benefit or harm to the patient? And I think it is not the standard or the guideline, but with this issue, it can inform our neurosurgeon. And is this good for patient? And such as, is this patient in minimal symptom or coma? Or is there a severe coagulopathy or underlying disease? We know that there is still some debate in it. We know that most of the ICH is attack on the subject's basal ganglion, thalamus or hypothalamus, or even brainstem. So when we try to approach this site, we will try to evacuate the hematoma and the mass effect. And so the operation or the technique may harm or risk to the patient and make the patient neurologic function more deficit. And such as a patient has a basal ganglia ICH or has a thalamus ICH, but it's minimal, and so it is need for operation. Or if there is a large hematoma over basal ganglion, maybe we can reduce the hematoma's mass, and patient has a better prognosis. And on the other topic, infratentorial, and if the patient has a lower coma scale or the mass more than 4 centimeters, or there is obstructive hydrocephalus, or there the brainstem is compression, the operation should be chosen as soon as possible. But if the patient has the problem of such as lost brainstem reflex, or he has the flaccid tetraplegia, maybe even after the operation, the prognosis is poor, and maybe conservative treatment is the choice. So if we choose the operation, and which one of which operation or which technique would we choose? Is craniotomy, or is a minimal invasive surgery, or is an endoscope, and then? And we know that if the hematoma is big and it is obviously midline shift or ICP sign, maybe a craniotomy and a big scalp incision and a large craniectomy and release the intracranial pressure is needed. But if it is acceptable, maybe minimal invasive surgery has a good outcome. From some paper nowadays, we can know that minimal invasive surgery has a lower time consuming, has a better hospital day, and a same prognosis as same as the craniotomy. And we know that Lexell stereotactic navigation is the precision choice for the aspiration. When I'm a resident, I ever use this technique to treat patients such as brain abscess or biopsy, brain mass biopsy, or even used to aspiration the hematoma. But we know that you need to use the frame, and you should go to an MRI or CT room, and you use the software to plan in the trajectory. And even the frame, you should fix it on the patient head and plan in the burr hole or where is the craniotomy site. So sometimes it's disadvantages, even it is precision. Such as you should spend more time to CT room, or you should know that the X, Y, Z, or the 3-dimensional problem, and how to set the frame, or how to use the software for the Lexell system. It is more difficult it is sometimes it's unfamiliar to a surgeon. And this paper is written by Dr. Chen Jianhua in 2008. He collected 6 patients and received is ICH patient and received the frameless stereotactic procedure to hematoma aspiration. Then at that time, we have the brain lab. We use the surface match method to navigation and to do the operation for aspiration. And we can see that there is a good hematoma reduction rate, and there is a good prognosis. So from the time, we often choose the brain lab for to use as the navigation and fusion with the brain CT to remove the hematoma as the minimal invasive in our hospital. And nowadays, we can see in the picture that in the left side, it is the brain lab is the second generation. And in the right side, there is the Artis Pheno. It is a robotic C-arm. It can make a dynamic CT at the operation room. And in the middle is the intra-op CT. And in the right side, it is Artis iconal biplane system. It is like the Artis Pheno, but it has a biplane. And for this, we call it maybe a hybrid operation or technique or room. And to do more, I think it is a tool for us to do operation, and more choice, and more thinking process, and to do more benefit to the patient. And this is I write the common procedure for the hematoma aspiration. First, we fix the patient head on the bed under the spine position, and we made a burr hole on the frontal. It's often a Cocos point. And we made a dyna CT by Artis Pheno system, and we set the target and make the planning. And the EVD is insertion guided by Artis Pheno system. And also you can use the Siemens industrial, they give us the software, the single iGuide navigation software to planning the EVD industrial plane. And then after EVD insertion, we can check EVD position by dyna CT again. And after check the position, we can hematoma aspiration. And sometimes we'll use the urokinase to injection and pressing it. And we will cross the wound. And now I will present two cases about we treat a patient ICH and by the aspiration technique and use the Artis Pheno system. The first case is a 51-year-old female. Is a 56 kilogram. Her chief complaint is the sudden onset of slurred speech, and she has a past history of hypertension. And for this, for her condition is she ever visit the local medical hospital, and brain CT has done there and show the left side putamen ICH about 4 centimeter. And she was transferred to our emergency room, and the coma scale is E3V5M6, and the pupil size and light reflex is normal. Vital sign is normal here now, and we can see show that there might right limb muscle power decrease. The ICH score is calculated is 0, and it is the local hospital CT. We can see that there is the left side basal ganglion ICH. And this is the dyna CT done by the Artis Pheno system, and it is already we aspiration the hematoma, and we can see that there is EVD siphon in this image. And for this dyna CT Artis Pheno system, we can combine with the iGuide and planning the EVD insertion trajectory. And this operation take about 2 hours and 30 minutes. And I have asked the operation of this, I asked the operator of this operation and it takes a longer time because it is the first time to use this Pheno system. The operator cannot he cannot confirm, or she has no more experience of this system before. So after he fixed the patient head, he also used the brain lab navigation over the patient with the service navigation, and check the EVD pathway is there as the same with the Pheno system. And after check with the brain lab, the operator said that it is almost the same. The trajectory is good. And urokinase 6,000 micro is inserted, and the hematoma 7 milliliter is a separation, and the blood loss of this operation is minimal, and the EVD was inserted within the hematoma residual place. And the hospital cost, post-op day 1, we follow up the brain CT, and after the CT, we remove the endotube. And in this day, urokinase intrathecal we ever use 1 time. And post-op day 3, we remove the EVD tube, and with the EVD tube is almost no drain amount. And post-op day 4, and the patient transformed from ICU to ordinary ward. On post-op day 6, the patient is discharged. The modified Rankin scale, and on the day is 1. And we can see that this is the post-op CT. In the left side is the post-op day 1. There's still EVDs in the hematoma, and the hematoma is almost a result of aspiration. And on the right side is the post-op 1 month CT, and there is a good post-op CT image. And then I will share the second case. It is a 49-year-old male. It's about 63 kilograms. The chief complaint is a traffic accident happened to him. He driving the car and hit the divisional island. And from the witness or his family say that a patient loss of consciousness was noted at the site, and seizure was noted. It is taught by the EMT. Patient has a history of hypertension. And from the PE and NE, we can see that in the emergency room, patient is semi-coma. A coma scale is E1, V1, and 4. So endotube was insertion in the ER. And there's still a normal pupil. And from the vital sign, we can see there is higher blood pressure. So then the blood pressure, the pump for the drug to lower blood pressure was done in ER. And with checking, we know that there's a mild abrasion wound over forehead. And the ER doctor ever done the fast sonogram to the patient's chest and the abdomen, and there's no finding. And there's mild upper limb convulsion. And this is the brain CT in in a patient in ER. And we can see that there's a huge hematoma over right side brain basal ganglion, and the hematoma invests in the intraventricular. So there's the IVH, intraventricular hematoma. And the hematoma was also found in the stem fissure and the third ventricle and the lateral temporal horn. And we can also see that the hematoma also noted over the third and the fourth ventricle. Because in this brain CT image, we think that there's more like the spontaneous ICH than the traffic accident related. And so the hematoma is too big. And we check the CT angiogram to check is there any vessel disease or such as the aneurysm or AVM in it. But there's no such finding. And the operator to choose the operation at the day, and they choose to EVD placement from the bilateral Cocos point as the IC monitor and drain the hematoma over the ventricle. And it's the post-op day 7 image. We can see that there's still much hematoma over the right side basal ganglion and many residual hematoma in the ventricle. And there's some air in the ventricle. And there's still some SAH within this cycle. And in the day 18, the patient is still stay in the ICU. The operator decide to do the second time operation. And he used the final guidance, stereotactic aspiration of ICH. And on the left side, he changed the left side long tunnel EVD. And this is the DynaCT image by the ARTIS Pheno system. In the left side, we can see that our radiologists, they use their software to write around the mass effect, the mass margin. And from the margin, they choose the entry point of this operation, and the target. And the entry point is from the burr hole before. From this image, we can see that this is the last time burr hole. And in the right side is the trajectory plane from the burr hole to the target. It is a planning, is running by the radiologist for all to check that is this pathway is okay for operation. And this operation is take about 1 hour 15 minutes, and a black hematoma about 30 milliliters was aspirated, and the blood loss is almost minimal. So the right side EVD was put within the hematoma, and the left side long tunnel EVD was done. And this is the post-op second times of day 1. We can show that most of the hematoma on the right side is almost resolved or aspirated, and the right side ventricle and the EVD is in the good position, and the ventricle is clearer than before. And the patient post second time operation course is post-op day 1. There's follow-up brain CT, and we use the urokinase intrathecal BID for 3 days. And the post-op day 4, we remove the right side EVD for drainage. And in post-op day 7, patient removed the endotube. And in the day 11, the operator removed the long tunnel EVD on the left side. And on the day 13, the patient was transferred to the ordinary ward. And in the day, the coma scale is recovered to E4, V4, M6. But because the hematoma is too big, and because of the ICH problem, and his modified Rankin scale is higher, is 4. And the 2 cases I will show today, and I will tell everyone that the hybrid or the navigation system now we use and there's no frame needed. We need not to run far away to the CT room. We don't need to think about what is the X, Y, Z for the software planning. and we have the time saving. And in the dynamic CT in the hybrid brain is real time. And if we see something is different, or if we see some problem, we can do the right way and do the right thing. And we can recheck or to adjust our operation technique, or even if the patient has more problem, a craniotomy or craniotomy may be done. And this is my today's topic.
Is any question from the floor? Okay, what's that?
Techniques for aspirational hematoma. My question is that for such kind of ICT planning, it seems very convenient for real-time navigated the target entry point and the hematoma volume measuring. So, and did you ever have some plan for coming future if for some larger hematoma aspiration, for example, the multiple points aspiration or other plans, did you ever consider for how to manage the large hematoma volume? And sometimes if during operation the hematoma even larger, when did you consider convert to craniectomy instead of only aspiration only? In some situation, before for minimal surgery, some of the doctor will consider stereotactic aspiration. But after CT or IC intraoperative CT, when you see larger hematoma, maybe you'll consider further aspiration or convert to traditional microneurosurgery. So maybe it's a tough question. Could you comment on it? Thank you.
Thank you. And in ICT use, and in a huge hematoma, and in my prior knowledge, we note that the hematoma aspiration, if the trajectory is in a good way, or sometimes the hematoma aspiration, we can almost aspirate about 50% more. And maybe we can consider to check the intra-op CT and check is there a residual hematoma, and do the second times operation again or technique again. But I never do it before. I never do it before. But it may be a choice. But as my experience, I ever use the Zigo system. It's just like Artis Pheno. It's the first generation. Sometimes we after operation, there is more artifact or even some gas in the image. So it may make your planning more difficult. I think it may be we should consider it. But the intra-op CT, I think the image is better now. So the second time choice technique for aspiration maybe is a choice. And what is the second?
The second question is, do you think the craniotomy to evacuation the hematoma is better than aspiration?
I think it is in some situation, it is the different topic or it's a different problem. And craniotomy, as my experience, sometimes is for the life-threatening, or we try to save the patient quickly. And craniotomy has the effect to decrease the intracranial pressure, and we can remove the cranial scar, so we can give more space and the pressure release for the patient. So if the patient hematoma is too big, or we think that patient is such as there's almost a pupil is some changed. It's more bigger, or the light reflex is not it's not so obviously. So, and we think that maybe the hematoma will progress quickly, or the brain swelling we may see then. So maybe I will choose the craniotomy and the hematoma aspiration for hematoma evacuation for the patient. And we thought that just in the before, we choose the patient for the hematoma about 30 milliliter to aspiration before. And then because I think maybe we have the more tour or more experience, sometimes they're 50 milliliter or even 100 milliliter, we also aspiration the hematoma, and patient has a good outcome, and there is no life-threatening problem. And so maybe I will see most of the point is the patient vital sign and the brain image, and his NENP presentation is my concern.
Okay, thank you.
I suggest the second case not only to put the EVD. At the same time, you must put the case into the hematoma cavity to hemolysis of the big intraparenchyma hematoma. Sometimes we have found that the putamen hemorrhage rupture to interventricle. You not only to put the EVD, but also you can use the sample hole and put a case to the hematoma cavity. Then easy to lysis of all the hematoma. Yeah.
Yeah, thank you.
Okay. Shift turn.
I just curious why the second case is a very big hematoma. Why is the aspiration since delayed to 1 month or 2 weeks later? Why? This is question one. Then the case one, you mentioned you use the urokinase, right?
Yes.
So
yes.
how is the amount of urokinase? And you know the Professor Lu and Rosa just use TPA.
Yes, yes.
So why do you not choose TPA or choose urokinase? Is there any difference?
Thank you for your question. And for the first case, because it is not my patient, but I ever treat the patient before. As I know that there is some problem of the patient underlying problem, and maybe there is some problem from the operator that communicated with his family. Maybe so the operation technique they choose this site, yeah. And from the second to the second question is urokinase use. We in our hospital we use the urokinase for in the aspiration hematoma for a long time, and we didn't see no obvious complications, and we use it and such we think it is safe. Sometimes we try to use it say 6,000 micro, or if the hematoma is less, or we afraid of the delay ICH or hematoma progress, and sometimes we choose to use 3,000 micro. Thank you.
Yeah, because we have a study on the urokinase. The urokinase have the brain protection effect. We have the animal study use urokinase. So traditionally we use urokinase for 30 years for aspiration the hematoma. Yeah. So the TPA we have no experience. Also, when you put the catheter into the hematoma cavity, immediately we use urokinase to lysis of the hematoma. And in our hybrid room, we check about 80% of the hematoma was aspirated. Then we close the operation. So the half-life of urokinase about 15 minutes. So injection the urokinase into the hematoma. 15 minutes later, you can open it. Let the hematoma drain out. So maybe sometimes we use 60,000 units of urokinase during the procedure. So we can achieve about 80% of the hematoma was lysis at the first time of the aspiration. Yeah.
Thank you.
Okay. I think the intraoperative CT has some advantage providing for neurosurgeon during operation, especially for tucking into some vessels. So it's very important to localize. My recommendation that routine use contrast CT during operation to clearly identify the vascular structure. In general, the vascular structure would be at the bottom of the hematoma, but sometimes during aspiration hematoma, the hematoma volume changed. Then the vessels also have some shift and the parenchyma tissue shift. So prevent from aspiration or injury to the vessels is very good. Use the intraoperative CT to scan again and to evaluate the further aspiration hematoma and prevent from damage to the cerebral vessels. Thank you.
Thank you.
Yeah, and the Pheno system have the eye guide. So you need them to have the frame. You just use the eye guide and the plan to the center of the hematoma, just to push the catheter into the lesion. It also can apply to brain biopsy. So it's very quick. One scan, then the robot can have the navigation itself, and you can very precise to put the catheter into the lesion. Yeah. Is there any question? No. Now we close this session, and I present the certificate for Professor Lai to his contribution to our society.
演讲与主持。那由于下一位外宾还尚未上线，那我们先短暂的休息一下。那待外宾上线之后，我们再继续等一下的会议。
袋进水了，正是水脑症。大家好，我是 Dr. Brain 布恩博士，我是人体的总司令，掌管人类生命活动最重要的器官。我住在一个充满脑脊髓液的房间里，每天容纳约150cc 的脑脊髓液。但是随着年纪越大，我越没有办法吸收或回收多余的脑脊髓液，导致我的房间内累积越来越多的液体，这就称为水脑症。水脑症典型3大症状为失智、大小便失禁、步态不稳，与熟知的阿兹海默症与巴金森氏症相似，因此常常被搞混而延误病情。水脑症有2种。若是因老化导致脑脊髓液吸收过慢而囤积于脑室，称为常压性水脑症；因肿瘤或颅内出血使脑脊髓液循环流通的路线受阻，以致脑脊髓液无法排出，则是阻塞性水脑症。水脑症可以预防与治疗吗？请专业医疗人员为我们说明。
水脑症并非不可逆的疾病，建议有类似症状的长者应尽快至神经外科诊断与治疗，能减轻照护家属的负担，并大幅改善病患生活的品质。
不要以为水脑症治疗一定要从脑部开刀哦。目前有腰椎腹腔引流手术，从腰椎的寂寞腔置入引流管，可以避免脑部开刀的风险。
水脑症虽然没有办法预防哦，但适度的维持正常的生活作息，少烟少酒，那适度的运动，然后再控制3高的这样的状况啊，高血压、高血脂或者高尿酸这样的状况，就有机会远离水脑症。那这边代表学会要呼吁大家一下，就是任何的疾病啊，最重要的就是预防啊，预防胜于治疗。所以当我们在日常生活观察到我们的长辈，如果有一些，比如说记忆力减退，这种记忆力减退通常指的是最近的事情记不清楚，可是远的事情他可能反而记得很清楚，或者是大小便没有办法控制，或者是走路步态不稳，有这3种状况的时候，那必须立即找神经外科或神经内科的专科医师，赶快加以诊疗，赶快去处理，看看到底是不是有水脑症的状况。那如果不幸真的是有水脑症的状况，那必须要赶快处理，来减少将来后续的一些问题，比如说失智啊，或者造成一些残障或失能的状况。
OK， 好，对，那好，各位同事，那我们外宾准备好了哈，所以我们就可以坐下来，然后准备听我们最后的这个演讲哈。谢谢大家，谢谢大家。好 ，OK， so it is my honor to introduce the last speaker, the Dr. Pradila. Dr. Pradila got his MD degree from Johns Hopkins University, and now he's an associate professor in Emory University. He's not only a well-known expert in minimally invasive surgery for ICH, he's also an expert in pituitary and endoscopic skull-base surgery. So he's the PI of a trial called ENRICH, which is the most anticipated trial of ICH surgery, which we will see the result perhaps this year. As you know, the MISTY trial was led by neurologists. The ENRICH trial is led by Dr. Pradila, who is a neurosurgeon, addressing the important neurosurgical questions in ICH surgery. I believe Dr. Pradila now is in Brazil attending the World Skull-Base Surgery. So it's like 6 a.m. in Brazil, and we thank you very much for giving us this talk. Let's welcome Dr. Pradila.
Morning. Thank you very much for the invitation. My dear friend Eva Huang, fortunate of sharing many insights with him over the years and watch the wonderful work that he's doing. As he mentioned, we are in the process of conducting a randomized clinical trial called ENRICH, and that will be the topic of my talk today. My practice is located in Atlanta, Georgia, the southeast portion of the United States, at Emory University School of Medicine. These are my disclosures, and the most important one is that the trial is funded by NICO Corporation, which is a company that designed and commercialized one of the devices that we use for the procedure. Intracerebral hemorrhage has been the topic of your meeting, so I don't have to spend a lot of time here, but I do have to tell you how gratifying it is to see that within the realm of cerebrovascular disease, it is becoming a much more talked about pathology, because during many, many years in the cerebrovascular world, on the neurosurgical side, subarachnoid hemorrhage caught all the attention, and we talked extensively about aneurysm treatment. With the revolution in thrombectomy for ischemic stroke, that dominated the conversation for the last decade, and it is only now that intracerebral hemorrhage is getting more noticed. In the United States alone, it's a very big disease. About 120,000 patients per year have it. And economically speaking, it's about $12.5 billion that we spend overall in the care of these patients. With regards to its growth in the future, all of the primary causes of it, hypertension, amyloid angiopathy, coagulopathies, most of those iatrogenic from anticoagulants or antiplatelets, those continue to grow. So this is a disease that we will see expanding as our population ages globally. To me, the reason to consider surgical treatment for this disease has 3 points that I hope I will convince you upon. The first one is intracranial pressure control. The second one is the prevention of clot expansion. And the third one is the prevention of secondary inflammation. So let's talk about intracranial pressure control. To me, any hemorrhage that gets above 30 cubic centimeters starts to become relevant in terms of elevating intracranial pressure. And the goal of an intervention is to improve cerebral perfusion and to prevent that ischemic injury that will happen to the perihematomal area. When we are able to eliminate this from the equation, then these patients who are frequently intubated in the intensive care unit can be more rapidly liberated from the ventilator, and that will get them out of the ICU. If we look at the mortality from intracerebral hemorrhage, half of that mortality, over 50% of these patients, they don't die from neurological causes, they die from ICU-related complications, DVTs, pulmonary embolism, sepsis, etc. And I'm going to play a short video for you that illustrates this point. The patient that is on the table there had a hemorrhage secondary to a trauma. So it's a very injured brain, and following a traumatic brain injury, develop a hemorrhagic contusion. So happen to have an intracranial pressure monitor, which is going to be the number located at the bottom. And you'll see this evacuation is happening live, and the number in the monitor, I don't know if you can see that, but it rose to about 35, 40 for a few seconds. And as soon as the evacuation started, the intracranial pressure dropped immediately to about 5. So from 35 or 40 to 5 within seconds. And I think whatever we do that can be considered an effective intervention has to be able to achieve that goal. The second reason to remove a hematoma, in my mind, is preventing clot expansion. So we know from extensive literature led by this gentleman here, Dr. Javier Romero, who's a radiologist at Harvard. He led the group that did all of the studies of the spot sign, which is an active sign of hemorrhage. It's a contrast CT angiogram that shows active extravasation. That data, we know that this happens quickly, and it happens often. The scan on the left side progresses to the scan on the right in a large proportion of patients. And we need to be able to intervene, and I'll show you this video again in a little bit of detail, but that surgical moment of finding the bleeding vessel and cauterizing it and eliminating the risk from that expansion is a critical need. If you look at this meta-analysis, which is fairly recent, it shows you that there are approximately 24% of all intracranial hemorrhages showing a spot sign, active extravasation. And that immediately, as you probably heard the meeting, if you had Dr. Hanley speaking, that was a contraindication to doing thrombolytics. So it's a very important point, not only as a predictor of outcome, but also as a limitation for certain types of therapies. The third reason to evacuate these hemorrhages, to me, is to prevent secondary inflammation. And that cascade of events is very well documented. We know that as soon as this hemorrhage happens, between moment 0 and 4 hours, these events develop. There's glutamate release, calcium influx, there's mitochondrial dysfunction, there's cytotoxic edema, and there starts to be necrosis. All of those things happen very quickly. However, if you decide not to intervene between 4 hours and 7 days from the hemorrhage, the presence of all of these well-known factors activates this inflammatory cascade of endothelial and microglial activation. And that causes cytotoxic and pro-inflammatory and pro-oxidative events that lead to this disruption of the blood-brain barrier, vasogenic edema, and apoptosis. And these events are very clear to anyone who practices with these patients, because this moment 0 to 4 hours is when your patient gets admitted and they are looking neurologically stable. They are protecting their airway. They have maybe a fixed deficit, speech or motor deficit, but they look stable. And when this edema starts to happen, they become obtunded, then they get intubated, and then they start to show lateralizing signs of severe intracranial pressure. So the big question is, can we intervene so that we eliminate that transition from the first cascade to the second? And I think that we can. If we look at several studies like this one from Stacy Wolf, for example, looking at microglial activation and activation of T cells, we see that there's a clear moment within those first 24 hours where that cellular activation peaks. And once those cellular populations have entered, the fate of that parenchyma is fairly dramatically changed in an irreversible way. So we are racing against the clock to stop that. When we see what happens with this inflammatory cascade, this perihematomal edema that forms, we know is very deleterious to the brain. We look at outcomes, we see that people with more perihematomal edema have worse outcomes and have higher mortality. Conversely, if we decrease the amount of blood, and if we do so in a time-dependent fashion, patients do better and develop less perihematomal edema, and their outcomes improve. So we know that happens. So the big question is this: if the rationale is so good, why are we not doing more surgery? This is one of those satisfying things that we like to do. We see that brain under so much pressure and we release it and we see it relaxing and pulsating again. And it just seems like a naturally right thing to do. And I think we have done a disservice to surgical treatment by not doing studies that show us that we are correct in instinctually trying to treat this disease with surgery. And let me see if I can convince you of that. So the first study that any neurosurgeon in the United States will quote to say that surgery is a futile endeavor is this one. And that is the very well-known STITCH trial, which was published in The Lancet in 2005. So this study was done in 1,000 patients in 83 centers across 27 countries. Massive endeavor. And it compared two groups, early surgery versus initial conservative treatment. And unfortunately, there was no significant difference in favorable outcomes. 26 patients did well by their standards in the surgical group versus 24% in the conservative treatment group. So not enough to be significant. They had a subpopulation of patients with a lobar hemorrhage without intraventricular hemorrhage that they subsequently studied in another large trial called the STITCH 2 trial, also published in The Lancet in 2013. And the metric was unfortunately not changed sufficiently. So the percentage of patients who did poorly was 59% in the surgical group versus 62% in the conservative group. Slightly better for surgery, but not significant. And that had a very high risk of crossover. So these two studies, the kids surgery. When you look and review the surgical protocols for these two studies, the surgical protocol itself is quite diffuse and non-specific. There were no recommendations as to what to do surgically. So while some centers did a very large operation that involved removing the skull, doing a hemicraniectomy, removing part of the brain, doing a partial frontal or temporal lobectomy, for example, and doing a very aggressive clot evacuation, other centers did a small craniotomy and did what we call a corticectomy, just a small incision on the surface of the brain, and then did an evacuation in that manner. And as you can imagine, the amount of variability that this generated in terms of outcomes was huge. The other thing that we never knew from these studies is how well the treatment was done, because there's no reported volume at the end of the surgery. So we don't know if they evacuated 5% or 50% or 90%. And these studies are quoted anytime someone says surgery should not be done. So there are a lot of methodological issues with these. It wasn't until, as you probably heard, Dr. Hanley, Dr. Zuccarello, and Dr. Awad got together and formed this collaboration that ended up with the MISTY study, that surgery was revisited for intracerebral hemorrhage. And as you heard, probably, there was a survival advantage to that intervention in this Kaplan-Meier curve. MISTY is at the top and the control group is at the bottom. So catheter-based evacuation with gentle aspiration followed by an infusion of a thrombolytic called alteplase led to improved survival. The disappointing portion was this one. The modified ranking scale at 1 year was not significantly better, and that was a primary outcome measure. So this was, on a primary outcome measure basis, a negative trial. So why are we so excited about it? Well, because it was very well designed in terms of analyzing success. And that's what gets me excited about this study. So they did find out that with better clot removal, patients did better. Their outcomes were significantly better. And that meant that if you got to an end of treatment volume of less than 15 millimeters, or you did an evacuation that was greater than 70% of the initial volume, the likelihood of a patient achieving a modified ranking score of 0 to 3 was good. Sadly, they only achieved that goal in 59% of the patients, which naturally led to all of us wondering if they had achieved that in 65 or 70% of the patients, would the trial have been positive? Statistically speaking, yeah, most likely. So what went wrong with all of these things? As I mentioned, the STITCH trial, which is this one here, had the issue of the surgical protocol. The method of choice was left to the responsible neurosurgeon. And if you're evaluating a surgical intervention, you have to be very specific about how that intervention is done, because the variability in technique is too great to say that surgery in general is not beneficial. The second problem, as I mentioned, is that clot evacuation was not reported. So we have no idea how they did. With the MISTY study, again, we know that unfortunately, only 59% of the patients got to that point. And they did a lot of follow-up studies. I don't know if Dr. Hanley went in detail on these or not, but investigators did the best, and they saw that people with experience and training not a surprise, improved over time. So the centers that did the more volume had the better results and so on. And there were centers that were not doing as much volume and they did not have as good results on a procedure that is, technically speaking, very simple. It's a catheter placement procedure done under image guidance. It doesn't get more simplified than that. So it is critical to achieve methodological adherence and success. The other big problem that all of these studies have, and that includes our study ongoing, is that we tend to group all of these and lobar hemorrhages and anterior basal ganglia hemorrhages and thalamic hemorrhages are grouped under this big ICH denomination when, if you look at their clinical course, they're very different diseases. And I think we have to start to study these diseases separately so we can do justice to the interventions we're trying to develop. So these are the remaining challenges after these studies. The patient selection. There are limitations to any technology and any therapy that we develop. We need to understand who's the right patient for each one of those. The timing of the intervention. We don't have a study that says that you benefit at 12 hours or 24 hours or 48 hours, but we have evolving data saying that it is not deleterious, it's not bad, it doesn't result in bad outcomes to intervene early. And then technique, we have better technique. Technology has evolved tremendously. Since the MISTI study was designed, which was over a decade ago, technology has advanced very significantly, and we are getting better at training and educating people on how to do procedures. So when we sit back and say, what's then the ideal procedure for this disease? It has to be, number one, able to decrease the mass effect, not gradually over a few days, which is what you got with the catheter procedure, but immediately. If you have 50 cc's of blood, you can't wait for 5 or 7 days for the clot to resolve. You need to be able to impact that right away. It has to maximize clot removal. So a 50% clot evacuation is not good enough. It has to be better than that. It has to minimize iatrogenic injury. So you can't just pretend that taking part of the brain out on your way in is going to improve outcomes. You have to be respectful of the brain around the hematoma. You have to be able to see well enough to do good hemostasis, because rebleeding was one of the problems with the first types of interventions for this kind of surgery. It has to be a procedure that decreases the length of stay, so we minimize those medical complications associated with being in the ICU and in the hospital. And it has to decrease the overall cost to the system. It cannot add to it. So with that in mind is that these 6 principles were developed. 1, using image-guided analysis of where this hematoma is and how you're going to access it without damaging the surrounding brain. 2, using that information in real time during surgery. 3, using a method that is less disruptive to the brain and to the white matter in particular. 4, using imaging systems that allow you to do safe, precise surgery in the way that we are used to do. Having efficient tools that work using this type of a workflow. And then finally, having sufficient access to continue to learn about how to make this disease less lethal. So this is what we use for this. This is a port that was designed to access the subcortical space, including the ventricles and the deep white matter. It comes in different lengths, anywhere from 50 to 95 millimeters. It has 2 diameters, 13.5 millimeters and 11 millimeters. It can be introduce using what we call stereotactic guidance, so MRI guidance for that. And this is how we think about this. So we tend to understand what the major fiber tracts in the brain are that are involved. In this case, we're illustrating here an anterior basal ganglia hemorrhage that is accessed through an anterior frontal trajectory that protects the cingulate fasciculus, which is that purple bundle there, and the superior longitudinal fasciculus, which is the green bundle there. And that is introduced through a sulci, not through a corticectomy, so the cortex is respected, and it's put in under stereotactic guidance. And once it's deployed, devices to do traditional surgery. We have a suction, we have a cautery device to stop bleeding, and we have a tool that can evacuate the clot in an efficient manner. So that's the concept. So let's see an example. So this is a patient that shows up with a large right-sided hemorrhage, and that's the trajectory that we typically would do. This is how we analyze the imaging study. So we have a clot that has caused displacement of the cingulate fasciculus medially, and you see that. You'll see the hematoma, and you see these fibers being medial at the top, and you see the green fibers, which is the superior longitudinal fiber, being displayed laterally. Right here is now the port being simulated as it enters the brain, and we understand how we're going to interact with that injured brain so that we stay within the confines of the hematoma and not disrupt anything on the way in or on the way out. And then this is the procedure itself. So in this case, we have the skull base, so the nose of the patient will be towards the top right of the screen. Top of the head would be at the bottom. You can see a small craniotomy has been done. So this is about a 4 centimeter craniotomy. And the brain is very full. You can see the dura mater is full. And now we are seeing the pulsations there. We only open the arachnoid layer just enough to introduce our port. So this is the port being deployed here. And this is a 75 millimeter port being introduced in real time using stereotactic guidance. Once the port is at the depth that we want it to, we remove this obturator, and then we have an imaging device that is coupled to that, so it automatically auto-aligns to it. And then we are looking down the barrel of that port, and immediately we see this clot erupting there. And then we use this device that speeds up the clot evacuation, even if the clot is firm. Hemostasis, as we remove the port, we inspect our trajectory, and then once this comes out, we see these pulsations here in the brain, and the cortical surface and the veins are very well protected. And this is the clot evacuation that we achieved for that patient. So in terms of efficiency of clot removal, very efficient. We conducted several studies, some single center, some multicentric, to evaluate the potential for this. And what we saw in those initial studies, number one is that the clot evacuation rates were much better than anything previously reported. They were all consistently over 90%. Second, we saw that Glasgow Coma scales improved pretty significantly. And in the modified ranking scores, which were analyzed in this multi-center study, we saw that at 6 months, there was a significant proportion of patients that met the good outcome denomination of a modified ranking score from 0 to 3. So with that was that we designed the ENRICH trial, and that stands for Early Minimally Invasive Removal of ICH. Our trial committee is very multidisciplinary in nature. We have neurocritical care physicians, stroke neurologists, neuroradiologists, emergency medicine, neuroscientists, and neurosurgeons, as well as biostatisticians and epidemiologists. And the trial is ongoing. We have 32 sites in North America, in the United States specifically, that are participating. All of these are our peer institutions and highly regarded academic centers in the country. If you'd like to see more details on the trial, this is our website, enrichtrial.com. Briefly, this is the purpose of the trial. We want to provide clinical evidence of functional improvement, safety, and an economic benefit when we compare this ICH evacuation surgery to standardized medical treatment. It's a multi-center, randomized, adaptive clinical trial that compares medical management to early, and by that we say within 24 hours, evacuation of the hematoma using the techniques that I just mentioned. The study uses Bayesian statistics. That means that we're able to adapt the trial goes along. It does block randomization based on the location of the hemorrhage, and we have 2 locations, the anterior basal ganglia and the lobar hemorrhages. And we're able to do enrichment depending on how the trial is going. There was no restriction in the number of subjects enrolled per location, and the sample size could range from 150 to 300 patients. We have done now all of our interim analysis. It was designed to do the first one at 150, and then every 25 patients all the way to 300. We included patients between the ages of 18 and 80. They had to have a CT scan showing a primary hemorrhage. Their Glasgow Coma Scale had to be between 5 and 14, so they have to be symptomatic clearly. It had to be salvageable. The volume could range from 30 to 80 cc's, so large hematomas. The study intervention had to be initiated within 24 hours of last known normal, and we are encouraging everyone to do it within 8 hours of last known normal. And the patients had to have a good historical modified ranking score of 0 to 1, so they had to be functionally independent before the event. The exclusion criteria include all of the things that we normally see in these studies. No primary causes for this, no aneurysms, AVMs, moya-moya disease, sinus thrombosis, none of those etiologies are allowed. Their NIH stroke scale has to be greater than 5, so they have to be symptomatic enough for us to know if we are making a difference. They can't show signs of herniation, so no fixed and dilated pupils, no extension posturing. They can have intraventricular hemorrhage, but not more than 50% of the lateral ventricles. As we know from the CLEAR-3 and other studies on intraventricular hemorrhage, when you cross that threshold, there's a lot of damage done by the intraventricular hemorrhage itself, more related to hydrocephalus, and that is a very big confounding factor. So those are excluded. Primary thalamic hemorrhages are excluded because in our preliminary data, we saw that patients with thalamic hemorrhages were able to achieve good outcomes, but it took them much longer to get to that stage. That we theorize had to do with the fact that thalamic hemorrhages very frequently will dissect into the midbrain, causing the patients to be obtunded for much longer. No midbrain, pontine, or cerebellar hemorrhages, and patients could be on anticoagulants that were reversible, so no irreversible agents. We had some parameters for blood work in terms of platelet counts and INR. And of course, patients had to be consentable and had a reasonable expectation of life. So this is where we are now. We've enrolled 290 patients, and we are fairly close to wrapping up this trial. At the rate of enrollment that we have right now, I think we should be able to complete this study within the next 3 to 4 months. We'll have 6 months of follow-up to do, and then hopefully we will be able to report the results of the study for the early season of meetings in 2023. So when we look, how am I doing with time? Are we doing okay?
Oh, yeah, please.
Okay. So when we look at all of the studies that we discussed, and we add the studies that I think you heard from Dr. Kullner, both using the Apollo device and the scuba technique, we see that clot evacuation rates are getting better and better. Over 90%, as I mentioned, using the technique that I described, 88.2% in the retrospective single center study that Dr. Kellner published. And if you look at clinicaltrials.gov, this is the list of ongoing trials. So Enrich is at the top. We also have the Switch trial, which is being done in Europe using decompressive craniectomy. We have the MIND trial, and that's the device that Dr. Kellner and colleagues use with the endoscopic technique. We also have the INVEST study, which is an observational study. There's the Dutch study using that same technique that is ongoing. And then we have the RISA, we have the MISS or the MISS ICH study. We have this endoscopy plus urokinase study going on, and the SOID-B study as well. So there's a lot of activity in the field, and we should see a lot of these studies coming to fruition this year. I won't talk about this because I think you had Dr. Kellner on. This is a very exciting innovation, and that has stimulated other centers around the country and the world to do more endoscopic evacuation. This is one of those videos, and this is one of the things that are challenging about this technique, and it's because I show you what I can see with the port, and I cannot see with this type of visualization. To me, it's much more difficult to work under these conditions. And this is done by somebody who's mastered this technique. This is one of Dr. Kellner's cases. So eventually you can see a little bit, but the visibility is not great. So it's challenging. It's a difficult procedure to do and requires a significant learning curve. This is another exciting development. This is the Aurora Surgiscope, which was recently acquired by Integra. It has this that looks like a port. Showed you. It has optics built in, and it's something that I'm sure we're going to see some activity on this year. There's an ongoing effort to start a multi-center prospective registry using this system. We'll see what that looks like. I think we have the master of this, Professor Wong, and I'm very excited about what he's doing and his ideas and vision. I think is one of the most well-designed, well-thought-out interventions, and I'm excited to see what the future will bring for the technique that he's described. This is what, in my mind, is where we should arrive to. And it's an approach that is volume and location specific. So there's no one technique or one device that will be universally better. I think we should use all of these innovations and tailor our approach. For example, if we have a patient with a large lobar hemorrhage, greater than 80 cc's, and for logistical reasons, they've arrived to your center over 48 hours after the event, that patient will probably benefit from a decompressive craniectomy and a clot evacuation. So a large operation, as is being evaluated in the SWITCH trial in Europe. Conversely, if you have a patient with an anterior basic ganglia hemorrhage that has between 30 and 50 cc's and they arrive early, within 12 hours to your center, then a minimally invasive option using either the port or the endoscope are probably very well suited for that. If you have perhaps a thalamic hemorrhage between 30 and 50 cc's and within 12 to 24 hours, maybe that's a patient for the MISTI approach, where you just leave a catheter and do some thrombolytics. And I think we will arrive at a systematic response to these hemorrhages that takes into consideration location and volume and allows us to use any of these techniques interchangeably based on these factors and of course based on center experience and training. So hopefully I convince you of my goals, that I think surgery is a viable, logical, and reasonable option to treat this disease. And there's a lot going on, and hopefully this will be the year where many of these trials will be concluded and we'll have more definitive data to share with you. Thank you so much again for the opportunity, Professor Wang. It's always a pleasure to be with you.
Thank you so much, Dr. Kadir. Are there any questions from the audience? Yes, Professor Hong.
Great. Thank you for Professor Pradilla. And the timing for diffusion tensor imaging to evaluate the path for prenatal aspiration hematoma, how do you think the timing is optimal? Thank you.
Yeah, great question. So the pathways to access the hematomas have evolved as we've done more and more. To give you an idea, there have been over 7,000 procedures using this system in the United States. Many of those have been for other conditions, such as deep brain tumors. But through this acquired experience, there have been 3 trajectories that have been defined. One is this anterior trajectory that I shared with you for anterior basic ganglia hemorrhages. And after doing so many imaging studies, we identified that that trajectory tends to be very safe and respectful of those pathways. So for that location, we don't necessarily have to do it at our center. We are able to do that because our protocol was designed that way, so that if a patient comes to the emergency room, they go to the magnet, and the image acquisition for this uses standard diffusion protocols. We can acquire that scan within 15 minutes. It's a 32 direction tractography using B0 and B1000 diffusion imaging, quick and we're fast, and at any time of the day or night. But in our study, these hemorrhages did not require that because that trajectory has been pretty well defined. So if you have a CT angiogram, we use that for navigation. For posterior hemorrhages, for thalamic hemorrhages, is where we use this the most, because the displacement of the fibers of the arcuate fasciculus, of the vertical rami of the superior longitudinal fasciculus, and of the optic radiations can be quite unpredictable. And we've seen that over and over again, where we think we have a safe trajectory, we run tractography, and we realize that we have to change our trajectory, not only the entry point, but the angulation, 5, 10, 15 degrees. And that is sometimes incredibly important in terms of preserving function, because if we neglect to do that, we can cause anywhere from conductive aphasias to significant apraxias. And that, of course, on neuropsychological testing is very apparent. We see that. So for those, we do that, and we try to do it, as I mentioned, very quickly. For other hemorrhages that are on less eloquent regions, frontal, non-dominant, anterior temporal, we can forego tractography. But if you're on dominant hemisphere, or if you're close to highly eloquent areas, the frontal operculum, the corticospinal tract, very, very helpful to know what you're dealing with and choosing a more respectful trajectory. So that's how we incorporate that into our decision making.
Thank you, Professor. The second question is that since you have undergone more than 100 patients of experience in diffusion tensor imaging, do you think is it possible for classify the possible trajectory to prevent from hematoma or evacuation during aspiration hematoma? So is it possible when you are actually, because of diffusion tensor image is sometimes is not easy for every center to plan in, because the use of MRI is very time consuming. So is it possible to classify the safety trajectory for planning of spectacular aspiration? Thank you.
Yes, so for anterior basal ganglia hemorrhages, absolutely. For cortically based hemorrhages, yes, if you think that they're erupting into the surface, for the most part you can. But I would caution the posterior hemorrhages, the thalamic ones. I think for those, there is a standard entry. If you use the parieto-occipital sulcus, that's a good entry point. That tends to be respectful. But the angulation in the superior to inferior trajectory and the mediolateral angulation, it's hard to identify. So that's the one that I would consistently wait to get a scan if possible. If you don't have access at the center, it's just not feasible, then you can do it using certain parameters for access. I did not go into the details of what we do, but we have some suggestions as to how to standardize that technique if you do not have it. So yes, it is possible to do so. It uses that parieto-occipital sulcus and a target point in the atrium of the posterior part of the lateral ventricle.
Okay, thank you for your response. Thank you.
Thank you. Are there any other questions? If no, I have one question for you. Yeah, so you and I are both a believer in early surgery, and we see patients improve upon early surgery. But I think like 10 years ago, when we are trying to run a trial in Taiwan, we had a problem persuading the IRB about the early surgery, because at that time, the guideline in United States mentioned that craniotomy should not be performed within 4 hours after ictus because of the high rebleeding rate, the Morgenstein paper. So so we did not get past the IRB, so we cannot do a very early evacuation, although our previous data showed good outcome. It was not until your enrich was in the trial.com, so we can start our trial. I want to thank you, but I also want to learn from you. How do you persuade the IRB, especially when they are all neurologists?
Yeah, I think that's a great point. For those of you who are not familiar with that study was done over 20 years ago. And it was a very small study. Initially, it was designed to be a randomized study. And the study was terminated early because of rebleeding, which meant that I believe it was 14 patients that were in that study total. And using very conventional a big craniotomy in a microscope, they had some rebleeding events. And that was what we share with our radiology and neurology colleagues who were part of the IRB that evaluated. We said, let's talk about that study. Let's review the power of the sample. And it was such a small sample done with very different techniques such a long time ago that it was easy for us to do that. Now, the second thing that we had in our favor is that during our first multi-center prospective registry, which was called MySpace, that's the one that was published in Neurosurgery, we had several patients that were treated within 24 hours with no as well in our favor. And the third thing that was quite beneficial, although very anecdotal in nature, was that we had some DTI to share with them that showed very early tract recovery that correlated with function. So we saw some corticospinal tract compression and patients with a fixed motor deficit that in MRI 24 hours after evacuation had significant radiographic recovery of the corticospinal tract that followed patients improving their motor deficits. So that was a very compelling piece of preliminary data. So those three things is what I think moved the IRB to agree to do this early.
Yeah, thank you. Yeah, so if there's no other question, we would like to thank you again, Dr. Padilla. We hope to invite you to Taiwan to show us more of your technique in the future. Thank you for giving us this
And
talk.
I want to come by and see the great work that you guys have done. Thank you so much.
Thank you. Bye.
Take care. Bye-bye.
Thank you. Bye.
Thank you, Dr. Huang. Now we would like to invite Professor Zhang Chengnen to deliver his closing remarks.
Wait. Oh, okay. At first, I'd like to congratulate to our President Zheng for the success of this wonderful ICH meeting. So in the past few decades, aggressive removal of ICH has been our attitude for the treatment of this kind of spontaneous intracerebral hemorrhage. But the outcome did not fulfill our expectation. So there might be some factors affecting the outcome. Dr. Padilla has emphasized that removal of ICH is very important to decrease intracranial pressure and also to prevent the expansion of intracerebral hemorrhage. More importantly, is to avoid the inflammation effect or response secondary to the blood clot, because blood clot is a very strong chemical irritant. So removal of ICH, I think, is the role and the main goal of neurosurgeon. But how to obtain our previous expectation to reach a very satisfactory end outcome. I think the key point is not only to remove the intracerebral hematoma, but also avoid to injury the normal brain tissue. So it seems that minimal invasive surgery is the role. And in this meeting, several papers has clearly demonstrated that MIS is the way and is the future to treat intracerebral hemorrhage. And also, I'd like to thank our President Zheng to hold this meeting to provide our members more recent knowledge about the MIS to treat intracerebral hemorrhage. Thank you. Thank you.
Now, let's welcome the Professor Shen Zhongqi to give us his closing remarks.
Dear colleague, and I would like to say congratulations for the successful of this meeting. And I also thank Professor Huang and Professor Gao, the National Taiwan University neurosurgical team, to organize so a very high quality meeting, international ICH meeting in Taiwan. And in this meeting, we have learned a lot of the new technique, minimal invasive way, and that we have many road to go. We have designed a new instrument for treated intracranial hemorrhage, and also the technique of the surgery, not only the goal. The most goal is how to protection our brain. The brain is time is brain. So like infection, we to treat the thrombolytic, mechanical thrombolytic of the cerebral infection. The ICH also, but we have time window to remove the hematoma. So there are a lot of mechanism we to explore. Also, we also must think about the following treatment of the ICS patient. How to get the protection. Is there any medication that we can improve the recovery after the intracranial hemorrhage? Also, the patient may be sent to a rehabilitation program that can achieve more successful of the treatment of the intracranial hemorrhage. So the surgery is just a technique, but the strategy of the treatment is the whole thing. So not only for surgery, but we also have a medical concept how to manage of the intracranial hemorrhage. And I would like to thank all the participants to your patient. And until now, we have a lot of participants here. So the most important things we must to take a group photo. So please come in front, and then we take a group photo.